Welcome to the inaugural Bookout Centre Symposium for Robotics, Imaging and Digital Surgery. So we're streaming live from the DeBakey CV Education Studios here at Houston Methodist Hospital, the Texas Medical Center. I am Dr. Stuart Corr, Director of Innovation Engineering, and here with me in the studio is Dr. Alan Lumsden. And we're waiting for the teleprompter to go up, guys. Okay, here we go. So we're in the studio with Dr. Alan Lumsden, and who amongst other things is Chair of the Department of Cardiovascular Surgery and Director of the DeBakey Heart and Vascular Center here at Houston Methodist Hospital. Now, over the next 8 hours, you'll be learning from key figures in such fields as autonomous robotic assisted surgery, image-guided navigation, digital surgery, and understanding more about the interplay and convergence between them. In the first session, we'll take a deep dive into the academic research driving these fields, with updates from internationally renowned PIs such as Jeff Severson, Nobu Hara, Mike Miga, Ron Alterovitz, Loris Ficera, and Alan Coons. In the second session, we will engage in discussions with Houston Methodist surgeons on the use of robotics across multiple fields such as vascular surgery, OBGYN, ENT, transplantation, and plastic reconstruction. In the afternoon session, we will be taking a sneak peek at some interesting technological developments currently making their way to market, with industrial insight from Citante, Viewful Medical, and Brelion. Now finally, before we cut to our special guest and to Dr. Lumsden, I'd like to invite the audience into our discussions. So if you please submit your questions via web at polev.com using DeBakey as the username, or text DeBakey to 37067 alongside your question. And you can also enter your question into the YouTube chat. And I'd like to hand it over now to Dr. Lumsden to officially kick off the annual symposium.
Well, thank you, Stuart, and a big thank you really to the Bookout family who, without their generous gifts, really none of this would be possible. Part of the concept that we've been working on for several years is this idea that we have tremendous imaging. Imaging, of course, has transformed our ability to deliver care to the patients, and imaging can take you clearly up to a certain level. In parallel with it has been robotics, and robotics also can take you up to a certain level. But the concept, and one of the first speakers this morning, par excellence, is going to show you what that means, is when you can start combining the imaging. I think of it as the patient's universe. Everything about you are really on a CT scan, for example. And if we can take that CAT scan, and we've developed methods of fusing that CAT scan on top of the patient. So now, for example, in my world, if we can extract or segment out the blood vessels and draw a center line, that's what we've used for measuring the diameter of aortic endografts. But it's a lot more than that. If you think of these center lines as really just a series of XYZ coordinates. And this became very obvious to me when we were working with Hanson Robotics, one of the first catheter robots, that we could have that autonomously navigating along a center line, hands-free. But you better make sure the imaging is good, you better make sure the fusion is good, and you better make sure that glide path that you're going to build in there is good. And so we think that here at Methodist is that we have tremendous expertise in clinical robotics. We've had patchy engineering support for this, and so the function of the Bookout Centre is to try and build this engineering support, collaborate with a lot of smart people around this medical centre, and provide our PIs the ability to interact with the surgeons, and the surgeons to interact with the smart people, the engineers and the PhDs who can take this to another level. And I really want to thank the folks at Imperial College. I mean, when I look at the Hamlin Institute and what they've achieved, we've obviously visited over there, and I really think that they've shown us what we can potentially do. And so we're kind of on this march to try and build something like the Hamlin Centre and collaborate with them here at Methodist Hospital. So back to you, Stuart, and thank you.
All right, so delighted to have in the studio today Dr. Jeff Severson over from MD Anderson Cancer Center, and he is here today to represent the Department of Imaging Physics and to discuss AI and robotic assistance for image-guided neuroendoscopic surgery. Dr. Severson, over to you, sir.
Thanks very much, Stuart. Thank you, Alan. Thanks for having me, and it's a pleasure to discuss some advances in intraoperative imaging and guidance. I'll focus in on applications in intracranial neurosurgery, and touch on really 3 cutting-edge technologies that were developed within a project in my group over the last 5 years. As Stuart kindly introduced, I'm a professor of imaging physics, radiation physics, and neurosurgery at MD Anderson. I also direct one of the focus areas in the Institute for Data Science and Oncology at MD Anderson, and that in particular includes surgical data science. Just a quick note of support and disclosures related to this work. The research that I'm going to focus on today was supported largely by a U01 from the NIH and conducted within my group previously at Johns Hopkins University. And so most or almost all of the work I'll show arises from that. And it includes biomedical research partnership with Medtronic. And so I think that's the only disclosure of interest as well there is relationships with Medtronic. So very broadly within neurosurgical image guidance, apart from interventional MRI, we're concerned with technologies related to imaging. That could be preoperative CT, preoperative MRI, the planning and trajectories and so forth associated with that image data, and also intraoperative, for example, cone beam CT. And everybody recognizes the O-arm in this photograph here. And so coupled with that are systems for navigation, either infrared, optical, and electromagnetic trackers, which are conventionally rigidly registered to preoperative imaging and intraoperative imaging as well. And finally, endoscopy. So in intracranial neurosurgery here, we're talking about a transventricular neuroendoscope. That could be freehand or robot-assisted, and is a valuable view into the surgical scene, of course, and can be used to deliver electrodes potentially via the working channel. Robots in this context provide an especially stable platform for tool holding, but could be used to do some other things, which I'll touch on here. So the 3 technologies that I'm going to discuss are those 3, and specifically using cone beam CT systems in a form where we hope to really advance the image quality associated with cone beam CT to a level that is sufficient to drive accurate deformable image registration of preoperative MR into the intraoperative cone beam CT in a way that accounts for brain shift deep within the brain. And finally, intraoperative 3D endoscopy, where we use the 3D information and registration described above to be able to augment planning structures directly within the endoscopic scene. So for example, this purple structure here was transformed directly from the preoperative MRI and is augmented into the video view and represents a structure that's actually beyond the visible scene. All right, so to get started, we all know cone beam CT. It's a technology prevalent for a couple of decades now in the operating room. And in cranial context, it's sufficient really for rigid registration, and that is to say bone. But beyond that, it conventionally faces a number of challenges. It's insufficient for deformable registration of intracranial structures, and it's insufficient to detect complications like a hemorrhage. The challenges to the soft tissue visibility there are numerous and are the study of imaging physics research ongoing. And the solutions are similarly numerous, include hardware, improved X-ray detectors, for example, and algorithms to correct the artifacts, invoke physics models for so-called model-based image reconstruction, and more recently, deep learning models, where we learn to restore image quality through many learned examples. And that's what I'm going to focus on here as a solution to image quality in this context. So let's look first at that physics-based, model-based image reconstruction that I mentioned. So we've got raw data here from the O-arm, numerous projections from the O-arm. We use physics models to impart artifact corrections. For example, X-ray scatter is a big one, but there are many. 3D image reconstruction methods go back to the dawn of CT, just 3D variations of what's called filtered back projection, or more sophisticated iterative reconstruction methods based on a physical model. And so work by one of my PhD students here, Pengwei Wu, really did a nice job of saying, well, we can push these physics-based models pretty far. Now you're starting to see a pretty major increase in the image quality here with just within one axial slice of a cone beam CT data sets, where we're seeing the ventricles pretty nicely. But there's residual shading and artifacts, and with metal in this scene, that becomes more challenging as well. Compared to a helical diagnostic CT, right, there are still real challenges to overcome. So with this about as good as we can do from a physics standpoint in cone beam CT, and these images down here show a clinical study that we did across 30 subjects under an IRB protocol. We can say, well, can we take this one step further and really, be able to get this to a level that's more consistent with a diagnostic quality CT, again, with our goal being to drive a deformable registration to preoperative MR. So that's where physics starts to transition to deep learning. And so one method for deep learning-based image reconstruction or image restoration uses a generative adversarial network, or GAN. So I'll show you a little bit about under the hood about how a GAN works. You see this a lot in various forms of generative AI. And in CT, it works something like this. We take physics-based reconstructions of an image as input, but we pair them with a diagnostic helical CT of the same subject. And you train a generator and a discriminator to be able to tell the difference between real or a synthetic image. And so there's a discriminator loss and a generator loss, and you iterate over this until, you look closely here, the synthetic image becomes more and more similar to the diagnostic CT. So you take away the discriminator, and now you're left with this system here, this GAN, that is trained to take input cone beam CT data, but produce a so-called synthetic image that looks very similar to the patterns that are learned by images in helical diagnostic CT. So there are numerous advantages to that. It's fast. You can adapt this to other scenarios. I'm just showing the brain here. The artifact correction, noise reduction, and even some resolution enhancements are very promising. The limitations, it's data intensive. A paired data set like that is nice, but can be a bit hard to come by. And there are other ways of training up on that. But a real limitation here is, to what extent can the synthetic image be trusted? Is it reliable, right? Has it seen abnormalities within the training set that it can reliably reproduce? For example, a tumor or some pathology. Right? It's difficult to have a good, robust training on all sorts of abnormalities that we would expect to see in surgery. Well, in order to know, well, can we really trust it? One good question is, can we estimate the uncertainty in this image? And if we can estimate the uncertainty in this image, let's say every voxel by voxel, the certainty with which this synthetic image represents reality, can we use the uncertainty to make a more reliable image? And that's what I've illustrated here. So here's just that generator again, cone beam CT data in. A generator produces a synthetic image like you're seeing here in the sagittal. Well, one way to produce an uncertainty map, to estimate the uncertainty in that synthetic image, is to introduce a so-called dropout layer, a Monte Carlo dropout, where basically now I can run this 5 different times, 10 different times, etc. Take the standard deviation over the synthetic image estimates, and that standard deviation is a proxy for uncertainty. There are some other ways to do that. This is work done by another PhD student in my group, Xiaoshuan Esme Zhang. And she showed that with this uncertainty map, you can do a mixing. So a little bit of math here, it's a mixing of 2 images, the physics-based cone beam CT image, the synthetic image, and you can see they're just weighted by this uncertainty map, this sigma, which I've just sort of rewritten as beta here. So you just mix the 2 images together in proportion to the uncertainty. So where the uncertainty is high, there's something in this image that we just never saw in training before, well, we'll go to the physics, right? We'll go to the raw data. It's something we know we can trust, so we'll bring that in. But in regions where the image is reliable, right, the uncertainty is very low, we'll use information from the synthetic image. So we refer to that as DL recon. And just some results of a clinical study shown here. On the far left is that very first image we said sufficient for bone imaging. Second column, probably about as good as we're going to get from physics-based, model-based image reconstruction, a synthetic image, an uncertainty map, and the deep learning recon. And we just zoom in here. There again, here, for example, you see pretty good visualization of, for example, this intraventricular hemorrhage. And you can see it's not quite accurately reproduced here in the synthetic image, right? This network wasn't really trained up to recognize abnormalities like a hemorrhage. But the deep learning recon starts to mix those two in a more reliable way. That method was actually best paper in the Medical Physics Journal last year. So that's one promising way of improving 3D intraoperative image quality. It's one that I would expect surgeons, if you're using the O-arm or some other kind of 3D intraoperative cone beam CT systems or interventional radiology, you can expect to see these kinds of advances in years ahead where no longer are these systems really only just good for bone imaging and rigid registration. So with that image, let's see if we can take things a bit further and transform the preoperative MR data and all of the planning that we've done there into that intraoperative context, courtesy of a high-quality intraoperative image. Well, registering an MR to a cone beam CT image, as you can imagine from these two images that we're trying to deformably align, it's very challenging. But actually, we just talked about something that gives you a clue as to how we might do a better job of this. And it's that same kind of generator discriminator method where we could produce a synthetic image that is intermediate. For example, here, an intermediate image like CT, like we were just doing. So we can take the cone beam CT, create an intermediate synthetic CT, create the preoperative MR, create an intermediate synthetic CT, and now register these two. All right, so now the image intensities are a little bit more correspondent. So it's a little bit more reasonable question to ask to align these deformable structures within the cranium, but it's still tough. But about 5 years ago, a method referred to as voxel morph and referenced down here demonstrated a pretty good capability to use synthetic images, intermediate synthetic images, and deformably align them. So now this neural network is really intended to estimate this transformation, this deformation of structures internal to the cranium to align the image information. We did a variation of voxel morph called joint synthesis and registration, or JSR, where we simultaneously solve for this intermediate image. It turns out to be something like CT, but it doesn't have to be. It's actually an intermediate image that's optimal to the task of aligning these internal structures. So it doesn't just have to be a CT image. Actually, it can be a little bit edgier, and so forth that assists the registration. And it simultaneously solves the transformation map, and it forces certain aspects of consistency between the synthetic image and the preoperative MR. So this is work by another PhD student in the group, Runzi Han. Did a nice job, and here this shows some example data where here's a cone beam CT images, and the green lines just represent gradient edges within that. Here, a preoperative MR simulated to show a very large deformation of the ventricular space, maybe sort of like hydrocephalus. And so now you see we've got many millimeters of deformable registration error between these two images. But on the right is the JSR image. Again, so following that transformation, we see close alignment of the gradient edges. And so now we've got, we've reduced that deformable registration error quite a bit. On the right just shows some quantification. So a rigid registration leaves you with many millimeters of error. A very good physics-based deformable registration, symmetric normalization with mutual information can do a reasonable job, but it's computationally expensive. Voxel morph by itself is fast, but then this joint synthesis and registration is similarly fast, reduces the registration error at about 2.5 millimeters, and improves the dice coefficient in the overlay of structures. All right, so I hit the gas a little bit, but we're almost to what we intended to achieve, which is to put those structures from preoperative MR right into the endoscopic scene. So here we've got high quality cone beam, deformable registration, and now we're going to bring those planning structures right through the transformation into a calibrated endoscopic video. All right, so no need to tell this group, but freehand neuroendoscopy is common in, for example, endoscopic third ventriculostomy, cyst drainage, transventricular placement. It could be done either freehand or increasingly with robotic assistance, which I think is a even just using the robot as a scope holder is, I think, a nice advance in quality. That robot could be tracked, or it could just be freehand, as I'll show you in a moment, tracked directly from the endoscope. So here are some data with our colleague at Hopkins, that's Mark Luciano. And so you see the kind of freehand neuroendoscopic scene, beautiful visualization here in the lateral ventricle, looking down the foramen of Monroe, and you see the choroid plexus there along the bottom of the scene. So what we did is a clinical study in which we came into the operating room, set up a geometric calibration jig just to rectify the distortions of the lens and so forth, recorded freehand endoscopy, and we can bring those out into an algorithm, a computer vision algorithm for reconstructing a 3D view of that endoscopic scene from the natural motion of either the surgeon's hand or motion of the robot. So the methods for doing that 3D reconstruction are numerous in the computer vision literature. For example, SLAM is simultaneous localization and mapping. There's others, SIFT, SURF, NERF, that's neural receptive field, and so forth. And so by way of that 3D reconstruction, now we can track the position of the endoscope and therefore overlay positions from the MRI. And so here are results of a clinical study. Again, another 30 patients undergoing ETV or other neuroendoscopic procedures. They all have preoperative MR. We did automatic segmentation in those images using FastSurfer. It's a freely available deep learning-based segmentation tool. So now here we've got plenty of structures here. We did 3D video reconstruction using, actually here we're showing that reconstruction via neural receptive field. So this is the video, but what you're seeing here in the lower left, that's actually the 3D video reconstruction via this algorithm called NERF. It looks like the video scene, but it's actually just a point cloud 3D video reconstruction. So this is a 3D image you're seeing here. And now we map those structures through from the MRI through the deformable transformation, remember, that we computed based on the cone beam CT. And in that video now we can overlay these structures back into the actual video scene. So you see a few structures highlighted there. So just like augmented reality, I refer to this as augmented endoscopy, right? And what you're seeing there are structures beyond the visible surface. So you can imagine other applications of this as well. For example, in the skull base. So a transsphenoidal approach to the brain where you want to see behind the surface of the posterior sphenoid, the carotids, the pituitary, and so forth. Here it is in the ventricles. But really any endoscopic scene, this is the kind of capability that I would expect to see in years ahead. And I think it's a great application of augmented reality. And say this is also work by a PhD student in the lab, of course, Prasad Vagdargi, who's doing a great job with this work. All right, so conclusions and outlook. I tried to touch on 3 technologies that are emerging here within the brain context. Intraoperative image quality beyond the conventional limits of just being good for bone visualization, and the technology that's enabling that is physics plus deep learning methods. And that mixture is important to having not only a high quality result, but one that is reliable. Deformable image registration, here again, deep learning based deformable registration methods, really moving the bar on the ability to compute accurate deformable registrations, but very quickly. And finally, this business of augmented endoscopy, where either with freehand or robotic endoscopes, like you might hear more about the robotic side of things from upcoming speaker, Dr. Nobuhito Hata. That would be great. But this ability to visualize beyond the visible scene in endoscopy, I think, is very exciting. All right, so just to acknowledge the folks who put effort into this. The team at University of Texas MD Anderson Cancer Center includes David Jaffray, who heads the Institute for Data Science and Oncology. The Surgeoneering team, these are folks on my group now working on things like this. And at Johns Hopkins, where a lot of this work was performed under NIH support at the iStar Lab and Carnegie Center. The junior faculty who worked on that project, Craig Jones, Jung-Hoon Lee, Ali Uneri, Wojtek Zubiewski, and these all-star PhD students as well. Thanks very much.
Thank you. Before we get rid of that last slide, can you say a little bit what we're looking at, that funny looking helical structure that we're looking at there?
Thanks for asking, Alan. Well, at MD, or at the Texas Medical Center here in Houston, you're looking north across what is called the mid-campus. And so Holcomb Boulevard includes Methodist, MD Anderson, and the numerous other hospitals here that conglomerate at the Texas Medical Center. But this helix shape is a new development here across our mid-campus, and it is a translational research park for the Texas Medical Center. So the building right there, for example, is called TMC3, and that's where the Institute for Data Science and Oncology is set up, right there within arm's reach of this juggernaut of clinical services at Anderson, Methodist, and other partners.
That's actually where Pumps and Pipes is going to be this year on December the 9th, and tickets do go on sale this morning right now. We have had some really interesting questions coming from our audience, so I'm going to attempt to get through these. There's two I believe could get combined. So the first one is skull rigid, fusion easy, are you working in soft tissue deformity? That could be combined, I guess, with if skull is opened, how do you adjust for any change in brain structure?
Those are great questions, and it was really the purpose of that second technology that I was talking about, where if you can form a high quality 3D image with cone beam CT, and now you can start to see those soft tissue structures even after the skull is opened. There's pressure changes, there's volume changes, etc. But you've got a high quality intraoperative image of that. Then you can take the preoperative MR, ignore the skull, you can strip that or what have you, and now deform those intracranial contents onto that high quality intraoperative cone beam CT. Right, so not just the surface level brain shift, but the deep brain structures, which is what I was focusing on here. So yeah, so even though the brain is rigid and that fusion is straightforward, what I'm really talking about here is that next step of deformably registering the soft tissues. In other areas like radiation therapy, this is done every day, in aligning soft tissue structures of a planning CT to a treatment CT. But seeing it in surgery, I think, is coming fast.
Does MR elastography play a role in this at all? Or could it play a role?
Great question. I think it might play a valuable role in understanding the kinematics and biomechanical properties of tissues, where elastography can give you some really viable, useful information there. And as another speaker this morning will talk about, Mike Miga at Vanderbilt, those kind of biomechanical models can bootstrap those kinds of deformation models even more.
Can I ask one final question, and that is, the way medicine was kind of built, there was imaging departments that were called radiology departments, and then there were doing departments, I call them surgery departments. And the evolution that you're seeing, this is kind of where you're on the front edge of this, is starting to put the imaging in the operating room. Now, I think of the no ring as being pretty crud. Hope I don't destroy the support, but we're now in a situation. I know they've got these at Anderson. We got MRIs in interventional rooms. We got CT scans coming, which is going to do nothing but make the fusion and the repeat imaging a little easier.
Yep.
What do you think is going to happen?
Well, I think there's a spectrum, Alan. It's a great question. Imaging is always about the task, right? And so imaging should be as good as necessary to accomplish the task. And so that spectrum could include the high-end, premium kind of installation with intraoperative MRI, intraoperative CT, et cetera, hybrid arrangements, and so forth. The Amigo operating room in Boston, right? So that high end of cutting-edge, very high-quality intraoperative imaging. But there's a spectrum, right? Let's say mobile systems. Mobile MR has some really interesting new technologies coming as well. Mobile CT, mobile cone beam CT. And again, it's all about the task, right? And so you might even think that there are even lower end systems coming that are not suitable for diagnostic purposes, but suitable to a surgical task. They're enough for me to register high quality information preoperatively into that. And if it's just that if it's just that geometry problem that's being solved, some of these medium end systems are up to the task.
One final comment. I think you're right on, because we've kind of gone through this evolution in my specialty in vascular surgery where, first of all, we fought for a portable C-arm. Then we got portable C-arm. That got us in the game. Then we argue for hybrid rooms. But the portable C-arm technology and the imaging quality has caught up dramatically.
There it is.
And so the cost of building a hybrid room, probably $8-9 million. The cost of building a surgical room with a portable C-arm in it, a fraction of the cost, and it can be used for other procedures. So I think what you're doing with portable imaging structures is very important.
Thanks very much.
Thank you.
Okay, well, thank you very much for coming in the studio.
Yeah.
Next on the list, we have Professor Hatta from, it's the Department of Radiology, Brigham and Women's Hospital and Harvard Medical School. And he's patching live to discuss expanding autonomy in surgical robotics, opportunities in percutaneous and endoluminal procedures. Professor Hara.
Yes, can you hear me or can you see me?
We can hear you and see you, live and clear.
Okay, excellent,
Welcome.
because I cannot tell from here, but I'm so happy to see you, and then thank you so much for the invitation. Can I start my presentation?
By all means, please.
Okay, good. Well, good morning, everybody. I here can't see the audience from here in my little closet office in my home, but I hope I can give you some insight into what is happening about the autonomy in surgical robotics. I see that the many prominent speakers will talk more about the science and technology around it. So I'd like to spend some time laying a foundation of what exactly is the surgical autonomy and what exactly is happening, and then also a bit of an introduction of what I'm doing in my research. I'm being very, very fortunate to be funded by NIH to pursue my research, and then also the industry support is tremendous, and then collaborators and the contributions from my students and fellow colleagues are now presented on the slide, and those names are on slide. I didn't have enough space to put their name in my acknowledgement slide. Apology for lack of acknowledgement, if you see. So our researchers are witnessing many interesting development about autonomy nowadays. Many of us found that the work by CMU, Carnegie Mellon NavLab team, to do autonomous driving. One of them actually ended up doing self-driving across the continent back when I was in, I don't know, college-ish or graduate school. So I was very fascinated by those videos and news. Now, in fast forward in 2018, we have a robotaxi with no drivers in it. I haven't tried it. I don't have that in Boston yet, but I've seen many fascinated news folks being on this taxi, and sometimes amazed by how beautifully they fail. But another thing is that there's the folks at the Houston may much know about it is this the SpaceX and SpaceX functions, where the launching pad actually the base launcher actually comes back to Earth and land itself without the involvement of the operator. So the autonomy is everywhere around us, and we engineers are fascinated by it. And then many car companies are nowadays also providing this. So much more accessible to the folks who doesn't know much about the science. The companies named the technology to help the driver to avert an accident by different names: driver's assistance, travel assist, and pilot assist. So many assists everywhere. Interestingly, not many companies use autonomous except the Tesla, who bravely name it as an autopilot. And so those technologies are available around us. Let me tell a little about the personal history about my involvement in medical robotics. When I was a grad student in 1994, I was tasked by my mentor, supervisor, Dr. Dohi, to present our work on, this is considered the first work on inboard MRI manipulator, which is basically a simple motorized manipulator or stereotactic frame put in the MRI scanner. I was much younger, thinner, grad student, and gave a talk. And then immediately after the talk, many angry people come to me or ask the question, "This is ridiculous. Robots will never be part of our practice." And I was scared. I was just a grad student asked to present the work. I happen to speak English a little better. But I was very scared. And then kind of, looking back, I find it a little bit more understandable now, because remember, Intuitive Surgical was only founded in 1995 or 4-ish. Back then, SRI, Stanford was making a prototype, and no clinical practice was conducted using this telesurgical equipment. So nobody knew about the robotics. Fast forward. 2016, folks from Children's National, including the Dr. Kim and Dr. Klieger team, published a paper in Science, Translational Medicine, presenting that the robot can perform the suturing or anastomosis with the help, of course, with a physician, but automatically. So this is a surgical assistant, robotic assistant, performing a suturing with a physician. So that actually steered the field a lot. Many people get excited about it. A year later, I got the interesting email from the folks from Science Robotics. This meeting was they held at the place called Halicum House. I didn't know what it was, but basically some generous donor basically housed us to talk about the future of medical robotics. I think Guangzhou Yang spearheaded it, but these are the people who were invited to the meeting. I'd like to kind of point to one gentleman, Mr. Daimler, I think Dr. Daimler, who came from White House to teach us how to navigate the adoption of autonomy to the field. So this paper later came out talking about the risks and then the degree of autonomy in medical robotics was actually meant to follow the path Dr. Daimler and the industry took to talk about level of the autonomy in car industry. Part of the reason, there must be many reasons, but one of the reasons I was fascinated to hear from Dr. Daimler was that we need to lay out a level of the autonomy and then advance progressively from lower one to the higher one, so that the people, the users, industry embrace the autonomy little by little. If you present the autonomy from the scratch with fully autonomous, no driver, no surgeon at all, people will be scared to accept and embrace the technology. I thought that was an interesting thought from him, and we diligently followed his advice and came up with a sort of level of autonomy, which was now presented in Science Robotics, and it's been collecting quite a number of citations as a sort of a foundation and thoughts for medical robotics and autonomy. This figure is not great. So I actually pulled another paper who just published, and which I'm going to introduce later, in 2024, basically outlining what are the thoughts and what is a way to distinguish the level of autonomy. It actually comes with many questions. One of the questions is that does surgeon continuously control all motion of the system? If it's yes, it becomes level 0 or 1. I'm not going to talk much about it, but like intuitive surgical Da Vinci's or many robotic system is now fall onto these either 0, not 0, the 1 category. Most of us is now engaged in doing a research on level 2 and level 3. And those are basically saying, what kind of a surgical task did robot generate and suggest to the physician? Basically, robots generate the plan and then ask the physician for permission. Does it ask? Yes. It doesn't. Oh, sorry. Does it ask? Yes. Does it do yourself? No. So those are the sort of a thought process behind it. It's not necessarily that the execution part that actually matters. It is how much cognitive involvement do you have with physician is nearly the way to distinguish it. Now, this paper came out, and I'm very, very happy to introduce contemporary paper about robotics and autonomy, which, by the way, has been discussed many years. This paper introduces the FDA-cleared surgical robotics, and I was very, very surprised that most of the autonomous robot was indeed developed much earlier than today. So these are the sort of an introduction of the number of the FDA-cleared quote-unquote autonomous robot. Most of them are level 1, of course, because that's what you see today. But increasingly, actually not increasingly, there has been level 2, level 3 in the last 10 years. So most of the level 2, level 3 were introduced earlier and continue to be in just the level 2, level 3 as of today. And then most of them are 510K. So I'm going to skip this slide for the interest of time, but I'm trying to tell that a high level autonomy is often seen either urology and then orthopedic surgery. And then I also like to introduce what exactly they mean by autonomy. Again, this is a level 3 autonomous robot sold, actually FDA cleared today since 2011 or 2015. But this actually precedes this device called the Think Surgical's device precedes the Think Surgical's ownership of this device. Actually was originally developed as a Robodoc. The Robodoc's function is that the physician and then the computer plans the osteotomy for the knee replacement, and then robotic device perform the cutting procedure with physician holding the stop button. That's what it says in the paper. The surgeon maintains control over milling cutter via manual override safety button. So this is pretty much what's accepted in the view of the FDA, mostly because they are approved in 2015 for the ownership of Think Surgical. Those are the list of the autonomy of all the FDA cleared devices. It's either ranging from 222, 333. Not all of them use the AI. So that's something I like to pay attention to, that you pay attention to. So what's going on in the field of research? So this is another paper, very contemporary, recently paper published in 2021, showing what exactly is going on in terms of research on autonomy. And I have to say that it's a bit disappointing that we have not that much advanced in the field of medical autonomy. If you look at the dots on the right side, red indicates those are lab-based research. Green indicates that they has reached to some form of a clinical deployment. And that's only available in some of the ablation needed procedures, and then only the organ tumor segmentation for like a pre-planning. Most of them we are working on more like enabling technologies or key technology to make application happen. For instance, we are working, a lot of the folks are working on gesture classification. They're trying to understand what the physician is doing in laparoscopic, robotic laparoscopy in preparation to deploy that to needle insert, knot tying or suturing or tissue retraction. There has been some effort doing this, but not much has been done. Another thing people are putting a lot of effort on research is true trackings or eye trackings. Again, in preparation for them to use this technology to work with physician to perform this, but none of them actually has been integrated into this as a final the clinical deployable form. I am going to introduce these two needle insertion and tissue ablation later, but that somehow is pretty much people have advanced to. The two highly cited papers in the fields are coming from days back to 2003 or to 2020. I'm very much big fan of this work by Dr. Baldastri from now at the North. And then he's been working on what's called magnetic manipulation of endoscope. You can see here, he has a magnetic driver kind of driving the endoscope so that the physician can get the help from the driver to maneuver endoscope very nicely. And this is the old paper helping the physician to move, back then there was E-stroke robot, which is gone, to move the laparoscopic holder to the place they want to pay attention to by using the tool trackers or sort of a beacon, and then ask the endoscope to go to the place that they want them to go so that they can collaboratively work with physicians. Most of these are follow-me approach, not necessarily suture tying or else, just like you've seen the video from Children's National. Many papers are about opinion papers, many papers about review papers. So there's a lot of hype about the autonomy, but not necessarily advance into this, the research. I've been very fortunate to work with my colleague from WPI, particularly Dr. Greg Fisher and Kai Chan, working on MRI-guided robotics. Actually, it goes back to the day when Greg was a grad student of Gabor Fichtinger, and then we are kind of working on making 60 OF robotic devices. And it's been a dream for us and to bring this to the OR, in this case, Amigo in Brigham, and try and then have an insight into how exactly robotic device helps physicians to perform procedures. And those are summarized in some of the paper we did. I am introducing this robot in the context of autonomy today, not necessarily medical robotics applications, but we've been very fortunate to work with a very understanding collaborator to bring to the clinic. So we got a lot of data for us to analyze using AI to understand how we can use it as in a future research. That's one of the assets we can provide from P41 Center. Greg Fisher's team has done a great work to do what's called NIDU steering. NIDU steering is emerging and also well discussed area where the physician can perform the NIDU steering to steer to the directions they want. That's mostly the context the researchers talk about, but also in our case, insert the NIDU straight according to a plan, because most of the brachytherapies and ablation therapies have certain plan to place, and not necessarily that the plan that necessarily includes kind of a maneuvering the NIDU around the tissue. It's rather, I just want to go straight to get there. And then the art, but often NIDU bending or NIDU steering, a NIDU bending actually prohibits them from getting to the place they want to be. Their team has developed what's called the curve approaches. I like to kind of introduce this graph a little bit carefully. If you rotate the NIDU, all right, in this space, 360 degrees, in a certain pattern, sometimes it's constant, sometimes a little bit of a more sinusoidal, or you can actually push and stop and push and pull. You can actually steer a NIDU to one direction if the NIDU is a bevel tip. So this is basically telling them the basis there, kind of a phantom study to show, again, using the platform I presented, to steer a NIDU according to this plan. So the field has advanced to do this well in the last 10 years. We are doing this in MRI. We have a way to do it, and using the device we developed, and we placed it in MRI. We use the NIDU. We have to first know where the needles are. We also have to come up with a strategy to steer a NIDU, and eventually we will see where the needles are, and then make a closed loop NIDU insertion, again, to steer the NIDU in either straight, because they tend to bend, or bend on purpose to reach the target. So those are sort of an interesting NIDU steering or autonomous NIDU control to help the physician. Second topic I'm going to introduce quickly is the device we've been working with Canon to do transbronchial biopsy. This is what we call snake robot. It's a multi-section continuous robot developed with industry. So all these sheaths and then tools are developed in the industrial quality, which my student cannot ever do, and then that actually has 3 sections. The beauty of this robot is that they actually have an ability to do what's called follow the leader motion. Can you see, folks, that it's trying to do the motion, very tricky motion or exploration like this? It's got the OD outer diameter of 4 and in diameter of 2.1. What am I doing this as a research platform for autonomy? Well, when we develop these devices, we come up with a strategy to let the users, this is Franklin King from my research team, to use a gamepad. Literature and our own experience tells me that you need a certain time to get used to maneuver this. I think that one of the articles about the industry robot indicates that they have to aim at least 50 lesions before they reach to the proficiency. They have to train on patient to try 50 biopsies using this sort of robot to fully competent. And that actually comes back later. What about turning this into voice controlled autonomous advancement using mouse pointer? This is Frankie is not now using the gamepad. He's directing he's actually controlling the robot, but he's actually directing the robot to aim the airway they recognize. Basically, he's clicking on the airway he wants that robot to advance, and then letting the robot advance autonomously. So that's the sort of one autonomous function you can do. The the technology behind it is called the depth map. And then Dr. Swerson introduced some of the GAN technology he used to produce synthetic view. In my view, we produce a synthetic depth map, or I don't know at this point I should call this synthetic. It is a depth map from the native bronchoscopic view. So you can bring in any bronchoscope and I can make a depth map for you. Why does it matter? We also use a GAN. Why does it matter? Because for the endoscope that advance to the airway, you have to accomplish two tasks. You can decognize the airway from the depth map. In this case, the device recognizes two depth map. And the next step is for the physicians to aim which airway they want to go. So this is sort of a borderline between level 3, level 4. Part of the task is performed by the physician. Part of the task is performed by the robot autonomy. The reason the last slide before we go on to the conclusion slide I want to introduce is, so why are we working on autonomy? Why does it matter? And at this point, a lot of excitement stems from our engineers' excitement. We haven't really nailed down with physicians what exactly can be accomplished. There's a paper published in 2022 from Ken Goldberg and Ross Taylor's group, but they couldn't really clarify it other than the fact that it's a learning curve, maybe shorter using the devices. And I agree with that. Like the slide I show, there's a sort of a difficulty of balancing hands-on training at the same time ensuring patient safety. And if the physician don't have an access to advanced training resources, there's going to come with some cost of high cost and then higher risk. These are the paper I put from the recent work showing that if you ask the physician to do a bronchoscopic navigation, just as I showed you, the physician takes about 11 cases. So this is a little bit of sort of the time required for them to do a procedure, 0 being optimal. They actually quickly learn to do it quicker, but at some point at the 11th case, interestingly, they start to take more time to perform a procedure, and it goes down back again. But throughout this journey, phase 1, phase 2, phase 3, physician actually improves the performance over time. And the very interesting observation, I found that is also true with even percutaneous thermal ablation. I'm pretty sure the audience, the physician listening to this audience can concur this sort of experience, showing that, we can quickly make it faster, but over time we get better. During the time of refinement, we take more time. So this is sort of an interesting aspect. I'm going to skip my slide to sort of come to my point. This talk actually introduced some rise of the autonomous robots in your life, and Falcon 9, and then some of the nice cars. And then, but those are less controlled environment. We're talking about the medicine. We talk about the risk to the patient. So we are kind of introducing the same concept carefully, gradually to a field. The progress has been made and research has been done, but a lot of discussion is still about regulations and safety, and then development of supporting technologies. It's about time for us to come together to see what exactly can be done with this for the benefit of the patient and medicine. We found that the learning curve may be something we can work on, but there must be something really to mitigate the risk or performing the procedure better, lower the burden, cognitive burden of the physician so that they can pay attention elsewhere. Those are the items we need to start to talk as we continue to work on this exciting area of autonomy. This is the last funny slide. I just showed the name of the assistive technologies in cars. If they're able to come to us, it can be surgical, named as a surgical assistant, adaptive surgical control, surgeon assist, and pro surgeon. I like pro surgeon. So I like to kind of conclude my talk with this kind of an interesting slide. Thank you so much for listening to my talk.
Dr. Hara, Alan Lumsden, we haven't met, but I just posted something on X, and it said, amazing, provocative, and stimulating presentation from Dr. Hara. That was really fantastic, actually. Got me all excited. So let me tell you a story. And this is interesting. It was an engineer who was driving a Tesla. It was an autonomous driving mode. Something went wrong, and he ended up in a canyon in California. But his response to that in his interview was really interesting, because he said, "Are you mad?" And he said, "No." And he said, you think this is a failure?" He said, "No." He said, "There will be failures, but I believe this technology will end up saving many more people than it hurts. But there will be failures along the way." One of the challenges in medicine is we're so risk adverse to failure. You bring on a new technology, it's going to get trashed if something goes wrong with it. So that kind of leads to some of these questions that are up there. Is you kind of address the one from the FDA. What about hospitals? I mean, when you go to an institution like ours and say, "Hey, we want to bring in this robot in self-driving mode," do you have any experience in how to handle this, or what kind of the resistance you can expect?
Yeah, so the episode I told you about, the story when I presented the robotics in 1994, was exactly what I'm facing today. I often come 50% of physicians say, "No way, no way autonomous happens." And then the other 50% is fascinated by this new technologies. They see day-to-day life, and then they're sort of try to embrace it. So we are at the junction where Intuitive was founded, about the similar junction where Intuitive was founded 20 years ago. And then I think that's up to us to embrace it. And then Dr. Daimler, I mean, it's funny that his name also overlaps with some of the car company. The Daimler is a kind of a notion that we will introduce this little by little by acknowledging the risk and also the benefit. I think that's where we are getting into. I hope I'm sorry. I understand this very abstract way. I hope I answered your question.
No, that's great answer. So I'm interested in who do you deal with at the FDA? I mean, do they have a central group who you interact with, who are going to try and evaluate all of these robots and this idea of them being self-driving?
I can't talk for FDA. There's always a risk mitigation involved in FDA regulatory clearance process based on my experience of interactions with FDA. You can't talk about their position about the autonomy. One thing interesting is that they're also taking a very cautious step about AI. One of the table I showed you showed that the AI was whether used or not. FDA, interestingly, have asked the vendor people, the manufacturer, to put the device in their database if the AI is used within their devices. I think that's one of the sort of a process they're taking to share the information with the people, and then gradually takes. I'm not an expert about the regulatory affairs of AI, but they're taking a very cautious step for AI. I believe the similar step may be taken in for the autonomy. Again, the level 3 autonomy only available here was only introduced 2011. I don't know when we knew enough about the autonomy back then.
Well, thank you. Just to reiterate, amazing, provocative, stimulating. I hope we have a chance to meet in person one day, but thank you for what you're doing. I'm going to hand it back to Stuart.
Thank you, Professor Hara. So next on the agenda, we have Professor Mike Miga. He is the Harvey Branscombe Professor and the Director of the Vanderbilt Institute for Surgery and Engineering up at Vanderbilt University. And we're delighted to have him patching in today to discuss advances in model-guided surgery and intervention. Mike, pleased to have you on your show.
Oh, great. Thanks. Pleasure to be here. Let me see if I can get my slides shared up there. Can you see them?
Yes.
All right. Very good. Yeah, it's a pleasure to be here. Thanks. I appreciate the invitation, and I think I'm probably going to give you a little bit of a different perspective on kind of the robotics field. I'm much more of a modeling person than I am robotics, so hopefully it'll be entertaining for you to some degree. So again, yeah, my name is Mike Miga. I'm from Vanderbilt University. I'm the director of the Vanderbilt Institute for Surgery and Engineering. Some of my disclosures are shown here. I'm supported by the NIH, and I hope to get to my project, co-PI project with for the Wellcome Trust as well. So it's great. Pleasure to be here. All right, let me see if I can get this going here. So hopefully, as far as as far as provocative questions go, is what is the audience going to get out of this to some degree? Hopefully we'll get some novel research directions potentially, hopefully some new methodologies. Perhaps I may inspire something from the domain, and if nothing else, I'll be a little bit entertaining and a little bit of a different perspective on these things. As far as what I know and what I can kind of contribute, I consider myself kind of a clinical device system scientist to some degree. And so our group was one of the first groups to ever produce the first FDA cleared image-guided liver surgery system that you see right here. It's just a kind of a little bit of an offshoot from kind of standard tracking systems, but you see it kind of in use over here. It involved kind of a surgical planner that allowed you to kind of plan these nice aspects of intervention in the liver. We could do residual liver volumes and whatnot and plan actual surgical plans, and then we could bring that information into the operating room and allow it to guide the surgeon. So it's a pretty useful device. As far as outcomes, see that was translated. It was actually probably used on about 1,000 patients or so. It was bought by Analogic, and it would, at the time, BK Ultrasound was part of Analogic, and they were looking at kind of developing an ultrasound-based kind of approach with the system, kind of a modified one. That moved on. Unfortunately, there was restructuring going on. It didn't actually get there, but this is the casination system, which actually came in under our FDA clearance, and so they actually brought their system to the U.S. market. It's still being used, but it's been retasked also into the interventional radiology domain. It's being used in a lot of ablation type work now. It's interesting. I think we were a little bit before our time in terms of image-guided liver surgery. It took a little time for the kind of the robotics aspects and things like that to catch up and some of the instrumentation, but I think it's starting to come around again. I think if we had formed our company now, we'd probably be in better shape at this point. So as far as, what are the counterfactuals to investing in time and listening to me? I work in a pretty difficult environment. You've probably seen that already in some of the talks. But the procedural environment, actually taking data, actually working in that environment, it's one thing to build something on a bench. It's a whole other thing to put it in the operating room. And so you can see a lot of the work that we've done in the past, putting in, tracked objects into open resections for liver resection, trying to take novel devices and get it into the OR in some kind of sterile manner, kind of down here. And then you can see kind of some of our guidance work that we've done in the past for doing experiments. This is actually our guidance system. We took our software and put it on the Cassination's hull and kind of used that within the operating room to kind of do some testing. We're still doing some testing on that. And then we also have here in the neurosurgical system, a different system that we were working on. And you can see actually there's two displays. There's one here and there's one here. We actually had to put our guidance system next to the other system and kind of get it all in there to actually do some testing. So it's a pretty challenging environment in general. That's kind of one of the counterfactuals we're kind of going after this type of research. So what am I trying to achieve today? Hopefully provide you a new perspective on guidance you may not have considered, and then hopefully maybe inspire a little bit as well. So it's good to take a look at where guidance has been, and it's still here effectively. So standard of care neurosurgical systems still use these three principles, which is imaging data, which reflects kind of the anatomical aspects of the patient. We use that in the context of displays within guidance systems. Then we have that provides us our image space. And then we have localization, which is our physical space, trying to locate the patient within the operating room to allow it to digitize and kind of understand where that patient is. And then we have this idea of alignment of those two spaces, image space and physical space, and trying to relate one to the other. And that's the process of classically rigid registration. And so that's what, typically when you think about a roadmap being provided from imaging data to allow you to move through tissue and be able to look at that roadmap as you do so, that's the classic kind of representation of conventional guidance. But over the last really decade, to some degree, we've seen a pretty dramatic change. And really, it's been about kind of what information can we bring, what are the sensor aspects, what are the visualization aspects, and how sophisticated have we got in terms of mathematics. So the imaging data now can be complemented with things like physical parametric data or pathology data or even predictions, okay? And as far as the localization, while we had standard optical tracking systems that are still used, we still use them, but there's also really more advanced aspects of computer vision, more actually come down in cost quite a bit, as well as robotic systems. I look at a robotic system as purely a way of doing localization, more or less, and actuation. We also have non-rigid registration turning into non-rigid registration and deformable models and artificial intelligence, aspects of that in terms of computation that are influencing that. And I think also visualization, where visualization was kind of put away for a while, now it's coming all back with respect to augmented reality, mixed reality, holography, and different types of sensing methodologies. You really are seeing a maturing in a different way that we've seen in the past. This is an example of one system. It's a little bit of a prototype. It's kind of an eye in the sky type system we were working on. It's for breast, so I'm probably do a lot of context of breast surgery here. And this is work that was done by my graduate students, Morgan Ringel, Winnow Ritchie, with a lot of other folks assisting, as well as our surgeon, Dr. Ingrid Mazoy. And what you're seeing here is essentially a computer vision payload, more or less. It's doing optical tracking as well as with classic tool tracking, but then we also have stereo camera aspects doing tissue tracking. We have a guidance display and a typical ultrasound. All these things being integrated for the patient. We've used it in the OR, kind of seeing here, again, this eye in the sky kind of aspect of kind of observing and measuring is kind of how we looked at it. And you get a sense we moved on to more sophisticated stereo pairs. This is actually the Stereo Lab system. It's used for robotic vision, but you can see here pretty a pretty rich detailed point clouds being generated. So up in the top screen here you have standard lumpectomy being performed. You can see lots of things being tracked in textured point clouds down here, all at video frame rates. And so the sensing capabilities is quite remarkable. And then you think about some of the sophisticated aspects in AI and computer vision that we've done. You could do things like track how the breast is actually deforming in this case, and you can see kind of these markers. In this case, we've turns out with breast surgery, they often mark up the surface of the breast, so putting on letters is not a big deal. And so the idea of using these as ways of tracking kind of how the tissue is deforming, tracking tools, as well as kind of seeing even how the imaging devices, in this case ultrasound, were interacting with the breast is pretty remarkable. And we can do all that kind of in very fast time for, again, trying to bring more information to the surgeon during the case. So what might an advanced system might look like? You could look at it from this perspective. This is kind of how we look at it. So you can think of, yes, we're still going to have anatomic data. You can't replace anatomic data, but we might have other parametric forms, things like elasticity imaging. When I'm talking about kind of predictions and models and soft tissue and deformation, elasticity might be an important factor. And from there, we're kind of building kind of automated ways of creating kind of computational models from that. And from that, we can actually build real soft tissue, complete biomechanics associated with that. And then we can have kind of sensor systems, intraoperative sensing, things like robotic systems, maybe perhaps surveilling tissue, as I've shown before, perhaps having a HoloLens associated with display on the surgeon as well. And then from that, we can have sophisticated AI methods, to actually quantify, capture that data, and actually process that data we mentioned before, and really give us measurements, not only tool positions, but soft tissue, kind of how they're interacting. That's kind of where we're going. And then the idea is to collect that data in such a way that now it allows us to bring the imaging from the preoperative state into the intraoperative state and reflect true tissue presentation at the time of surgery. And so one of the challenging things with this is what's the nature of that data? And it's actually pretty tricky. You have things like fiducial data, perhaps some skin surface, perhaps some ultrasound, but ultimately it's very sparse data. So how do you use that to kind of correct the roadmaps when all that data was taken preoperatively? And that's something we work on. So the next slide you're going to see is I have a green set of images, which is the ground truth, which you wouldn't normally have during surgery, which is an MR. And we've done some excitation conditions to kind of simulate surgery. And you're going to see this magenta surface kind of matching that surface to kind of give you a sense of how we're doing alignment. It's slowed down quite a bit, so so you can see it, but it's this idea of taking that preoperative data and then moving it into the operating room to allow it to align and then be representative of true structure. And so you see it's kind of slapping on. Again, the ground truth is the green. You wouldn't normally have that. But again, the idea is we don't put it in the surgery. Now the surgeon can use it for an accurate roadmap at current presentation. So this kind of framework looks like this, which is if surgery is initiated, some form of surveillance system kind of working synergistically with the surgeon, perhaps some kind of AI-based process measurements, moving into automated strategies for alignment, all taking place extremely rapidly, and then having some form of augmented reality display, and then essentially improved guidance in this case. And this is kind of one of the hallmarks of our group, which is really to try to make these systems embedded in such a way that they actually kind of can provide additional information and additional guidance to the surgeon. One thing I hadn't mentioned is the augmented reality aspect. So this is kind of right, you see a conventional display where perhaps I have a monitor nearby. I could be watching that kind of 4-panel display. But on the left, you're kind of seeing, what are we thinking about, which is kind of this idea of projecting that display more readily into the field so the surgeon can use it. And so we've been doing this in the lab. Now we're starting to get that same kind of capability. So it turns out this is kind of tough too in terms of how to handle it. But this is one option you might envision doing in kind of an augmented reality way. You might envision maybe a model view, right? You might have something where you have the actual 3D model geometry projected over it and used in some way. And so we kind of have been working on that within the lab as well. You can kind of see a mock-up of that right here. You can see a tumor kind of floating in space. This has been registered, and now we can kind of change our viewpoint. You might notice a little bit of a shifting there, which, that's part of working with technology to kind of figure out how to make it work well. So there's an aspect of the way HoloLens works that locks in for most kind of gaming applications, but for surgery, it probably needs to be a little more accurate. So we've been working on that to make it really accurate. And so what you see here in the top images here, we actually figured out how to do some tracking with the stylus and be able to kind of create point clouds by using the HoloLens itself. And what you're going to see here is a vascular anatomy within a liver fan. This liver fan was actually built from a patient's set, and so the patient's anatomy there is actually shown there in terms of its vascular structure, as well as these models that you can see. And when as the student walks around, you'll be able to see kind of that reflect within the data, and things kind of go behind vasculature. So from a targeting aspect, we feel like we've kind of conquered some of that in terms of trying to use true AR to really do some targeting. So you kind of watch it right here. And you can kind of see as these tumors are they're actually going behind some vasculature, that you can see it kind of coming in front, and you can see it kind of really getting a good perspective. And so the idea of being able to perhaps target with an ablation unit or something like that, totally very possible in our mind. We're going to kind of continue to work on this and this blending of displays. And again, for us, we're thinking of it more in a collaborative way with robotics as far as kind of that sensing capability. So we've kind of conquered this first three areas right here, which is the registration and kind of moving into the patient. And so how do you do that to really help resection, right? So if we're talking about resection, we really want to make sure we clear the cancer margins as best we can. And so what's typically done is you do some kind of resection. You have kind of a mapping. The surgeon does a mental mapping to some degree. And they talk about superior borders and inferior borders and lateral and medial borders and the deep margin. And you typically will create some kind of pathology sample, and you'll send that off the path. And when we create that pathology sample in the operating room, oftentimes we ink it. Not everybody does it, but sometimes people use sutures instead. But we typically ink that surface, and it allows us to give a real good sense of what margin's what. So when they look at where tumor is on margin, where maybe perhaps an added resection needed to be, they can say, well, hey, it's probably on the margin in between the superior and posterior area, and that would hopefully guide them back into the tumor bed to allow them to do re-resection. But with all this digitization information going on, we should be able to do things like digitize that tumor bed and perhaps make a representation of that exact kind of mapping that they're doing in the OR, and then maybe perhaps put that back on the images and create essentially a virtual histopathology type record. And so that's something where we can look at our non-rigid registration in the context of that and see how we fare relative to the contrast enhanced lesion, perhaps have an estimate of what this is. Because the reality is that pathology resources are one of the most stretched resources in a hospital. So it's very difficult to do all that during a case, although I'm going to show you a case of that in a second. But to do that during surgery is actually pretty challenging for the most part. So again, what do we know about, clearing margins, establishing margins in the operating room? It's pretty interesting. There's some papers out, very few, but a few that are out there that are kind of interesting. This is one from Carral and Ong that looked at kind of how well can we find areas within a surgical tumor bed and be able to kind of re-resect areas where we've been told maybe some information. So this was an interesting experiment where they basically had a surgeon put in some sutures where the areas of pathology were going to line up with their specimen, and they placed those sutures in, and they kind of made some measurements associated with where the sutures are relative to other structures. And then the surgeon walked out of the room for 5 minutes, and they actually removed those sutures and then brought the surgeon back in to see if they could re-identify where those sutures were placed. And this is kind of the results of that study, which turned out to be on the peripheral as much as 1 centimeter, and on the deep margin as much as 12 millimeters on average. But you can see the range is quite alarming. Okay, so when you think about even in the case of 5 minutes time, you still have quite a bit of discrepancy between what you visualize and kind of what you can do. So the idea of needing localization is definitely something to be needed. And then when you think about the idea of doing a re-resection, perhaps the patient goes home and they get called back when pathology comes back with results. That's an even harder situation. So I have a colleague of mine, Mike Top, from over at Otolaryngology, who's working on kind of creating these very detailed virtual 3D pathology reports, which is a really kind of interesting idea, and kind of bringing the pathology kind of into the operating room. This has worked with Ji Wu here at Vanderbilt as well, and I'm kind of working with them on this as well. And so you get the idea of making these three-dimensional models that actually have all the detailed pathology, and as positive margins are allocated, you can kind of populate these margins and they become a really good record. And then if you can guide the surgeon, or perhaps maybe use augmented reality, you might be able to kind of guide maybe the specimen back into the cavity in some sense if you're doing maybe intraoperative frozen sections, and be able to kind of take that margin information, the close margin information, and really get a good sense of where it is within the tumor bed itself. So that's kind of an interesting approach for this. I'm also working with them, and you might think of even in the case when they're not in the operating room, have to bring the patient back, or even in the operating room when there's a lot of distortion and soft tissue deformation. So we're working on that in my lab in conjunction with Mike. And so this is in the case of breast cancer, where we're using the Stereolabs camera to kind of capture the 3D pathology sample. And then this is primarily simulation. We're still working on this. but we've done some work dealing with distorting that tumor bed, shrinking it, pulling it, using retractors and whatnot, and then actually doing some simulation work where we take common effects that occur in pathology, such as the shrinking of the specimen and changing of shape. So this is kind of the situation you might be faced with, where you have a black point cloud that represents the tumor bed, and you've got a specimen that's much smaller in size as it's dehydrated and whatnot. And then can you figure out a way to map that using kind of some of the techniques, modeling techniques that we've done, and we're working on that. You kind of see some of our results here. It's coming along, and those that know some of the ARPA-H work that's going around, there was a whole call on this idea of making more precise surgical interventions dealing with really pathology specimens. So we're kind of working on that problem too, for that system. So, again, localization for improving, surgery is good, but what about therapeutics? How can we kind of work in that space a little bit? I'm going to speed up a little bit to make sure I kind of make time here. So we're working in the area of ablation, microwave ablation, and so this is really for any local regional therapy, and this is in cases of liver. And the idea behind that is you're bringing in this ablation probe. It's a imposing microwave level EF energy, and it's actually going to be basically agitating the water molecules to the degree that it actually causes ablation to happen, a thermal cooking of the tissue more or less. And typically, if you have a centimeter tumor, a tumor that's a centimeter less and pretty much accessible, they can do this quite effectively. And there are guidance systems that are out there, but recurrence is quite common, and it has a limited number of indications. And one of the things that we want to work on is, rather than being brought to systemic therapy, where therapeutics are becoming much more, much better than they were. And so the idea of patients moving from palliative to perhaps ablative scenarios is something we're really interested in, as well as making more conformal ablations, being able to ablate things that are kind of would not normally make it into the indications. We're trying to kind of expand that process. So we're really working on a lot of localization work and advanced registration. So we're pretty good at modeling. And so what you're seeing over here, this little red dot up here, is basically our best modeling guess when we simulate microwave ablation. If we know enough about the properties of the tissue, we can do a pretty good job of estimating that. And what we wanted to look at is, we're doing all this registration and alignment work to guide these things. What happens to our positive predictive value, in terms of our overlap with what we want to do versus what we actually do when we're in the presence of misregistration. So what you're seeing here on the x-axis is target registration error, and then we see the positive predictive of the overlap, essentially, kind of our planned ablation versus what we actually do. And so as you can see, as my methods get more accurate, I obviously get better predictive value. But as you look at it, you can see it's quite clear that for every basically millimeter of error, I lose about 6% of my volume. So if you're 3 or 4 or 5 millimeters off, and we're in those ranges with these soft tissue deformations, you're losing 20 and 30% of your predictive value just in that process. And then I made the assumption that I could predict things. So from the modeling side of things, what if I use the wrong properties or use the wrong things? I could actually lose quite a bit more. And so we have this kind of challenge. This is kind of going into some of our digital twin work. So one of the things, why do we care about properties and things like that? So we're trying to look at imaging data and what can it do for us in terms of being predictive? And so it turns out fatty liver disease is one of these common things that present with cancers. And so can we use fatty liver disease, which, that affects thermal things, right? Probably fat does. And so can we use these things to kind of figure out ways of making the models more accurate, more predictive, and then move on and be able to correct for deformations to make these things much more accurate? So this is the kind of typical stuff you get in a Medtronic type system with an app or something like that. And so we're working on ways of taking imaging data, things like fat quantification and anatomical imaging data, making more accurate models, things that are dielectric and thermal properties that are dependent on it, that we're doing some measurements that look at kind of how thermal conductivity changes with fat content. So can we take the fat content from a patient and then just deposit the appropriate dielectric properties in order to kind of create these very accurate modeling methods? And then can we use all the deformation correction stuff that we've done in order to kind of make the guidance system more accurate? So this is kind of I was talking about the components that have changed. This is the idea of bringing simulation, predictive aspects into the theater where you can't do all the measurements. There are measurements you can make, but not things that deal with all these comprehensive things. So can we bring those kind of high-end computations to the OR? And just to give you some example really quickly, this is ablation volume delivered. This is thermal dose, and this is basically the fan base based on low fat to high fat. So you see quite a bit of variability in terms of ablation volumes when you have varying content. So the idea of this seems to be a pretty decent one for trying to kind of bring more sophisticated computation there. My time really quick. I'm going to skip through this last one pretty quickly, but The last thing I wanted to talk about was, okay, that's great. We have all these technologies that help us do surgery, but how do we use them to guide surgical training? Okay, and this is kind of getting a little bit into the robotics. This worked with Nabil Saman. And so we're very familiar with the paradigm of see one, do one, teach one. That's the common way that we train in surgeons. It assumes that we have essentially a cadre of surgeons available to us that can provide that training. Protocols have been developed to do this. Societies have adopted it. Its subjective assessment has been shown to be very effective. But when you think about developing countries, those cadres don't really exist as much. Oftentimes there's a drain of these folks where maybe they're coming from constrained countries. They go to places to get trained, but then they often don't return. And so there's an issue. How do you train folks when the cadre is there not to do so? And so that's one of the things we're working on to meet that need, and we're doing this with the Wellcome Trust as a grant associated with them. This is the team that's working on. Again, this is led by Dr. Nabil Saman here at Vanderbilt, and the general idea is to create an exoskeleton that allows us to kind of do a whole new version of haptics. So can we allow surgeons to train realistically to do things like cholecystectomies, which this one is geared at, and allow the robotic exoskeleton to kind of act as appropriate haptics. And you kind of see some of the robotic systems here happening where Dr. Idris is able to move this laparoscopic manipulator as much as he needs to. And then basically the system itself can actually either monitor it for training purposes and evaluation, or it can provide the appropriate haptics and control, like you're seeing here, in order to kind of achieve that. We're also tying, that's great. You have the ability to do the haptics. Well, you need the actual procedure to do. And so we're working on ways of this is actually fairly old. We're actually much more sophisticated than this now, but the idea of actually having a simulator with a HoloLens coupled to the exoskeleton is kind of where we're going, which is kind of really interesting conception of a simulator. But again, you could have all the training aspects associated with this all self-contained within a low-cost system in order to kind of train folks in areas to do these types of procedures. We're doing aberrant anatomy and making models that are very sophisticated with respect to what they do in terms of using FEM. We're starting to work on ways of doing the different manipulations and blunt dissections, as well as cautery, as well as general other aspects associated with clipping and clamping. And then we're also doing, that's great. We can do all those models. And anybody who knows XFEM or FEM, they're kind of slow and compared to doing, faster than video frame rate updates. And so we're actually using machine learning and physics informed machine learning in order to achieve this. And we're getting down to millisecond level of interaction. So it's really getting to that This is done with Sohail Kaluri. It's also part of the team. So it's really great. So hopefully that gives you a little bit of an idea of a lot of different areas to some degree where essentially all this kind of more sophisticated area of guidance is coming in and where modeling can play a role as well. And so with that, I'll take questions, but hopefully you found it worth your time. You've gained some insight from my expertise and maybe saw some opportunities in this research environment. So I have some time for questions. I'm more than happy to take some.
Professor Miga, that was a very fascinating, insightful talk. Thank you. We have got a few questions that have come in from the audience here. So here's one. Are there any robotic systems out there that deliver microwave ablation?
There are many, commercial vendors that do microwave ablation. Yes, there's many. New Wave has a system. Perseon. Medtronic's Covidian system is also, so there's several systems that do microwave ablation, yes. As far as the guidance systems and things like that, there are some that are coming online. I won't comment on any of them. Oftentimes they are not as efficient as they need to be. Oftentimes they are done in the context of IR. The cassination system is one of those as well. But ablation is one of those, things that can be done in a lot of different contexts, including open surgery, laparoscopic, and percutaneous. And so there's real need for, dynamic conditions of delivering those kinds of therapies. And oftentimes the indications for use are quite limited. And so one of the things I didn't kind of highlight it in there is we're thinking of microwave therapy in a more conformal way. So there are some sector arrays that deliver microwave energy kind of sectorially, which are kind of interesting, right? And then there are also this idea of if you understand how to predict it well enough, can you really make headway in terms of expanding the indications, the size of tumors, and the control and the approaches that you use? That to me is a really interesting question for the future. And again, going back to you're seeing a lot of advances in therapeutics in such a way that they're making this more possible. Tumors are shrinking. People are moving from palliative to being surgical candidates or ablation candidates. So it's kind of super exciting in that way. And it actually kind of emphasizes, one of the things I think that's really challenging, even in robotics, is, you develop these systems kind of thinking that the clinical condition is going to be like that forever. In my career, when I first started, I was working really in the neurosurgical area, and I expanded into liver. But back then, liver cancer, primary liver cancer, was smaller than, in terms of its patient population than it was for brain. And then over the years, due to things like fatty liver disease and various comorbidities, there's been a change in such that there's been quite a bit of growth in cancer associated with liver over the years. And that's directly related to changes in etiology and things like that. So it's kind of interesting.
We do have a few other questions actually coming in. So I know your models utilize thermal coefficients, dielectric properties. So are you working with MR thermography at all?
MR thermography is great. I think it's a good validation tool. You can certainly use it to assist, and there certainly are systems that are out there that are using it in a way to predict that. But it is an MR thermography system, so the infrastructure and the encumbrance around that do have to be taken into account. It certainly is a very viable technology to assist with understanding ablative context. But you remember, thermal energy, when it gets deposited, boiling water doesn't cool very quickly, so you're really trying to control, right? So you really have to have more of a predictive aspect to it, even with thermography, because once you deposit that energy, you can't take it back. And so you really do need to have even good predictors associated with that if you wanted to use it, even in the MR thermography scenario, if you can get by some of the workflow aspects.
So have you been looking at MR-EPT then to actually derive the physical dielectric conductivity properties from the patient?
Well, that's one of the things we're looking at, is looking at fat quantification imaging for that very perspective. But there are electroconductivity imaging type things you can use. I think it matters as to, are they a good surrogate, and have you validated against good ablative experiments. But I think that emphasizes the idea of digital twins, though, which is pretty exciting, to kind of bring in as much data as you can that's been validated and verified in order to kind of make these predictions better.
And there's a good one last one, I think it's more broad, is what are the main barriers to entry with surgeons using AR in their day-to-day activities?
It's a great question. It's still unknown. I think what I'm pretty, I've seen, this is the third time I've seen AR in my career. Actually, some of the very first work was done at Dartmouth, where I did my PhD. And it's always been not sophisticated enough. The sensoring aspects have been not kind of far enough along to really make it effective. I'm kind of a believer right now, in the sense I think the HoloLens is a sophisticated sensor package that can do quite well. So I'm pretty impressed with it. I think there's still weight requirements that are still a little off. The HoloLens is better than some of the other ones, a little lighter than most. So there are some aspects of that. I still think there's an aspect that surgeons don't like their field really, really super cluttered to some degree. So there's an aspect of how it interacts with the surgeon that's important. But I do think the sophistication is getting there, and it's actually worth really looking at as a technology. I do think the lack of having to look away from the field to get guidance versus in your field and getting that information that's necessary, I think is it's there. The displays are quite remarkable. So I do think one of the biggest barriers, probably head weight. There's a little bit of disorientation. I'm kind of more of a fan of the augmented reality, versus the full overlay. So I think that's a little better. They have a little better context of what's around them to make them not have motion sickness and things like that. So there are some aspects that still need to be overcome, but they're pretty exciting, I think, when I've looked at them.
Dr. Lumsden?
Yeah, thank you. Again, very exciting. Yeah, you're the first person who's presented using ultrasound. And to me, that's much more, you're taking on a much more difficult problem. You stick somebody in a CT and an MR and you kind of get a cookie-cutter image coming out of it. But the ultrasound is so dependent upon who's got their hand on that probe. Can you talk about a little bit of the challenges of this?
Yeah, ultrasound is it's if you talk to any surgeon, they love it. Like, as far as it's a great it's one of the most ubiquitous, nice imaging modalities to do intervention with. So like when we talk to our IR folks, for instance, and they have the guidance systems in the CT, they always say, if I could get ultrasound to work really, really well and I could do it, I'd do it with ultrasound every time, because it's just so much easier to use. And so I think from that perspective, it is great. And I think it does have, we are working here at Vanderbilt. We have another investigator here that's working on ways of enhancing the actual image clarity and contrast with soft tissue structures. So there is work in those domains in beamforming. Actually AI is being involved with that quite a bit, which is pretty interesting. The idea of other modalities like perfusion imaging, as well as is done well with ultrasound now. You can actually do things that are below Doppler. One of my colleagues working on it as well. And there's aspects of elasticity. So they do provide quite a bit of information. Mm-hmm. The registration's tough. It's not an easy one, for sure. But it can do certain things well, which is when I was mentioning our breast project, things like chest walls and things can be very easily found with an ultrasound. So there are definitely features that we can do it with well, and it just serves as a source of data. But it is an intervention modality that can be done at the time of, and so it's pretty useful in that regards. And so I think it's probably not good to negate it. I think it's going to be there for a long time, and I think it's going to be something where we have to think about how to integrate it in with our guidance systems and our robotic technologies to some degree as well. Because I think it's going to be there to stay, and it's one of the few modalities that really works well in the workflow.
Wonderful. Well, Professor Miga, thank you very much for joining us today. Really do appreciate your time.
No, my pleasure. Thank you.
Okay. Moving on and keeping best to time, we have Professor Ron Oterovitz online. Now, he is professor up at the Department of Computer Science, University of North Carolina at Chapel Hill. And he is here today to talk to us about Towards Autonomous Robots for Healthcare. Professor Oterovitz, good to see you, sir.
Okay, thanks for the invitation. Do you see the slides and do you hear me well?
Correct.
Okay, great. So again, I'm Ron Oterovitz, and my research focuses on enabling robots to operate autonomously. So today I'll focus on our work on automating procedures, medical procedures in living tissue. So we already have a variety of autonomous systems. One example is a rocket, which can autonomously control itself without human intervention to reach a specific orbit in space. However, if we want to reach a specific site deep within the body endoscopically, no current commercial platform is capable of doing this autonomously in humans. Enabling medical robots to autonomously move through a body to accomplish a task is really hard, essentially harder than that rocket launch example. And creating autonomous robots, though, could have significant benefits, including enabling greater precision and accuracy, enabling new treatments and procedures, reducing medical errors, enabling remote healthcare, and potentially lowering costs. So what do we need to do to enable a medical robot to autonomously complete a surgical or interventional task? Let's start by looking at how medical robots typically operate today. So a physician typically teleoperates a robot, which is then operating on the patient. And to make the decisions, the physician uses a variety of data sources, such as sensor data, including visual, auditory, tactile data, medical images, medical records, and so forth. If we want to create an autonomous medical robot, we need to add an AI, and this AI can then look at the same data as well as feedback from the physician to control the robot. And as we make the AI more powerful, we can decrease the amount of control and feedback we need from the physician, increasing the level of autonomy of the medical robot. So let's take a closer look at the AI. There are many approaches we can take to enable autonomy. So one approach is a model-based approach where we develop kinematic models of the robot and create 3D models of the anatomy and develop planners and controllers that use those models. Another approach is to use learning-based approaches where we create neural nets that directly map the data to actions for the robot. So I'm going to talk about our approaches that we use, and I'll make the case that we need to use all of these different types of computer science and engineering approaches to address the challenging problems of automating medical procedures. So let's look at the motivation for our autonomous medical robot, which is lung cancer. So lung cancer is the deadliest form of cancer in the United States, killing more Americans each year than colorectal, breast, and prostate cancer combined. So early diagnosis is critical for survival. So achieving a definitive diagnosis of lung cancer currently requires a biopsy, which requires guiding a device into the lung to obtain a tissue sample to verify the presence and stage of the cancer. A traditional approach to biopsy is transthoracic biopsy, in which a physician inserts a straight needle into the lung between the ribs. This often results in errors in guidance and also requires puncturing the pleura, which is the outer membrane of the lung, which can lead to a serious side effect of lung collapse. An alternative approach is a trans-airway approach in which a bronchoscope is deployed through the airway. This reduces the risk of lung collapse by not puncturing the pleura, but often cannot reach many nodules, particularly in the peripheral or outer parts of the lung. So modern robotic bronchoscopic systems can reach more targets, but still not everywhere. So my research group is combining the best of both of these approaches by creating a device in which a steerable needle is deployed through a bronchoscope and can steer to a nodule anywhere in the lung. And so this was research supported by NIH, and it was led by my team at UNC Chapel Hill, also in collaboration with folks at Vanderbilt, and also Alan Kuhns, who worked on it while at UNC, now at Utah, who will also be talking later this morning. So here's a picture of the robot. We see the robot actuation unit, which controls a steerable needle. That steerable needle then gets deployed through a conventional bronchoscope, and it comes out the other end where it can steer through the lung tissue. So the key enabling hardware in the system is the steerable needle. This video here shows several manual needle insertions into gel to demonstrate some of the capabilities of these flexible steerable needles. So deployment of the robotic system consists of 3 stages. So first, the physician navigates the bronchoscope. In the second stage, the physician pierces the airway wall and embeds the needle in the parenchyma. And then finally, in the third stage, the robot autonomously steers the needle to the target along a safe path. So we're going to focus here on the autonomous stage. And the idea with autonomy here is pretty simple, that we want the physician to be able to push the go button, and then the robot takes over and autonomously completes the task. So here we see a simulation video of a procedure to reach the nodule in the lung for biopsy. So steering the needle, which we see here, trying to avoid those blood vessels and reaching that yellow nodule, in many ways resembles steering a car, but now we must do it inside the anatomy in 3D in very cluttered tissue, where we must avoid obstacles like significant blood vessels. We also must handle respiratory motion, which is like the entire environment deforming. So we created this robot platform and we assessed its performance in living and breathing lungs, in which we conducted a set of in vivo system deployments. So here's a photo of the experimental setup. We performed a live study using a live pig, which has lung anatomy similar to humans. You can see the robot actuation unit, the bronchoscope, a scanner cut off on the right, and then also a magnetic field generator and sensorized fiducials, which allow us to track the needle and perform registration between the CT of the lungs and the actual lungs. So this study showed the first medical robot to autonomously steer a needle and avoid obstacles in living tissue. This was published in Science Robotics under a year ago. You can see the link there if you want to sort of download the paper and read more about the details. To summarize some of the high-level results, not only did the robot succeed in performing the first autonomous needle steering in living tissue, it also performed quite well, achieving high accuracy. Here we use a penny as a reference to better conceptualize the scale of the errors. Overall, we performed 3 needle deployments in 2 in vivo experiments. The average targeting error for these insertions was under 3 millimeters, which is below the threshold for accurately reaching the smallest clinically relevant nodules. These results demonstrated our system's ability to successfully operate autonomously in living lungs undergoing respiratory motion. Next, we want to answer the question, can an autonomous robot improve procedure outcomes? So we compared our robot to an existing clinical bronchoscopy method. We conducted a comparative study in ex vivo pig lungs, and this photo shows here the experimental setup, which was similar to the in vivo setup. We measured the error in reaching the target for both our robotic automation approach and a current manual bronchoscopy approach. Using the penny for scale again, we see the manual deployments had a high targeting error, with physicians indicating that many of these biopsies would not have been attempted if this was in real patients. Our robot using automation achieved a much better accuracy compared to the current bronchoscopic technique. So now let's look under the hood on how we made this system work. So first off, a disclosure. So I am an inventor on university-owned patents on medical robotic devices that incorporate steerable needles. So in our workflow, we first take a preoperative CT scan, and then we segment the anatomy to construct an environment for our motion planning algorithm. From the CT scan, we can automatically segment the relevant obstacles, including the large blood vessels, the pulmonary pleura, which is the outer membrane of the lung, and the bronchial tree. We can also segment non-critical structures that would be nice to avoid if possible, like smaller blood vessels, which can be encoded in a cost map for comparing feasible plans. Then, based on the segmentation, we plan several safe paths given the hardware capabilities of the needle. We use a robotic steerable needle capable of following curved paths through tissue, as shown in this X-ray image here. This particular needle has two key properties. It has an asymmetric bevel tip, which causes the needle to bend as it is pushed into soft tissue, and it is highly flexible, so it curves a lot. We can twist the needle at its base to change the direction the bevel is pointing, which enables us to change the direction of the steering and follow curves like the one in the X-ray image. The task of the steerable needle motion planner is then to compute a 3D trajectory that complies with the kinematic constraints, avoids the anatomical obstacles, and precisely reaches the target site. So one approach we have used is to adapt a rapidly exploring random tree, or RRT type method for steerable needles, which is a fairly standard approach for motion planning for robots. This is sort of a 2D illustration here, but this is all being done in reality in 3D. For each of these voxels here, we can highlight some of them are obstacles, meaning they're like these larger blood vessels. Some of them are free space, which is parenchymal tissue through which the needle can navigate. And we want to reach the orange circle there. So the RT-based method starts to explore this space. If it runs into an obstacle, then it basically says it's not going to go further in that direction. This is all done computationally until we eventually find a solution that reaches the target. And these types of exploratory methods like RRTs, again, work very well in practice, and we can get plans in sub-second times, but they don't offer very many guarantees. In particular, it can only guarantee that it will eventually find a solution. And so really we want to know is, can we do better? So we ideally would want to find an optimal motion plan in a fixed finite amount of time, guaranteed. So we've been developing methods to essentially create certifiable motion planners, providing certifications and guarantees on motion planner performance, which is important for medical applications and autonomy to be adopted clinically. So how do we achieve this sort of guarantee on performance? So as a step toward this goal, we investigated a search-based approach. So our method uses needle-specific motion primitives. A motion primitive defines a motion, in this case, that first rotates the needle to determine its curving direction and then inserts the needle. These are needle-specific in this case. We build now a search tree that repeatedly applies these motion primitives, and we refine the motion while expanding the search tree. So we implemented some speedups that make this method fast in practice and guarantee returning an optimal solution in finite time. So up until now, we focused on the autonomous needle deployment, which is the third stage of the robot. However, when the needle starts in stage 3, it depends on the earlier stages. So in particular, where should the physician park the bronchoscope and pierce into the parenchyma or the tissue of the lung? This defines the start pose of the needle and has an impact on whether the needle can successfully reach the target. So to determine where to park the bronchoscope, we created a motion planner that considers all 3 stages of the system deployment, from the bronchoscope to the piercing into the parenchyma to the needle steering. For efficiency, we plan backward from the target onto the surface of the airway, which is actually faster because we're going from essentially a point to a surface for planning. And that's much faster than trying to plan from a particular launch point to a particular target. We can then execute the plan that we found in the forward direction, but we've already taken advantage of this speed up in computation. Parking the bronchoscope for needle deployment is essentially a handoff of control of the needle from the physician to a robot. And how this handoff is performed has an impact on the success of the procedure. So to make the handoff as robust as possible, we can compute funnels around potential plans, such that if the bronchoscope launches the needle from any location where the funnel intersects the airway, then the autonomous steerable needle will be guaranteed to be able to find a plan that reaches the target while avoiding the obstacles. This is essentially a form of communication where the autonomous robot is telling the human physician its capabilities on a patient-specific basis so that the handoff from where the human is controlling the system to where the robot is autonomously controlling the procedure will result in an overall successful procedure. So we've now discussed all three of the planning stages. One thing that I didn't mention that's critically important here is respiratory motion. All the planning was done in a static environment based on what I spoke about so far, but in reality, the patient is breathing, creating a highly dynamic environment. So our approach is to only advance the needle when we are in a known lung deformation state. So specifically, we use the inhalation state, which corresponds to the image that was segmented, which is also when the lung is biggest. So here we track the fiducials. We see these EM trackers that we have on the chest wall of the animal. And we use breath holds, which you see sort of for the first about 8 seconds or so. There's a breath hold, so they aren't moving. Then we allow 2 breaths. And then you see it sort of hold steady for about another 8 seconds or so. And then we have 2 breaths, and we sort of repeat the cycle. We are then only going to insert the needle during those breath holds. And we see this in the bottom plot. Now we're tracking with an EM EM tracker, the coordinate of the needle tip. And we see that we advance the needle tip, steer it during the breath hold. And then while the breathing is happening, we don't insert the needle. And then after the 2 breaths, the state of the lung has returned very close to where it was at the time that the needle paused. And then we resume needle insertion and continue until we reach the target. So in summary, we used a primary model-based approach, which led to our successful needle steering automation in living tissue. So we focused primarily on setting up and performing the autonomous needle deployment. Now let's go deeper into the bronchoscope navigation. In our in vivo experiment, bronchoscope navigation was purely manual, but we recently also have been working on greater levels of assistance for the bronchoscope placement. So as before, from a preoperative CT scan, we can create a 3D model of the anatomy in which we can identify a target pose where to park the bronchoscope. Then, during the procedure, the physician needs to register the view they see from the bronchoscope with their camera to the preoperative 3D model. The big question then is, where is the bronchoscope's tip in the 3D anatomy model? So there are several major challenges in bronchoscope localization. The first challenge is that while the anatomy being used for localization is static, the lungs intraoperatively are dynamic, deforming due to respiratory motion. This results in a discrepancy between the anatomical states which leads to CT to body divergence, which makes tracking with systems like electromagnetic tracking navigation challenging because the lung is deforming, whereas the tracking coordinate system is not necessarily moving with the lungs. So also the idea of using breath holds, which we used previously, doesn't work for the duration of bronchoscopy. So the other challenge here is the visual appearance of the environment. So we can, in this example bronchoscopy video, see that the tissue is very uniform and repetitive, and there are very few features on the wall of the airway to help localize where the bronchoscope is. This means that a lot of traditional approaches used in engineering and computer science, in robotics, for visual localization and visual odometry type of approaches struggle with this setting. So to try to overcome these challenges and enable accurate localization, we proposed a new method for bronchoscope localization using landmarks based on bifurcations, which are the splits in the airways. So the idea of using sort of a landmark-based approach here is that we want to leverage the observation that while globally the lung is deforming, locally the landmarks, bronchoscope, and target do not move significantly relative to one another. So using the observation that locally everything moves together, we can determine the bronchoscope position and orientation relative to the nearest bifurcation or airway split that's visible in the camera feed. And so to learn the transformation from the bronchoscope camera to the bifurcations, we tag bifurcations in some of the preoperative 3D anatomy and generate a data set of image transformation pairs. We then use that data set to train a deep neural network to regress the transformation from the bronchoscope to the nearest bifurcation using the bronchoscope image as the input, and then this transformation to estimate the bronchoscope pose. So in our experiments, our method localized the bronchoscope with accuracy sufficient to access the smallest clinically relevant nodules, and the method now runs in real time. So in summary, we discussed steps toward autonomously reaching sites in the lung, including in vivo procedures. There are other medical robots that my group is also working on. I won't have time to discuss these in greater depth. One such example is endoscopic procedures in the colon, particularly like ESD-style procedures. This is a project led by Caleb Rucker, also jointly with Bob Webster. And here we're looking at essentially these push-pull robots that can manipulate and potentially autonomously manipulate tissues inside the colon endoscopically. We also have a lot of our motion planning software, which we've used for automating procedures in vivo, are based on our fast motion planning libraries, MPT, and also nearest neighbor search library called NI. These are the building blocks of these automation-based methods based on motion planning. And these are available open source, so you can feel free to download them and try them out. And we do use our own code here in our experiments, including the in vivo study. We've also developed a data set for anatomical environments, which can allow people that are interested in getting started in medical robots to try out different planning and controller methods that can be used toward automation. And these are now freely available based on real human data. So going back to our in vivo experiment on automation, I'd like to discuss a few of the lessons learned. Okay, so the road to autonomous robot development is a long one. And like many groups, we initially start testing our algorithms out in simulation, then we move to benchtop experiments, then we go to ex vivo experiments, then we move to in vivo. And this is a big step to in vivo, but of course, beyond in vivo, there's still more, of course, moving to cadavers first in humans, and eventually, ideally, aiming for a standard of care. If we look at the challenge of medical robot autonomy specifically here, every stage of development is a cliff where some robot automation efforts don't proceed. And so I'm going to focus on that in vivo cliff as we move from ex vivo to in vivo, and what are some of the challenges that we encountered when taking robotic automation techniques and then putting them in living tissue. So sort of preaching to the choir here for anyone who has worked on this, or especially physicians who deal with this every day, but enabling autonomy in vivo is hard. So research groups that have focused on robot autonomy in general, sort of how to make robots autonomously operate in the real world, in many cases don't have experience with in vivo procedures. They sort of have experience with autonomy in other settings. And this needs to be mapped into the in vivo space, which raises a whole slew of challenges. So a large team of people is needed. So in order to do an in vivo experiment, you have to have physicians present. There's the vet staff, the imaging staff, the research team, and so forth. And all these people have to have space in the room near the robot in order to work effectively as a team and to have space to work. There's also the time pressure that in a lot of experiments that are ex vivo or sort of like robot autonomy experiments that are not in vivo, time pressure isn't necessarily there, but when in the OR, time is ticking, things have to move on a clock, things have to be efficient. And this places sort of an extra bar on the automation. It has to essentially work quickly and efficiently. Another aspect for folks that are sort of newer to making automation work in vivo is that life is constantly in motion. And this is something, again, physicians and experience and are very well aware of, but people that are more in the engineering and computer science communities who haven't experienced this firsthand will sort of be less familiar with this. Life is in motion. There's breathing, there's pulse, there's moving limbs, and all these things are going to affect your registration and your ability to perform procedures autonomously. And these have to be considered. And that leads to this next challenge, which is robustness to uncertainty. There are variances in anatomy, variances in image quality, and we have to be essentially whatever data comes in, the robot needs to be able to make that decision on what to do next. And for an autonomous robot, that has to be done automatically. And that leads to the final point, which is the show must go on. Unlike with certain other cases where you're doing things in simulation or in benchtop, something isn't working, you can pause it, rewrite your code, and improve it. In an in vivo setting, there's a live animal there. The robot has to make a decision, it has to make a good decision, and it has to move forward. And this is sort of a critical part of making things move forward, because once we push that button, we sit back and we watch and we hope that the robot can succeed. So in this talk, I talked about some of the challenges that we face and how we overcame them to enable our lung steerable robot to work autonomously in vivo, and the various AI tools that enabled us to do that, and hoping that we can push forward and push that automatic button for autonomous performance for more procedures in the future, and also moving toward toward humans and so forth. So I want to thank the team of students, the graduate students, physicians, collaborators, and everyone else that made this possible, as well as collaborators inside UNC and outside as well as NIH and NSF for their support. And thank you, and happy to answer questions.
Well, thank you, Professor Arturovich. The sign of a great presentation is the amount of agitation that I feel, because we've not done this here yet. So I'm going to try and persuade you to start looking at another specialty, and that is the original endobronchial robot was actually Hansen, and it came from an endovascular robot converted into an endobronchial robot. And now the whole field has exploded. But I'm a vascular surgeon, so that's why I get agitated when I see how advanced endobronchial robotics has become, and yet the endovascular robotics part really has gone, there are fledgling companies. You'll hear from one of them this afternoon. We run a meeting once a year with oil and gas in town, and one of the drilling guys said it's all about working through long, thin tubes. And so I think the premise of that is it doesn't really matter which the organ system is. A lot of these things can be applied in any long, thin tubes. And so you must have thought about blood vessels. And can I persuade you to start applying some of these things that you've achieved into the vascular community?
Yeah, we have thought about it. It's something I'm definitely interested in potentially doing more research in. There are absolutely a lot of connections in terms of, just like you said, sort of creating a long tubular path from outside the patient into a site of interest. There are different challenges in different spaces. In the lung case, part of the time we're spending in the bronchial tube, but then a big part of it, the autonomous needle steering, was actually through the parenchyma. And through the parenchyma, we're actually going, essentially, it's the equivalent of going off-road, right? If you look at either the tubular anatomy of the bronchial tubes or even the vasculature as being sort of like a roadmap off of which you can sort of like follow the roads. When you enter the parenchyma, you're essentially off-road. And at that point, you need to sort of have complicated decisions on steering through the tissue. That said, there are a huge number of collections, and I'm definitely interested in hearing other people's ideas. And everyone should, it'd be great if folks would reach out to me afterwards with ideas as well. And I'd love to collaborate on new applications, endovascular, as well as other parts of the body as well, where we can bring some of these sort of automation style tools to automate robotic procedures in other domains.
So let me throw out a concept, is that blood vessels are everywhere. You can access any organ anywhere through the vascular system. What we need are the techniques that you've developed. How do we get out of the vascular system? Use it as the pathway to get to a point anywhere, liver, lung, get out of it without bleeding to death, and seal that hole and come back into it. A much more ubiquitous distribution pathway, if you think about it from that standpoint, for a snake robot.
Yes, well, thank you. Yeah, definitely agreed. And I'd love to explore these new applications.
Mm-hmm.
So we've got two very specific questions from the audience, and we've got about a minute and a half. So how do you account for perception/actuator uncertainties in the search-based planner?
So great question. So the search-based planner is going to create a path from the start to the goal. And there are two ways that we can handle the uncertainty that will then arise. So the uncertainty can arise, for example, if our estimation of the radius of curvature or some of the kinematic modeling assumption parameters aren't fully accurate, if the deformation of the lung isn't perfect and things like that. So ways that we can account for that are, first of all, we can use a controller to try to help control us and ensure that we're following the path of the needle. That's essentially the approach that we use in the in vivo experiment. Another approach that we've also been explored with is rapid replanning. So we can actually make our planners fast enough that we can put them in a control loop, essentially operate them at sort of multiple hertz, and as the needle is inserting, actually replan continuously a path to the goal. And this can account for some of the uncertainty and some of the kinematic modeling errors that we can have as the needle maneuvers through tissue.
Wonderful. And we got another question just come in. Can you describe more regarding what do you use for fiducials beside the needle to find the target? How do you deploy these fiducials in vivo to find the bronchial scope tip? Very specific.
Okay, well, great. So we used NDI EM trackers. Due to space limitations in the needle, we had a 5 DOF tracker at the tip of the needle, and then we would sort of estimate what the 6th degree of freedom of roll is. We also had the EM trackers on the chest wall. Those were the ones that I showed in the graph of respiration motion. And so those were we also had, I guess, one other EM tracker at the tip of the bronchoscope. And with those, we had essentially the information that we needed to do the automation that we described.
Okay, and now for the golden prize, Ron, we're really putting you on the spot here. Another one is, for the bronchoscope localization, how does your neural network generalize over different patients?
So we have some results in the paper actually that talked about essentially that generalization of different patients. So the neural net can be trained across multiple patients, and that will create a level of robustness that when encountering a new patient, it will have the information that it needs to sort of localize itself from just the bifurcation that it sees. So very explicitly, this is sort of trained across multiple patients to allow it to be generalizable across multiple patients.
And last question, with the RRT for steerable needles, how do you navigate overfitting and patient uniqueness? Bonus round.
So with the RT, the anatomy is always going to be on a patient-specific basis. That will define where our obstacles are. So from the preoperative CT scan, we do the segmentation. That creates a patient-specific anatomy. And then we will run this, either the RT or the search-based planner based on that patient-specific anatomy.
Okay, Professor Altrovitz, you've been absolutely excellent. I really do appreciate the rapid fire round there questions. Thank you very much for joining us, and I look forward to seeing you again in the future.
Excellent. Thank you. Thank you for the invitation.
All right, next we have Dr. Loris Ficera. He is an assistant professor tuning in live from the Department of Robotics at Worcester Polytechnic Institute, and he's going to be discussing next generation surgical robots for energy-based surgery. Loris, pleasure to have you on the show.
Good morning, everyone.
Morning.
Over to you.
Hello, everyone. Okay, can I go ahead and share my screen?
Please.
Alrighty. Just give me a sec. Screen sharing failed to start. Okay, this has never happened before.
It's okay. Houston, we have a problem. We're very fond of that expression here. But we get over it. Carry on.
Okay, how about now?
We got you.
Yeah,
Excellent.
perfect.
Okay, well, good morning, everyone. So my name is Loris Ficera. I'm an assistant professor at Worcester Polytechnic Institute. I gotta say, it's really hard for me to speak immediately after Dr. Alterowitz. His research is amazing, and he and his team have been so successful. And I didn't even have a fraction of his success in my career until now. I'm at a much, much earlier stage. I guess I'm saying this because I'm trying to manage expectations a little bit for the next 30 minutes. But moving right along. So this is WPI. For those of you who have never heard of it before, we are a small science and engineering school located in central Massachusetts, about an hour away from Boston. Historically, we've been an undergraduate school, but in recent years, our research output has increased quite a bit. And in fact, our graduate population is increasing a lot. As of today, we have about 6,000 students, and about 1,800 of them are graduate, and the majority of them are in the robotics program, which I would say is the one thing that is probably the reason why we are known both nationally and overseas. WPI was home to the first undergraduate robotics engineering program back in 2007. And since then, we have grown a lot. As of today, we have about 21 faculty in our department, and we do research in all aspects of robotics, including surgical robotics. But really, you name any type of robot, we most likely have it. The reason why I joined WPI is that we have this center called Practice Point, where we essentially have a replica, a mock-up of different clinical environments where you can test your robots without having to use machinery or rooms or facilities in the hospital. We can do testing up to the preclinical stage. The pictures here are showing some of our facilities. We have, among other things, a full clinical MRI. One of my colleagues here, Greg Fisher, is a pioneer of MRI-compatible robots, but we really do have a cluster here of medical and surgical robotics faculty, including people that do research into imaging, others that do research into magnetics, and so on and so forth. This is my research platform here at LPI. I do research, my students and I do research in two main areas. On the left side is what we call energy-based surgery. So what we do is we look at ways in which energy-based instruments interact with biological tissue, and we try to develop modeling and control algorithms to optimize the effects that these instruments have. And on the right side of the screen, we have continuum surgical robots. Now, if you're watching the presentation from Dr. Alterovitz, I don't need to introduce these types of robots for you. Typically, projects in our laboratory involve some combination of permutation of these two main trusts. And I would like to start by talking to you about one project that has been, for which we have received funding from the NIH, which I believe best combines these two fundamental research trusts. And this project involves doing surgery of the vocal folds, surgery of the voice box in the office. This is a collaboration between my group at WPI and Dr. Thomas Carroll at Brigham and Women's Hospital in Boston. And effectively, what we're trying to do is to enhance the way in which pathologies of the voice box are treated in an office setting. If you're not familiar with, treatment of the voice box, this is one way of treating them. Essentially, if people present with, let's say, a benign tumor of the vocal folds, the physician would pass an endoscope through the nose down into the voice box and then deploy an optical fiber to apply laser pulses on the lesion, and effectively using the heat produced by the laser to necrotize the tissue and essentially remove the tumors this way. Now, one of the limitations of these procedures, among others, is that it's currently very hard to control the aiming of the laser, because the only way to do that really is to control the bending of the scope. And so when the physician is into the larynx, it may be hard to keep the laser on target. And I hope you're able to see the video that I'm playing right now, but this is showing a natural procedure where the physician is really trying to wrestling with the scope. Of course, there is also patient movement going on because people, patients are awake. And it is really hard because of all this to keep the laser on target, which is where we come in. So this is me testing a new type of optical fiber we have developed in my laboratory with a three-dimensional model of the voice box. And in this video I'm playing, what I'm doing is I'm using this new bendable optical fiber that we can use to target lesions in places that would normally be hard to reach, precisely because of the inability to control the steering of the optical fiber. We have developed this device together with Dr. Carroll, as I said, with funding with the NIH. And really the secret sauce of this device, what makes the bending of the optical fiber possible, is these very tiny 1 millimeter in diameter notched nitinol sheath that carries the optical fiber, and that can be controlled remotely to provide essentially fiber steering at the distal tip. This is the work of my recently graduated PhD student, Alex Chiluisa. We describe this work in a 2022 IROS paper, which you can access by scanning the QR code below. One of the interesting aspects of this work that I like to emphasize is the fact that, as I said, the notched tube wrist is really the secret sauce. And we can create notched wrists that can bend according to different geometries. Sometimes, depending on the anatomy, you may need to have more distal bending. Some other times it may be beneficial to have more proximal bending. And so this is something that we have actually explored in our group. These notch tube wrists, the way they work is essentially we have these sheets of nickel titanium, and we use a laser to create asymmetric notches into them. And then we attach a wire to the tip of the instrument that is pulled proximally to create the bending. The asymmetric pattern is beneficial in this type of applications for two reasons. The first one is that the device can be bent, can be articulated with a single wire, which of course enables us to create all like these instruments in a very tiny form factor. The other benefit is that with the asymmetric notches, we can create very tight curvatures, which would not be possible if, let's say, if the notches were symmetrics, as it is the case in traditional endoscopes. And the other thing that I said we can do is we have actually developed mechanics models that enable us to create different bending geometries. And so what we did specifically for this voice box problem was we looked at simulation to find out exactly one bending pattern that was most beneficial for vocal folds and to enhance surgical access in this part of the body. What you're seeing on the screen right now is one of these simulations. The blue shape represents the anatomy of the voice box that we have reconstructed in 3 dimensions from a micro CT scan of a cadaver. And then the simulation, what is happening there is essentially like a computer moving an endoscope with an optical fiber, one of the optical fibers we have designed sticking through. And every time the optical fiber is able to get close enough to the tissue, then we simulate the application of laser pulses and the tissue turns yellow. And what that means is that that part of the tissue is now reachable, and we mark it as accessible surgically. And what we have found is that if we compare the access granted by our steerable fiber versus what surgeons can access with the traditional straight fibers they currently have in clinical use, then we can increase access nearly 2.5 times. And so in the long run, we hope that once we translate this clinically, this will help physicians treat many more patients that right now wouldn't even be eligible or for office treatment. So, and this is one of the things I'm mostly proud of. The research, we have also discussed it in a recent issue, in an article that appeared on a recent issue of the laryngoscope. Those of you who are in the ENT part of the ENT community will certainly know this journal, and they featured our research on their cover page. Now, we brought the laser into the body. Now we need to control what the laser is doing. So this is where things get interesting because, traditionally, whenever I'm talking to an audience of like a general audience, what I say is, tell me what is, in your mind, a quintessential surgeon instrument. And everybody says, of course, it's the scalpel. Well, if you're using a laser works nothing like a traditional surgical instrument, so to speak. So you have to rethink the way in which, whatever models you have in your mind of how your tool is interacting with the tissue. Just like, the scalpel will normally use mechanical force to create cuts. The laser can also create cuts, but it is doing that using a different mechanism. And typically that is a thermal mechanism. And if we don't really know how to tune the operational parameters of the laser, we can achieve completely different effects, as shown by this figure here at the bottom, which is actually taken from I forgot to add the reference here. It's actually the a handbook of laser tissue interactions by Markov Niemts. And even though I'm not a doctor, I certainly recognize that, this is not a good outcome. There is a lot of carbonization here. This is certainly undesirable. Whereas this cut here at the left seems a little bit more acceptable. So we were saying it's a thermal dynamics we are trying to work with. So as roboticists, this is something that I speaking for my communities, this is something that we are not really used to controlling. Whenever people think about robots, and this includes surgical robots, we as roboticists know very well how to control the kind of forces that the robot is applying to the environment, the forces that the robot is applying to the tissue. Why? Because, well, that's really part of our basic training as roboticists. Any roboticist, anyone with a degree in robotics these days has taken a fundamental course in robot dynamics. That's part of the core curriculum, and that's what they teach us. But when the tool that the robot is manipulating is an energy device, that type of physics that the robot is trying to control is completely different, and they don't teach us that. And that's where my research, that's the knowledge gap that my research is trying to fill. So what we're doing is we are building physical models, trying to capture the interaction between energy instrumentation, including lasers, and biological tissue, and then enabling robots to control these interactions. Those of you who have some familiarity with heat propagation or laser tissue interactions will certainly recognize the equation at the bottom of this screen. This is the traditional heat equation that describes how heat propagates in solids. And in first approximation, this is oftentimes how laser tissue interactions are modeled. The idea is that the laser is absorbed into the tissue and creates some localized temperature rise that is essentially like the concentration of heat, which then dissipates through the surrounding tissue following this equation over here. What makes this kind of thermal dynamics challenging to control, both for humans and robots, is the fact that it can be really hard to predict or to know how strongly the laser will absorb, how strongly the tissue will absorb the laser. The second equation, the one at the bottom of this screen, is giving us a very simple model of that. And the key parameter here is this mu A. What this equation is telling us essentially is that the total amount of heat that we are going to deposit into the tissue is given by the product between I, which is the intensity of the laser. So think about, increasing the power of the laser. That essentially increases the I. But then there is also this mu A, which is called the coefficient of absorption. And it is a parameter that is a function of both the type of tissue and the type of laser. Some tissues will absorb more than others, certain wavelengths. And it is really hard to know a priori what this mu A is, which in turn makes it really hard to know exactly how much heat we are adding to our tissue. And once again, I'm not the first one to describe these issues. In fact, I like to quote this review paper from Stephen Jacques from 2013. Mu A's values of the coefficient of absorption have been studied, have been documented in the literature on a variety of different tissues. But then if you have a patient in the operating room and you need to do treatment planning on them, would you be confident using a tabulated value from the literature? And he goes on saying, variations in mu A are significant, even from person to person, side to side, and even from time to time. Some lasers are strongly absorbed by the water present in the tissue. So sometimes even something like the level of like a patient's level of hydration can drastically change this value of mu A. And so how do we deal with this? This seems to be a roadblock on the way towards trying to automatically controlling these laser tissue interactions. Well, I partnered with a colleague of mine here at WPI, Dr. Andre Arnold, who is an expert in statistical state estimation. And we came up with this concept that we call virtual palpation. It's inspired by palpation that the surgeon would normally do before a before a procedure to feel the anatomy and perceive where things are. We call it virtual palpation because in this case, we're not really touching the tissue. We're using low pulse laser beams to create a thermal response and then measure these thermal responses and based on the sensor data, based on the observation of the temperature increase, we back calculate the mu A or the coefficient of absorption. And we do this using a new type of ensemble Kalman filter, which is a type of statistical state estimation method that she has developed. And we have done some experiments that we have disseminated in a journal paper that you can access by scanning the QR code at the bottom of this screen. And what we found is interesting. So there are a number of figures here, but I would say I would love you to focus on the one at the bottom left. What this plot is showing is that over time, as we are applying these laser pulses, the filter output is converging onto the actual unknown true value of mu A. So in this plot, the dashed black line is the true value of the coefficient of absorption that our filter doesn't know. We apply a laser pulse, and the solid red line is the filter estimation. And of course, the filter doesn't know exactly what that underlying value is. So it will never give us a certain measure. It will give us an estimation, which is a solid red line, with some confidence bounds, which are the dashed red lines. So essentially, it's a distribution of probability we are playing with. But over time, these confidence bounds get smaller and smaller and smaller, which means that the filter becomes increasingly confident about its own estimation. So this is very promising, and we are now working on implementing these in real hardware and doing this and validating this approach with real tissue. What can we do once we know the mu A, or at least we have a better idea what the mu A is? Well, we can control the tissue temperature. We can adjust the laser parameters, the laser inputs, to achieve consistent results, to achieve consistent heating. My PhD student, Nicolas Pacheco, recently published a journal paper where essentially what he has done is he has shown that it is possible to control the focusing of a laser to achieve controlled heating. And we do that by using adaptive control, which is a type of automatic control technique someone would use when trying to control a system whose parameters are not entirely known with certainty, such as the case of laser tissue interactions. And once again, we are really excited about the results that Nick has obtained, because we've done experiments where we have put different types of tissues in front of a robot manipulating an optical fiber. And the reason for using different type of tissues was exactly to try to create that variability in that mu A, in that absorption coefficient. Of course, the robot doesn't know anything about the type of tissue it is phasing. All the robot is told to do is to heat the tissue because maybe we want to thermally necrotize it. And the good news is that regardless of the type of tissue the robot is phasing, it is able to consistently create a temperature, regardless of the mu A, regardless of the type of tissue, with average tracking error in the order of 1 to 2 Celsius degrees. So hopefully this is showing some of the potential of these statistical estimation methods. We now are able to control very precisely what the laser is doing, even without any prior knowledge of the type of tissue or without any a priori knowledge of the control that we need to use, the parameters of the controller we need to use. Another thing we can do, in addition to heating the tissue, is also cutting it. This is a little bit older work I have done earlier in my career. During my PhD, I was tasked with creating autonomous controllers, autonomous systems for laser cutting. And the way this worked was by essentially collecting data, capturing how different parameters affect laser penetration depth, and then using all this data to build machine learning models that are going to predict how the tissue is going to react based on certain laser inputs. And so we did some experiments. Once again, this is a little bit older work now, but we did some experiments where we showed that it is possible to pre-plan incision or ablation of an entire area of tissue, and then we can let a robot do the scanning and remove the tissue autonomously. And we were able to achieve ablation accuracies of in the order of 0.15, 0.2 millimeters. In summary, I'll move on to conclusion. I'm really excited about the future of energy-based instruments. Of course, lasers are a big component of my research. One of the things I like to emphasize is that I didn't start my research just out of the pure desire of pushing lasers into surgery. I like to say that I had a time machine when I started my research in hindsight, and by that I don't mean to say that I had a DeLorean or any other type of form of time machine. I simply read papers, and in particular, I read this paper from 2007 from Steve Zeitels and colleagues at here in Boston. They are ENTs and they are here in Boston. And this paper, once again, published in 2007, reported a set of forecasts that they anticipated would have become true by the year 2020. We're in 2024 now. But it was very inspiring for me to read this paper at the time because it contained some of the elements that I have since used to create and chart my own research platform. And in particular, I would like to call out this one. They said in 2007, inevitably the advantages of fully automated surgical treatments may be achieved. For example, a robot laser for laryngeal cancer surgery could be a device capable of finding and vaporizing tumor based on programmable criteria, instructed to detect and avoid blood vessels of a certain size, and to query the surgeon where certain criteria are not met. True surgical robots will almost certainly be developed and deployed eventually. So most of my research is trying to enable this vision. And once again, the reason why I wanted to emphasize this connection with this paper is the fact that, you know, we as engineers, we can only do so much in surgical robotics. Eventually, actually, even not only eventually, but right off the start, we get lots of inputs from the medical community, and inevitably, you know, we can only have an impact if the clinical community and we engineers work together to tackle the problems that the clinical community is facing. With that, I would like to thank my team here at WPI and also the funding sources that have enabled us to conduct our research, including the NIH and the NSF. And I will be happy to take questions.
Thank you. That was fascinating, even for a vascular surgeon. So one of my questions for you is that as you start ablating and the surface properties change, like when I take an electric array, it starts off looking at nice liver, and then all of a sudden there's this big eschar on top of it. Can you compensate for that? I mean, can that be built back into the robot?
That is a great question, and that's exactly one of the elements of novelty, I would say, that we are trying to bring to fruition here. When I talked about, you know, statistical state estimation of tissue properties, and that algorithm that we are using is one that is able to sort of track how the tissue properties are changing over time. Which is, I would say, probably the main element of novelty that my colleague Andre Arnold is bringing into this work. So we haven't demonstrated this yet in experimentally. We have only done it in simulation. But yes, ultimately that's where we're headed.
Thank you.
And I believe we had one question from the audience as well. It was, how do you vent out ablation products from the airway?
Oh, how do we remove the ablation products from the airway?
Correct.
Right. So usually the way that's done is with a suction mechanism that takes. So if it's aerosols, then it's relatively straightforward because you would normally just suck the air out. If it's solids, let's say that you have tissue particles and stuff flying around. Once again, it depends on the size of the debris. It may or may not be feasible to do that with a suction mechanism. If they are like larger things, a forceps may be necessary.
Wonderful. Well, Dr. Ficera, thank you very much for joining us this morning. And again, I look forward to seeing you again soon. Thank you.
Appreciate it. Thank you.
So here to close us out in our first session, our first research session, we have Dr. Alan Coons. He is Assistant Professor up at Callert School of Computing and the Robotics Center at the University of Utah. And he is here to talk to us today about reducing invasiveness and increasing autonomy, building the medical robots of the future. Alan, pleasure to have you on board.
Thank you very much. Can you hear me?
Loud and clear.
Wonderful. All right, thank you so much for having me. I'm really excited to be speaking with you today. So one of the things that drives the research in my lab is that we're living in a healthcare crisis, and it's kind of starting now, but getting much worse. And that crisis is that there are not enough medical providers. And this is true up and down the provider chain. So there are too few EMTs, there are too few paramedics, there are too few nurses, physicians across most specialties, and particularly there are too few surgeons. And in fact, it's anticipated that by 2035, the caseload per surgeon is going to more than double. I myself am not a physician, but I collaborate with a lot of surgeons, and I promise that there is not 2 times the capability there, 2 times the bandwidth, right? And many of you, I'm sure, are surgeons and hopefully can agree. Okay, so in my lab, we look at addressing this concern in 2 specific ways. And so we look at kind of expanding the art along 2 axes. And so we look at reducing the degree of invasiveness of surgical robots or medical robots broadly. And this lets us do important things to address this shortage. One is we can get patients access to definitive or diagnostic care earlier in the disease process, implying that they need less resources in the future. And then also, as they experience surgical or interventional care, then they can heal more quickly, also consuming fewer resources in the healthcare system. The other thing that we really focus on doing is increasing kind of the level of autonomy of surgical systems. And this, we envision, will help us reduce the per patient workload of surgeons. And really what we're looking to do in my lab is kind of explore this unexplored quadrant up here together. All right, so the first thing I want to talk about is our work in increasing the level of autonomy. And I titled this talk with a component that says building the robotic systems of the future or something like this. And I really want to emphasize the future part of that. So my role here is to talk about things that are a bit further away, potentially. And so that's where we're going to go with this. All right. So as we think about automating robot-assisted surgery or aspects of it, let's look at what it looks like today. So here is kind of a typical surgical suite. These are, I believe, promotional materials from Intuitive, so it's going to be Intuitive focused. But here is the surgeon side console of a Da Vinci surgical system. The surgeon here is using these, what are functionally haptic devices, to provide commands and input to what I call the business end of the robot over here, which is interacting with the patient. And so that looks like this. And this is 1 generation old now, but many hospitals still have this system, including ours at the University of Utah. And the thing that I want you to note about this specifically is that it has 4 arms. And if we take a look back at this, I want you to note something very specific about this surgeon. And this is true of all of the surgeons I've met or collaborated with, and that is that they have at most 2 arms. And so our vision here is to take any 2 arms that are idle at a given time, which is typically the case, and automate things for those that can help the surgeon
perform more delicate tasks. So we're going to look at automating less critical, safer aspects of surgical subtasks to facilitate the surgeon doing more critical things. Okay, so as we think about robot-assisted surgical automation, there are kind of two paradigms that people have been looking at. And the first and most traditional, and where we've seen the greatest advances, and I think you've heard about some of this earlier today, is what we call the model-based approach. And so this is the very traditional way in which a team of roboticists or engineers and computer scientists and clinicians collaborate closely over the course of potentially many years to develop a robotic system and or the computational methods that make that thing work to perform some medical task autonomously. Now, this, having been involved in multiple of these, is very, very time consuming, takes years and years of a ton of dedicated effort, and then you end up with a system that's capable of performing kind of one task. And so this, as we think about the future, isn't really going to scale across different tasks. But it does provide some benefits that are critical. For instance, the behavior of these systems as they perform out in the world is predictable based on kind of the math and things behind the model-based approaches. And critically, it is somewhat interpretable, which means that a human supervising these autonomous systems in deployment eventually can do things like query the system for why it's making the decisions it's making. And so this is critical as we imagine a system that's working with human surgeons. But there's a huge problem in autonomy. And so in AI, we have something called the alignment problem. And this is functionally, how do we get AI systems or autonomous systems to do what we as humans actually want them to do? And a related concept is something that an AI pioneer, Stuart Russell, once said famously, which is, for any given incorrectly stated objective, the better a system achieves that objective, the worse it is. And so this is something that we are seeing in medical automation a lot, which is that we as engineers collaborating with clinicians write down kind of the objective functions that these robots are optimizing in order to perform their tasks. But those objective functions that we wrote down are just wrong. They are not the whole story. They're not expressive enough to account for the ways in which these tasks vary. And so functionally, people are bad at stating what they want. And this is true. This becomes more and more true as tasks get more and more complex. So that brings in this kind of second paradigm, which is this learning-based approach. And this we've seen provide hugely capable results in other areas of automation or AI. The idea here is that we're going to take data. In medical robotics, this frequently looks like demonstrations from humans performing tasks, expert surgeons performing tasks, and we're going to learn from that data. And so this lets us create one kind of computational method that then is capable of encoding many tasks as the data changes. And then we can have the system improve with more data over time. Unfortunately, though, the methods that are the most performant in this space are very opaque, which means that we're not able to get any intuition or understanding as people, typically, out of these models, why they're making the decisions they're making or how they're making these decisions. And so they're not interpretable. And really, this is frequently presented as two sides of a coin, but it's actually a spectrum, right? And so there are ways to live in the middle of this, and that is one place that my lab is exploring actively. All right, so how might we start to think about this? Well, let's look at a surgical procedure today being teleoperated by a human. So here is a surgeon doing a right upper lobectomy. So they're removing a lobe of this patient's lung. And this is just a piece of the video in which they're kind of manipulating tissue around. And so if we look at this as roboticists, as engineers, and identify the ways in which this differs from how I might think about automation in like a factory setting, for instance, Amazon's warehouse, a lot of huge differences jump out. From a perception side, from understanding the environment, it's hugely challenging. The field of view is limited. The instruments are occluding everything. Everything's shiny and smoky and bloody. Huge perception challenges. But even just in the manipulation side, the one thing I want to draw your attention to is that this lung, it's deformable, it squishes, right? And this is very different from how we've traditionally thought about manipulating things autonomously in robotics. And so the ability to manipulate deformable objects, this is the first step that we've been taking in my lab as we start to think about automating surgical tasks. All right, so the first thing I'm going to tell you about is a piece of, well, many paper series that lives kind of in this region of this model-based, learning-based spectrum. Okay, so the idea here is that we're going to take something that we call shape servoing, or the community calls shape servoing. We didn't invent the term, but the idea is we're going to look at a deformable object that we're manipulating, tissue in a medical sense, and we're going to say, what is it currently shaped like? What do I want it to be shaped like? And then what is an action I can take with my robot to manipulate it a bit closer to that desired shape? And then I'm going to do this over and over and over again. And so that's represented here. So we take the current shape here, measured as a point cloud coming out of your endoscope or some other sensor. Also, we know where we're grabbing the thing, and then we know what we want the shape to be, some goal shape. And then this machine learning-based method outputs an action that the robot should take that moves this current shape a little bit closer to the goal. And then we do it again, sensing a new shape and moving over and over and over again. And that is what you've seen kind of up here. So this here is a big neural network. And so how are we training this thing to know what actions to take to manipulate these objects? Well, we do it in simulation. So we built this method around one of NVIDIA's state-of-the-art physics-based deformable object simulators. And the idea is we put some surgical robot in this simulation. We give it a lot of deformable objects of various sizes, shapes, geometries, and stiffness properties, or material properties, so different stiffnesses, et cetera. And then we let this robot kind of wiggle these objects around in simulation a lot. And then what it does is it starts to learn how objects deform or wiggle based on how it moved its grippers, right? And then what it's actually learning is the inverse of that. So then, given a desired shape change or wiggle, what is the action it should take to get a little bit closer to that? And so that's how it works. And this ends up working really well. So here it is in simulation, manipulating objects with geometries that it's never seen before into shapes represented by these red point clouds that it's never seen before. And it does so well. It can do so with one arm. It can do so with two. Forgive the dramatic entrance of the robot arms. I think my PhD student was being extra dramatic. But that was in simulation. So how does it work on real tissue? Or not real tissue, but on real world deformable objects? We'll get to real tissue in a minute. It works really well. So if we train it only in simulation, because it's this closed loop, iterative, control-like method, even though it's working on materials that are much different than it's seen before, with physical properties that are much different than what it saw in simulation, it's still capable of accurately manipulating these objects. So here it is on foam. I don't want you to think I'm hiding any dirty laundry. So here is kind of a representative set of results. So here is the worst that it's ever been on these one-arm manipulation tasks on kind of box-shaped or pillow-shaped deformable objects and these kind of cylindrical deformable objects. And so here's the worst it's been, here's the best, and kind of some representative quartiles in between. This is one arm, here it is with two, so these are a little worse over here, but kind of some representative examples here. We can use this to do all kinds of interesting kind of tasks. So if we have the right goal point clouds, such as this, so here we have two instances of this method working in collaboration to align these two deformable tube-like structures. So you could imagine this has applications in industrial settings, but also in medicine, for instance, pre-aligning tubular structures for anastomosis, things like this. We've used this to make the robot capable at wrapping deformable things around rigid things, such as this. And then we've used this without training anymore in simulation or training in the real world. We can use this to manipulate biological tissue as well. So here is some chicken breast, obviously non-homogeneous, very different from what it's seen in simulation based on those kind of idealized deformable objects. And here it is by manually manipulating this chicken breast into the desired shape. Okay, but where are these shapes coming from? So far, what you've seen is the ability to manipulate deformable objects into a desired shape, but what shape? And that's where kind of the task comes in. So you can imagine that this is like a local controller for deformable objects, but controlling how? And so our idea is, well, let's train this controller from large-scale simulation, and then we have this capable controller that then we layer on top of this task specifications that we learn from demonstrations of humans. And so this is how we do that. And the idea is that we're going to map variations in the surgical context to how the task varied. So we're going to watch surgeons performing a task or other humans, and we're going to say, how did the way in which the surgical context presented itself to them change the way in which they performed these tasks? And then can we learn that mapping in order to capably do the task when we see new surgical contexts we haven't seen before? So the idea here, the first step toward this, is to learn these goal point clouds from demonstrations conditioned on some context, some geometric context, for instance. So here's a very simple example of what this looks like. This is just a toy example to demonstrate the concept. But the idea here is that we have some object we're trying to manipulate. Let's say that this has some attachment points that are affixing this to the surface underneath it. We want the robot to kind of lift this up potentially to facilitate this human kind of cutting it off of the thing it's affixed to. So how would you go about manipulating this tissue? We can kind of tell how one would do it based on looking at this hand. And so this is the concept. We say, all right, well, this hand, this is the context. This is telling me how I might change how I execute this task. And here's the object I'm manipulating. And then I can learn what the goal point cloud should be for this object, where this is the point cloud of this is kind of retracted back, based just on these demonstrations, right? And so then what I can do is I can plug this right into the beginning of this other method I've been telling you about. And now we get this goal that's encoding the task learned from demonstration. And then we use this closed loop control method to get the object to that goal shape. So to show you what this looks like, this point cloud now, we're going to wrap this tissue. And so now we've seen demonstrations of this wrapping task. This point cloud now looks a lot more like what it's going to end up looking like. So not exactly, but again, this point cloud was learned from demonstration, and this is a new task being executed. To show you what this looks like on that toy example, here's that point cloud. Here's the robot kind of retracting this fake tissue away, conditioned on that hand. Okay, so how might one take this kind of simple example I'm showing you here and do something useful that's more medically relevant? So that's where we took this next. And so here is our Da Vinci Research Kit surgical robot here. And what we're going to do is we're going to leverage this pipeline I was just telling you about to learn a collaborative manipulation task here. And so the idea here is that we have this chicken breast that's affixed to this piece of beef. So we have kind of multiple tissue types. The idea is we want to cut this chicken breast off of the beef without disturbing the beef. Okay, so what my PhD student's going to do is he's going to teleoperate both arms of the Da Vinci robot. And he's going to use one arm, this one specifically, to retract this chicken and tension it to facilitate cutting with the other arm, which he's going to teleoperate here. And so he's going to provide some demonstrations. You're going to see an example of one right here. So here he is teleoperating both arms. And our pipeline is watching him do this. So it's watching how he retracts this tissue conditioned on how he was kind of approaching the tissue with this cutting tool. And then it watched him do this a handful of times, and then it learned how he preferred the tissue to be retracted, or even the concept of this retraction in general from scratch. And so Oh, here is that demonstration again, sorry. So here it is now working autonomously. So he's not going to touch this arm, which is operating the retraction, and instead the algorithm is going to do that for him autonomously, and he's just going to focus on the cutting here. So here is an example of this, and so it is moving by itself. He cuts as it retracts autonomously, and then here's another example from a better camera angle, so you can see kind of from the other side. And again, autonomous retraction and tensioning here, while he then cuts this tissue off. So again, it learned how to do that to facilitate his cutting action entirely from demonstrations, and just a handful of them based on this pipeline of ours. Okay, but we've made some kind of critical assumptions about these demonstrations, notably that they're optimal. And so what if they're not optimal? And why wouldn't they be optimal? Well, it turns out that as humans, we don't really do things optimally. And before you get mad at me, let me explain this concept a bit further. So what I mean by that is, as humans, we typically do things very, very, very well, often and usually good enough, but they're not optimal with respect to some mathematical objective function that we can write down. They're just very good, good enough, and then we leverage kind of the flexibility around what good enough means to use that flexibility to facilitate other secondary objectives, right? And so human demonstrations, or even things that are happening really in nature, don't really live in this kind of optimal space. So what can we do to kind of improve this concept if we're dealing with suboptimal demonstrations? Well, what we've done is we've leveraged kind of this new burgeoning field of machine learning that looks at learning from comparisons or preferences. And so this basically says, I'm going to take some suboptimal demonstrations, and I'm going to just rank them pairwise, preference-wise style. So the idea here is just like what you've seen at the optometrist, which is better, 1 or 2, 2 or 3, 2 or 4. And then what we can do is we can start to extrapolate what made 1 better than 2, or what made 2 better than 4. And we can start to learn things that are better than any of the demonstrations we started with. And so we've applied this concept to learning kind of electrocautery policies for our robots to autonomously cut tissue off of other tissue it's affixed to. And this really opens the door to a lot of things. So for instance, these demonstrations now, they could come from surgeons, like they have been, but they could also come from non-expert humans, because this concept is letting us learn to be better than a lot of the demonstrations we were getting. We're in fact learning from the ways in which the demonstrations were not ideal. That is just more information that we can leverage than we had before, when all of the demonstrations were assumed to be ideal. These demonstrations can even be automatically generated by the robot using a non-optimal policy. So you can imagine now a robot system that's kind of bootstrapping itself into capability. So it has suboptimal demonstrations, or it has some policy that's not very good, but it's some are better than others. And then you start to learn the ways in which it was better, et cetera. All right, so how did we do this? Well, we, leveraging that last concept, we had the robot that was poorly doing this electrocautery task based on a suboptimal way to do it, exploring this in simulation, like you see here with this big suite of simulated robots. And then we leverage this pairwise ranking in order to make the real robot very capable. And so here we have an example from this paper of 6 executions where it successfully cut this tissue off of what was underneath it, and then 2 in which it failed. And again, it wasn't trained in the real world at all, purely in simulation. Okay, so I'm going to spend the last little bit of my time talking about this degree of invasiveness concept. And the idea here is that I work with a lot of microsurgeons. And if this is the state of the art in laparoscopic surgery or robot-assisted laparoscopic surgery or thoracic surgery, things like this, in microsurgery, it unfortunately doesn't look like that. So with the exception of the optics, microsurgeons are frequently operating with surgical tools that are, haven't been innovated on in a century or more. And so in my lab, we're looking to provide microsurgeons with new tools. And here's an example of one of those. And so we've been developing this surgical wrist at the sub-millimeter scale. So this is like the endo wrist that you would find on the Da Vinci robot that really revolutionized surgery there, except for at a much, much, much smaller scale. So this here is 0.3 millimeters in diameter. For some perspective, this is the corner of a penny, so that's how small you're looking at. This is a tool that they're currently using in ophthalmic microsurgery to give you an example of the relative scales. So what we do is we 3D print this as one structure on a very complicated 3D printer that has sub-micron resolution. And then we run tungsten tendons down the length of this structure that we then pull with motors on the back. And then as we pull them, this kind of can bend in any direction. It can grab things with its gripper. Here is a piece of tissue paper it's grabbing. Again, all of this is under a microscope. These little fibers are fibers of tissue paper to give you an idea of the scale. This is the bigger version of the robot. We're innovating on the gripper geometry itself to better hold these microsurgical needles. And we're innovating to make these bend very expressively. So here is the bigger version. We're getting a radius of curvature of in like the 2 millimeter range. And here's the smaller version with a radius of curvature of 0.5 millimeters or so. We can teleoperate this device. So here we've hooked it up to our surgeon side console of the Da Vinci robot. And here you see again under a microscope, one of my students teleoperating this wrist here. And then the very last thing I wanted to tell you about really, really quickly is one of our exciting new innovations here, which is a magnetically steerable needle. So I believe you heard about steerable needles from Ron Alturovitz earlier today. We have a new type of steerable needle that we're very excited about that leverages magnets for steering. And so the idea here is that we take a very flexible shaft with this 3D printed screw-like tip. We affix ring magnets behind the tip. And then as we rotate this shaft, the screw-like geometry at the tip causes the needle to go forward or backward, depending on which way you're rotating. And then we can leverage an external magnet to torque the tip of the screw and steer it as we go. So here's what it looks like in the system. Here's a sheep brain we've been doing experiments with, but let me just show you what this looks like in practice, and then I will conclude. So here we are just simulating matching the geometry of some structures in the brain. So this is the hippocampus and amygdala. This is kind of representing a potential application that the neurosurgeons that I collaborate with are particularly excited about. And so here we can steer this needle to expressively kind of cover the geometry associated with this brain-like structure. So here's what that looks like overlaid. And then if we curve this as tight as we can get radii of curvature, something in the 10 millimeter range. Okay, here are my collaborators. It's a subset because I haven't updated this in a while. So if I collaborate with you and you're not on this and you're watching, I apologize. If you're not watching, I don't apologize. Here are my students and funding mechanisms. And with that, I'll take questions.
Presentation to round off the more basic science. I'm going to give you a throwaway line that one of my mentors used to say, that the art of surgery is the art of traction and counter-traction. And you're taking this to a whole nother level. So congratulations on that. So as we dissect, sometimes these tissue properties change. I mean, how does the robot account for that? And obviously, intuitive are now starting to build haptic feedback into it. What are your thoughts about how this is going to impact surgical practice?
Yes, so two things are at play here. One is, how will this impact kind of the traditional teleoperation aspect of surgery? And then as I think about the automation side, which is really where I live on the science, how will this notion impact that? And I can't speak as much because, for instance, haptics affecting teleoperation is not my research area, so I can't speak too much of that first piece, although I imagine it'll provide capability and a lot of signal to these surgeons. But I can speak to the second piece, which is, as the surgeons are experiencing these forces and moments, as they're interacting with the tissue, as that changes how they perform the tasks, then our methods can use that as additional information to say, all right, well, the surgeon's thinking about tension in this case in a very specific way, conditioned on what they're observing in another very specific way. And so we view that as, in my lab, a very exciting increased capability that'll let us collect more expressive data and learn more capable things.
Well, once again, let me thank you from everyone here. That was a very stimulating presentation, and I'm sure we'll be in touch. Thank you.
Wonderful. Thank you so much.
So we're going to transition now onto clinical applications, particularly featuring some of the experts who are here at Methodist Hospital. So I want to introduce the people that were joined and have joined us in the studio. On my left is Dr. Ramirez. He is the chair of OBGYN and another expert in robotics. To my right is one of his faculty members, Dr. Suri, who you're going to hear from a little bit later. And then we're going to kick it off with Dr. Bavari, who's one of my partners. For a long time, I've thought we've missed the boat. I hate watching other people having their hands on great technology that I don't get my hands on. So we kind of decided we were going to try and focus this, and Dr. Bavari is going to tell you about that journey.
Thank you, Alan. Great to be here. Welcome to our panel. So I must say I am not the expert on this one. Well, I would say I'm an enthusiast because I'm somebody who is trying to make headway into getting robotics into vascular surgery, where a field where none of us have really put our foot into it. So what about vascular surgery, where minimal invasive surgery was actually founded for aneurysms by Frank Veith, Juan Parodi, and Michael Marin? They had placed a stent graft, essentially a graft which is a polyethylene material, and they put a stent inside that, deployed it, and so it's taken off at a whole new level with EVARs, or endovascular aneurysm repair. But we know that these things have pitfalls, and they have secondary procedures, re-interventions. So we know Dacron has been, since Dr. DeBakey invented the Dacron tube graft, or manufactured the Dacron tube graft, it's been one of the most dependable repairs for an aortic aneurysm. Why not, like all our other open surgical colleagues, gynecology, urology, thoracic surgery, why not give patients the minimal invasive approach in vascular surgery? So there has been some work, not in the US, but abroad, mainly Peter Stadler, and then some work in the US with Judith Lin, initially, who started off with collaborating with urologists to see if we can do vascular surgery with the robot. And currently, these are the places where we can apply robotics for vascular. Aortic aneurysms, occlusive disease, endoleak. So you see there is a lot of stuff that we do as open surgeons that we can do with the robot. It just question is then why aren't we doing any more, or why aren't we doing more of them? So endovascular surgery has taken over aneurysms and aortic occlusive treatments. Fewer patients are getting open aortic procedures, and then fewer surgeons are training for them. So robotic assisted laparoscopic procedures, they need some laparoscopic and robotic skills training. And mainly the laparoscopic training is not so much how to handle the instrument, but how to set up the case, because it's all about the setup. If you don't set it up right, everything goes, the angles are all awkward. There is a deficit with the integrative vascular programs, and likely better with the 5+2, where people have done general surgery training and then come into vascular surgery. So there is no robotic vascular surgery training programs for the surgeons in practice in the US currently. No proctors for robotic vascular procedures, and hence we are not doing any more. Operations are also not very high volume cases like urology, gynecology, and general surgery, who operate in the abdomen or thoracic surgery in the chest every single day. We don't do open aortic cases every single day. There is an initial high cost of robotic systems and instrumentations, but then it's offset due to reusable equipment. We don't throw away stuff as much as we used to. There is a definite learning curve, but also not as steep for traditional laparoscopy. This is where the spark had started, where Dr. Lumsden had come into a conference saying this was a case presented at a vascular meeting. Dr. Money is the one who presented it, but then said that, well, I didn't do the procedure. It's a urologist who did the procedure. So then we said, well, if a urologist can do a vascular procedure, why can a vascular surgeon not do a vascular procedure on the robot? So I established contact with Intuitive Surgical. They said, you start simple. Think of cases that are currently done more frequently. So they said, we cannot support vascular surgery, but we can support general surgery. So if you're doing a general surgical procedure, yes, we can help you with that. So I identified people with peritoneal dialysis catheter who needed lysis of adhesions and ventral hernia repairs, who've had previous abdominal operations. And initially we had said, okay, you cannot get a PD catheter. But this is a lifestyle change for them. Hence, I started doing these procedures. They were low risk, they were standard procedures, and there was cross-training was easy by general surgeons. So the impossible became sort of possible. And then I was told this should be my motto, that I should be committed, not just interested, because you just cannot say, okay, I have an interest in robotics. You have to be committed to doing that. We made a proposal with Dr. Miles, who is the chair of the robotics committee here. He said, okay, we shall formulate a plan for you. And this was the plan. So start some basic training with Intuitive, then start doing case observations with an independent surgeon and in a facility where I went to Austin for that. I had to have 5 proctored cases with an external proctor, and then I would be certified to do robotics, but only for general surgery. Then I would have to train at some high volume center, or at least visit a high volume center, where I identified Prague, where Dr. Stadler, who has done the most robotic cases in vascular surgery, exists. And then we would have an IRB for some porcine model for vascular anastomosis. And now we've come to a point where we would now identify our own IDE, or investigational device exemption. So I went through this training in March 2021 through August 2021. So I did some certification, I had case observations, I did a wet lab, and then we did some cases. My first case was actually a lysis of adhesions and placement of a PD catheter. This is my crew, my first crew for robotic surgery. On the same day, I was called to the GYN OR, where there was an injury to the external iliac artery. And I went up there saying, okay, can I help this? And first of all, every vascular surgeon goes in with the intuition that, okay, give me a knife, give me some forceps, give me a needle and a driver, and I'll help with this. I said, okay, can I do this sitting on the console instead of trying to open up this patient? So Dr. Kamath, who was the surgeon there, she said, how many cases have you done? I said, 1. When was that? Today. So she almost fell out of a robotic chair out there. So, but I went in, got control of the vessel. I was able to put a U stitch, and the bleeding was controlled. And on that day, that gave me validation that, okay, this can be done safely, robotically. So vascular surgery is not out of the realm for us. And so we started doing the basics of robotic training. I finished my cases. I did case observations. I also went to University of Chicago in Illinois to train on the robotic kidney transplant program, where they have a porcine model and an inanimate model, where they tailored the program for me just to do vascular anastomosis. The next step was to go to Prague last year and visited Peter Stadler, who has written the last review out of the country, and I'll come up to our review, which was done here. He has about 600 plus cases of all kinds of aortic cases, no venous cases, but a lot of aortic, abdominal aortic cases. This was the crew, and then there are 3 other surgeons. These are 2 of them who actually operate in tandem, and they know these are high-risk procedures. They have to be done with a certain process, one after the other, the same way every time. Our further steps would be to acquire some laparoscopic vascular instruments, for example, clamps, and we've done that. I identified potential cases like the ovarian vein and renal vein transpositions. I took the help of the urologist to see how we can set them up, because this was the key. And our biggest volume here right now for aortic cases has been lumbar and inferior mesenteric artery ligation for type 2 endoleaks, which then takes away multiple radiologic CT scans and embolization attempts to get to this. Also attempted a partner here with Dr. Lei, who is our vascular surgeon here. So she's also on the training program. Mighty with the lab we are trying to see if we can incorporate the C-arm with the robot when we can do venous cases accordingly. My aim is to keep up the skill set doing PD catheters. So far, this is our volume that I have. A few ovarian vein transposition, renal vein transposition, and a rib resection. The biggest volume has been lumbar and inferior mesenteric artery ligation, filter retrieval, median arcuate ligament release, and then the lysis of adhesions and PD catheter. I don't think we have time for a video, but this is what we want to say. Okay, so if you want to do robotic surgery, how do we do it? So read our review. We recently came up with our robotic assisted vascular surgery literature review, clinical applications, and future perspectives. This is in the Journal of Robotic Surgery, which is open access for everyone. Currently, if we want to do this, there is no program that is offered by Intuitive for training, and the integrated vascular residents don't have much exposure. But like I said earlier, the incoming fellows are much trained. We need training pathways to enable other surgeons to do it. Right now, we don't have any FDA clearance, but there is clear interest from Intuitive to start getting vascular surgery from into their paradigm. But there is no FDA support. So, what could we do? This is what we are planning to do is, because they don't support vascular surgery, we need FDA approval. Da Vinci platform is not approved by the FDA. So we have proposed IDE, which is an investigational device exemption for robotic vascular surgery. We would concentrate on a few cases like vein transpositions or lumbar artery endoleak ligations to help get the skill set up and running. And this would enable people to be cross-trained under our umbrella and maybe even conduct courses for other surgeons in practice. And then submission to FDA, hopefully get approval. And there is a lot of interest from France and Japan who've invited us to see if this can be done. And once the FDA does it here, I think other countries will follow suit. There is a lot of training that has to be done with Intuitive. I think training at MIT would be ideal once we have our IDE up and running. The future for us is I think our Walter Tower operating rooms are very well supported by robotic as well as the endovascular hybrid platform. We are planning to integrate them to see if we can bring robotics and hybrid together. The education channel is, we have more than 100,000 subscribers. People have written to us with an interest to see robotic vascular surgery more and more. And MIT is a great training facility. As we are all here at the Bookout Symposium, the Mirren Institute would be a great platform for us to jump on this one. I would like to thank Stuart Core for this. I have a little video. I don't know if you all can see it, but this is what JFK said at the Rice Stadium.
Why choose this as our goal? And they may well ask, why climb the highest mountain? Why 35 years ago fly the Atlantic? Why does Rice play Texas? We choose to go to the moon. We choose to go to the moon. We choose to go to the moon in this decade and do the other things, not because they are easy, but because they are hard.
I think that's what our motto is. It's not because it's easy, but because it's hard. We want to do it right. We have a lot of acknowledgements for my enablers, my proctors, and I would just end with this: committed, not just interested, and hope to give you more and more of vascular surgery with robotics coming up in the years. Thank you.
Excellent job. All right, so we've got time for questions if anyone wants to send them in. So Charo, what do we need? What are the missing pieces, and why have we languished in terms of surgical robotics? Because there's another thing we were talking about this morning, catheter robotics is a whole other world that we can be involved in.
I think three big factors. One is the acceptance by vascular surgeons that robotics can be applied to vascular surgery. There is a lot of inertia to say, okay, this is slow, this is not safe, this cannot be done. I think that was one to accept. Secondly, lack of FDA approval for Intuitive to help other vascular surgeons get enabled to do this. And I think third is the lack of trainees and exposure to actual procedures to get this up and going. Like I said earlier, we don't operate inside the abdomen every day. We don't operate inside the chest every day. So our volume of cases also is not as much to say, okay, here are 50 cases at the end of 2 months. We don't have that volume.
Dr. Ramirez, since we got you in the studio.
Yes, sir.
Do you join tubes together? I mean, robotically, I'm trying to see. I'm a big believer that the solution to my problem is somebody else's toolkit, and by and large do it every day. We just don't even talk to one another. So, do you join fallopian tubes together with a robot?
Yeah, so it was a routine practice for many years. Certainly, particularly in the area of reproductive endocrinology and infertility, particularly for patients that had a prior tubal ligation and they wished to get pregnant again, and there was an interest in reanastomosis of the fallopian tubes. But I think that as the increasing popularity of IVF became a solution to that challenge, then it's become less and less. But yeah, I mean, technically, can it be done? Yes.
Very interesting. Mm-hmm. We had a vascular robotics summit in which we had asked various specialists to come and show us dissection of the pelvis, and you couldn't come that day. So you sent your second year resident to show me how to dissect all the way down on the pelvis and the internal iliac. She did a beautiful job. And so,
I might say she's married to a vascular surgeon.
I know that, but
so by osmosis.
Yeah, but I think it was remarkable to me that somebody early on in their training could do such a good job dissecting out blood vessels.
That's right.
She's way ahead of, except Charo, most vascular surgeons in the United States. And so it's not going to be a huge journey in order to be able to pick up that particular skill set.
I would say, a segue of that saying that listening to Min Kim, our chief of thoracic surgery, when I approached him and Dr. Lamson approached him about robotics, the first thing he said is, this is not laparoscopy. This is actual surgery with your own hands. You're just extension of your hands inside with those instruments. Plus now you have bipolar at the tip of your index finger and thumb now. It's so wonderful. So it's actually not laparoscopy, but it's more your hands inside the belly. You just need to know how to set it right.
Well, the other thing about, sorry, go ahead.
No, I was going to say that, obviously that this level of dexterity that has been added with the robotic systems has allowed for us to even perform better dissections, particularly certainly when we're looking at lymph node dissections around the blood vessels, the common iliacs, the external iliac, internal iliac, and the many branches of the internal iliac. Obviously the visualization, the dexterity provides for a much safer approach, and particularly also when we go up to the periotics for the periodic lymph nodes as well.
So, if ask Charo to dissect out the aorta open versus the robot, he'll lose less blood with the robot than he does with open. It's funny because it's a completely different technique that you use, and I don't know if these robotic techniques have made the leap into your open practice. It hasn't happened in vascular surgery yet.
Right. Yeah, it's interesting. When we used to perform the radical hysterectomies through the robotics approach, it was a common finding that the surgeons would comment on the fact that they were doing much more extended dissections, much more safer dissections with significantly less blood loss, because I think it's the element of the visualization and the dexterity of the instruments at that fine level of definition around the structures.
Yeah, so the thoracic surgery group reports up at our service line meeting. They drive us crazy because we have cardiac, we have mortality, we have vascular, we have mortality. The thoracic surgeons can go for a year here with no mortality, length of stay less than anticipated because of the robot. But they're doing the same operation that they did before. We haven't invented an entire new specialty called endovascular procedures, none of which works in the same degree of efficaciousness, if that's a word. The thoracic surgeons are doing the same operation and have transformed really what the outcomes, are. My mother-in-law had a lung cancer resected with a robot. She's 78. She was up and walking around within 2 days. And so it is truly remarkable how rapidly people can recover from this.
I think from your talk, I think it's fascinating and very inspirational for what you're doing. I think it was people, I've been doing robotics since 2010 when I was in my training. Dr. Ramirez was one of my mentors when I was in residency, and I remember watching him do robots and training like, wow, this is, 2007, 2008. But it took people like Dr. Ramirez and other people in that generation to push the envelope and say, we can do this, and it takes a lot of leadership that you have to do that and to bring about this change in your department, in your division, in this hospital, and hopefully a lot of other places in this country. So that's really, really great. Another thing is now I know that if, I have a vascular injury, touch wood, I can call you in and I can know that you're not going to maybe make a big open incision. You'll be able to do it robotically, which is wonderful.
You know what's embarrassing? Is we were called once for an injury. I wasn't called, I think.
He can blame me. He's been very nice to me. I was the one who was called. This doesn't happen very often. It sounds like it happens all the time. Can I tell that story?
Yeah, please.
So, came up to the operating room and the robot was docked, and the surgeon said, hey, I got a big problem, and can you fix this? Got out of the chair. I went, no, I can't fix it. You mean you want me open? She said, give me the knife. No. I think you can fix it with the robot. I said, I can't fix it with the robot. Now, that's my job in this institution. And I was summarily dismissed. in a nice way. He said, I think we take care of it. And so these were kind of the things that to me were, number one, the renal vein transposition was done by a urologist. Number two, we have a robotic kidney transplant program here. The last time I checked, that was an arterial anastomosis, and the venous anastomosis, and the ureteric anastomosis. And most vascular surgeons can't do it. And then I got dismissed by somebody who because I couldn't stop. Didn't have my hands on the tools to stop the bleeding. So these are all kind of the aha moments. Said, man, we got to figure out how we get involved in this. So my question, I'm dealing with the naysayers at the moment. How did you deal with the naysayers?
Well, it's interesting. I think because our field went from open surgery to laparoscopic surgery, and then of course, obviously, to robotic surgery. And I think that having had that additional cushion of the minimally invasive training, it was an easier transition from open to laparoscopy to then robotics. And then, of course, obviously, it was a significant improvement in terms of the technology, the dexterity. So then, therefore, there were many who were more embracing. However, obviously, as you mentioned, there were some naysayers in that when this new technology comes on, obviously then the potential for the associated additional cost and then the access to the robot, as obviously you often would get a case that you could schedule the next morning at 8 a.m., but if you wanted the robot, you could be waiting 2 or 3 weeks. So, certainly for them, it was an opportunity to then use that level of skill and the training that they had already acquired through minimally invasive surgery, starting to see the results with the robotics approach, with the robotics technology. And then, of course, obviously, the institution seeing this growing interest, both by clinicians and patients, then there were obviously more tools that were available to those surgeons. So there were more units that were available to the surgeons. And then, of course, obviously, then that was that transition into accepting it.
So let me ask you a question. In GYN, do the residents still get trained in laparoscopic GYN, or are you bypassing this and going straight to the robot?
Yeah, it's always a conundrum, right? Because the residents, as naturally trainees, they would like to get exposure to every single potential approach. However, obviously, from the trainers, the surgeons, there's decreasing level of expertise in laparoscopy. Oftentimes now the residents know that they're much more marketable when they are graduating by saying, well, I have robotics training and I'm going to be able to provide the same level of skill that obviously somebody else in the institution is able to provide through a robotics approach. And then often, I talk to the graduating residents and I say, when you're out there in the job market, how many times are you asked, are you able to perform a laparoscopic surgery versus are you able to perform robotic surgery? And of course, typically it's the second.
Interesting. Yeah. So if you've got a case tomorrow where you're going to use the robot, and they go, sorry, the robot's not available. Dr. Bavari took it away.
I'll
cancel the case?
I'll find a robot. No.
But you wouldn't do it laparoscopic.
So I was trained both laparoscopic and robotic. When I did my fellowship training, it was the bulk of it was robotic training. Now, personally, I can do laparoscopic surgery. I get called in sometimes to help general gynecologists with laparoscopic surgeries, the complex surgeries. So I can get around it. I'm sometimes not the happiest when I'm doing it. And I always say, well, I think in 11 years that I've been here, I've booked 2 laparoscopic cases. But I do laparoscopy in terms of if I were to get called in, I've done enough robotics and I have enough caseload experience that I can get around with doing it laparoscopically, but obviously my preference is going to be the robot.
So 5 years from now, is anybody going to be doing laparoscopic GYN surgery?
I think in the United States it is very different than if you were to look outside of the United States, and that's when you get into obviously the point of low resource settings. For many countries, obviously I have colleagues who are incredibly proficient in laparoscopic surgery. They don't have access to the robot. Yep. So outside of the United States, I think there will still be the case. I think in the United States, the overwhelming majority most likely will be robotics.
So do the Europeans hate your message about robotic surgery? I guess
some of them welcomed it.
That's a good segue into your topic, which is going to be about the ideal framework for surgical robotics, because we need standards and we need ways of evaluating it, and you've really led the charge from the U.S. standpoint. So, Dr. Ramirez.
Excellent. Well, thank you so much, Alan, again for the invitation. It's really an honor and a privilege to be presenting here at the Bookout Center Symposium 2024. And thank you for allowing me to share this discussion. And what I'm going to speak about is the ideal framework and discuss a little bit about what the ideal framework is. But certainly in principle is a structure and evaluation of a systematic assessment of how robotics, and not limited to robotics, but how new surgical technology is integrated into the standard of care. So the ideal collaboration is actually a group, it's a multi-specialty group of surgeons, and it's actually based out of Oxford University in England. IDEAL stands for Ideas, Development, Exploration, Assessment, and Long-Term Follow-Up. And what the IDEAL framework entails is a systematic evaluation of surgical technology, of robotics technology. In other words, how do we come from the point of the development and the technical expertise in robotics engineering to actual clinical care, the standard day-to-day integration of robotic systems into our clinical practice. So I'll speak a little bit about the robotics development and evaluation from different perspectives as it pertains to the actual device and how those devices should be evaluated, from the clinician's perspective as to how the clinician incorporates that new technology into their practice, and also obviously from the healthcare system and how do we make that an equitable and equally accessible tool for most healthcare centers. And then of course, obviously, very, very importantly, with any new technology, robotics or any type of surgical technology, the patient. Because obviously the patient bears the benefit of the technology, but also the patient is the one who may bear the harm of a technology that has not been appropriately integrated. So I want to speak about a little bit about the ideal phases of robotics evaluation. And many of us are very familiar, particularly those in oncology like myself, are very familiar with how medical therapeutics get integrated into the standard of care. We know about the phase 1 trials, the phase 2, ultimately the phase 3 randomized trials, and the phase 4 trials as to how a new medication will come into play into the standard of care for our patients. But oftentimes we don't see the same sequence of systematic evaluation in robotic surgery. Often it is the experience of a pioneering surgeon who starts doing these procedures, who then goes and certainly teaches other surgeons. Other surgeons will start publishing on their experience, and then ultimately becomes an accepted technology without really having the proper, thorough, systematic evaluation of how this is integrated. So again, I'll speak about the perspective from the device and in terms of how the device has been systematically evaluated and safety and efficacy. And that's critically important because obviously, as with any new tool that we put in our hands, we want to make sure that actually has gone through the proper evaluation to make sure that it actually does what it aims to do. From the clinician's perspective, obviously, it is important that any new tool, technology, or robotics that is brought to the clinician's operating room, they need to know, is this really going to add any benefit to me? Is it going to add any benefit to the patient? How am I going to integrate this into my clinical practice? Or do I just keep doing exactly what I've been doing through the experience that I've had in this procedure? And then, of course, obviously, from the patient perspective, is it acceptable to the intended patient group? And is it an acceptable technology and tool that will be able to achieve the same approach in a safe manner through this new robotics technology? And then ultimately, as I mentioned, through the systems perspective, is there really a need for this technology? Should we really integrate this in our hospital? And of course, obviously, this is often a question that comes up from our hospital administrators, and particularly when this is a costly technology, how do we really incorporate this, and is there really truly a need? So with that, the different phases of the ideal framework are really based into different domains. And this is the first domain is the first 3 stages. The stage 0, which is the clinical, preclinical evaluation of the technology. In other words, has this robotic system has undergone a thorough evaluation of the actual engineering of the technology that it entails to make sure that this is actually safe to even expose a patient to this new technology. So that's the first phase of this evaluation. And of course, obviously, we know that through industry's development of this new technology, obviously there is a thorough evaluation prior to the exposure on in-human and first evaluation in our patients. And then subsequently, obviously, the first phase, stage 1, is the proof of concept, first in human studies. In other words, this is the initial exposure of our patients to this newer technology. And I'll speak a little bit about the specifics on those. And then the development. In other words, as we start gathering data on this new technology, what are some of the things that are critically important? So as it pertains to this first domain, these first 3 stages of evaluation, from the perspective of the device, obviously, we need to evaluate what has been published on the technology, what is the evaluation that has been performed on that tool, and then also what is the initial clinical data that we're seeing from the implementation of robotics. And of course, obviously, we've seen this in many areas of surgery. When the robotics technology is introduced, there is the initial reporting on a case series of patients that have been exposed to the robotics approach for a particular procedure. In this phase also, it is critically important to document any changes to the device. And oftentimes, obviously, industry will reevaluate and consider that we need to make changes to some components of this new technology, and that's obviously critically important as well. And then, of course, the reporting is very, very important on the first in human studies. From the clinician's perspective, it is important to define and analyze what is the integration into that practice. How is this clinician going to be using this tool to really enhance what they are already doing, either through patient outcomes or through perioperative metrics of improvement in that particular area? And then, of course, obviously, now another thing that we haven't really talked about, up until this point, we have not been dealing with autonomous robotics. Oftentimes, obviously, we are used to the robot is only going to reproduce the actual movements of the surgeons. But as we now go into a new era of robotics and technology development, there is obviously artificial intelligence and machine learning. And how do the autonomous robots, how are they going to be evaluated for reliability? And how are we going to assess when is it a time to hand over from robot back to surgeon? And what are the reasons for a human having to take over in the autonomous system? And then from the patient's perspective, of course, is to ensuring a transparent process. And when there is this initial integration of the technology, is to actually have a discussion with the patient. This is the first vascular case that I'm actually doing on the robotic system. For the patients to be aware that there's a process of evaluation, there's a process of an initial learning curve, and they need to, of course, obviously understand the risk associated with that as well. And then, of course, obviously, this is the beginning evaluation of the early economic modeling and assessment of the cost effectiveness of any new technology. Ideally, obviously, of course, trying to prevent research wastage in this particular setting. The second domain is once we have provided information as to the safety, and it's important to highlight the safety and the reliability and the consistency of this type of technology for a particular procedure, for a particular field of surgery, then that's when we get more into the exploration and the more thorough evaluation of this type of technology for a particular field, for a particular procedure. This is the prospective cohort studies or the randomized controlled trials, where we're looking and evaluating the new technology in comparison to prior approaches to these procedures. So again, looking at the device perspective, one needs to prospectively now evaluate the risk and benefits through this prospective data collection to assure that this is, again, a safe approach for our patients. Certainly from the clinician's perspective, there has to be validated tools and qualitative research exploring human factors. How is this impacting the surgeon? This new technology, is it making it better? Is it making it worse? Is it really providing a benefit to the patient and to the patient? And also, of course, obviously, the real world experience. This is where we actually start gathering the evaluation of learning curves. How long does it take for me to actually perform this procedure safely? And then, of course, from the patients, understanding that now this is a more formal evaluation of this new technology, and then continuing through this prospective assessment to evaluate the economic impact and have the stakeholders that are critical in the success of the implementation of this new technology. And then lastly, of course, obviously, once the technology has been accepted as this is safe, we have data, we know that actually it is either equivalent or superior to how we had it before, then it's gathering long-term data on these technologies. And of course, is the long-term monitoring of high-quality data, transparent data, customizing to accommodate dynamic nature of artificial intelligence and autonomous robots. From the physician's perspective, of course, this is where we need to start looking at how do we train the next generation of surgeons on this new technology? How do we continue to revalidate and make sure that those surgeons that were the pioneers are still actually continuing to see ideal results and safe results for our patients? And then, of course, obviously continuing to measure the adverse events that come along as we continue to expand on that learning curve. And then, of course, obviously the development of registries and long-term monitoring, and we can speak a little bit about how that is done, but it's important to continue to capture data. So oftentimes you see that surgeons will publish their initial experience of 30 cases or 100 cases or 200 cases, but then after that it's sort of like, obviously, these are results that are favorable, these are the results that we're consistently seeing, so then therefore I'm not going to continue tracking the data for my patients, and of course, obviously, it is critically important to continue tracking that information. And then, of course, obviously, continue to evaluate the impact on patients with patient-reported outcomes, quality of life of this new technology. And then lastly, of course, continuing to evaluate the cost effectiveness and engaging, of course, in the setting of low resource setting, engaging with leaders in those areas to see how this new technology is offered to patients in those settings as well. And that's critically important because obviously then by not doing so, there may be an inequity or a disadvantage with regards to patients in high resource countries getting a type of approach or a type of technology that is of much higher quality and potentially of better results surgically as well. So it is critically important to continue to evaluate that and assure that this type of technology is available to all patients as well. It's a lot of information, obviously, to cover within the course of the 15 minutes or so, but anyone who is interested in looking into the specific details of the ideal framework and the evaluation of this systematic integration of robotics into clinical practice, I would invite you to read a recent publication that our group had in the journal Nature Medicine outlining all of the details of this evaluation. So with that, thank you.
Thank you. Lots of questions coming in. So tell us about the ideal group. Do you have any money?
I'm only on the council. But yeah, so the ideal group is a group of surgeons, multiple specialties, so vascular surgery, colorectal, gynecology, orthopedics, and their aim is to provide a framework for the evaluation of any type of new surgical technology. And as you see, it's a systematic evaluation where there is a methodological process.
Beyond robotics.
Beyond robotics.
Okay.
That's right, exactly. Even beyond robotics. And of course, obviously now, one of the new areas that we focused on in our last annual meeting was the integration of artificial intelligence, the autonomous robotic systems that now, obviously, some of the new technology is providing an opportunity for surgeons to sort of play the role of the pilot, and the robot is on autopilot, and the surgeon takes over whenever there is an issue of safety. But otherwise, these robotic systems could potentially and will potentially perform a major segment of the procedure on their own.
So there's a lot of discussion this morning about autonomous robots. And so if that feeds into the next question is, where's the FDA on this? I mean, do you guys engage the FDA? Is there any beyond ideal from the FDA? At the end of the day, we're going to depend upon them.
Yeah, right. And I think certainly there is a focus on the evaluation of the robotic system, and also from the FDA that they are now creating groups where this is a part of the evaluation, because there's many issues related to the autonomous robots. It's not just the interaction with the surgeon. It's also an element of training. It's also an element of when do you actually perform the takeover? When does the surgeon then really make a decision, this is the point where I need to take over? We often speak about how, there are some of us who, regardless of what we're seeing in front of our car, and noting that perhaps an alternative road is a better option, you still follow the GPS because you trust that GPS actually is telling you the fastest way of getting home. And when you provide that level of just handing over that decision making to another process, then as a surgeon, when do you start then making that decision as to, I need to take over now, versus I trust that it's going to continue the right path in this difficult area of dissection? So that's obviously going to be very interesting. And also, if you then integrate autonomous robots as part of your standard, then what does that say for your own experience?
Yeah. Do you have any questions?
My biggest question about autonomy on robot is there are so many anatomical variants that we have in general. Say in your field, a hysterectomy; for our field, say median arcuate ligament release on the celiac axis. There are so many nuances that we keep telling ourselves, oh, I should be careful here, I should not do this way, or this patient is different, and we see it. Mm-hmm. So where do you think the autonomy would be, and where do you think that the surgeon would have to take over?
Yeah, I mean, I think that, as I see it, and of course, obviously, I do not claim to be an expert on autonomous robots, but as I see it, when we started learning about the computer systems that would beat a world chess champion because, it was faster, it could think, those systems were systems where you actually had to integrate every single piece of information into that system. Now it's very different. The autonomous systems is you just show it what the rules are and it learns on its own. So then with procedures, then it's a system where certainly it continues to learn from previous procedures, from other feedback, from other procedures, so that then it adds that level of expertise. So in other words, if you have your own experience as a vascular surgeon, you have only the number of cases that you perform as your own experience.
True.
But if you have a system that is taking in input from numerous hospitals on a daily basis from around the world, and is continuing to integrate that into its frame, then it's not the experience of Dr. Bovary, who may have performed 500 vascular robotic cases. This is the experience of a system that has thousands and thousands of robotic cases, that has seen every single vascular variation, has seen every single approach to that procedure.
Do you see that with that aspect of it? Obviously, there are going to be some positive viewpoints, in terms of AI, kind of helping with these procedures. But what about the negative pitfalls in terms of like your own experience, surgical training, training residents and that sort of thing? That's always something that's, in my mind, a little scary. Like, Is this good or bad? Are the machines taking over? Is this a good or a bad thing?
Yeah.
And how do we find that balance before we give them too much autonomy?
Yeah. Well, I mean, I see it as, as an example is the way of, do you find it as a bad thing that you can pretty much go anywhere in Houston, even places you've never been to before, very easily by just putting in the address, and you're going to go straight there, versus trying to figure it out and trying to ask around and get off the gas station and ask the attendant at the gas station, how do I get to Sugar Land? And is there a downside to that?
Yeah, it's a good point.
So I told the story this morning, but I'm going to repeat it again because I'd like to hear your response. And it was an engineer who was in a Tesla. It was on autonomous driving mode. The thing went haywire and he ended up down a canyon in California. And so he was being interviewed, and they expected him to be furious. And he said, no. They said, I'm an engineer. There will be failures, but pursuing this for the public good, there'll be dramatic benefits from this, even though there are failures along the way. Can we survive those failures in medicine?
Well, I think we already are. I think that I was reading an interesting book about patient care and quality of patient care, and hospital-based and physician-based errors caused the equivalent number of deaths as 2 747s falling per day, every day. And we just seem to be moving along because this is sort of part of the standard. And I think, point to that point of the engineer, that's where I think putting in a framework of really thoroughly evaluating technology where you actually assure safety at each point, and particularly safety before it leaves the factory, to make sure that actually that is very thoroughly and appropriately evaluated. And then again, of course, obviously, then there's going to be the combined issue of the system failure plus the surgeon's inability to actually attend to a fall.
Mm-hmm. So one of the questions that came in was, what's the best way for clinicians to engage basic scientists interested in this field? You have computational scientists, mechanical engineers. I don't know if that's something Ideal has thought about.
No, I mean, I think, the Bookout Center is a perfect example of that, certainly. And I think that this is a great opportunity that we have here where we are engaging with engineers from across the street at Rice University constantly, or from engineers that come to us from NASA, or engineers that come to us from other areas of industry, where they need to see what are our needs and what are our concerns and what are the tools that we need in our hands to provide a better surgery, a better care. And for physicians to get involved, I think is critically important, because again, the engineer, oftentimes they will tell you, I can build that, but I need to know what is it that you actually need. So I think that having that dialogue of the surgeon, physician with the engineers, it'll definitely provide us with much better tools.
You have any other questions? No? Okay.
I'm just stunned by the 747 falling from the sky.
Yeah.
That's impressive, the amount of...
2 a day.
That's not good.
No.
All right, so we move on. We're running a little ahead of schedule. No, we're right on schedule. Dr. Suri, talk about innovations in robotic surgical training.
Wonderful. Well, I wanted to thank everyone. Thanks for the Bookout Center for the invitation to speak. My topic is going to be innovations in robotic surgical training. I've been here at Houston Methodist now for almost a little bit over 11 years, and I'm one of the gynecologic oncologists, and I would say I do a lot of robotic surgery. Since I've been here, I started doing robotics back in 2010 when I was in my training at UNC Chapel Hill, and Dr. Ramirez was one of my mentors when I was a resident at MD Anderson Cancer Center. So this is something that's important to me. I think I work with a lot of the residents. I have a second year and third year resident on our service, and we do a lot of surgical training. And there's been a lot of changes in surgical training. I think when 10, 12, 13 years ago, when I was in my training, sitting at the robotic console, there was just maybe your attending yelling at you and saying, stop, don't do that, do this, what are you doing? And not the greatest feedback, but that's how we learned. Or there was a DVD-ROM with the procedure on it, and I would watch it every day to try to learn that procedure, which worked really well. But I think as we're moving forward with more and more robotic surgeons, not just gynecology and urology, we're working with general surgeons, vascular surgery, cardiothoracic. I think the number of robotic surgeons, even at this institution, has grown so much since I've been here, that the training aspect is important, not just for residents or fellows, but for established surgeons. There's still a lot of surgeons that have been in practice that did not want to, partake in robotic surgery, that are now seeing the benefits and want to learn. So when you look at robotic surgical training, you look at the three components of the robotic system. You see, the console is what the surgeon sees in the middle, and then the video data is what the surgeon sees in terms of the screen, and then now coming up forward is the kinematic data, which is how the surgeon moves. And now it's going to be, how are we performing these procedures? How can we give feedback to the trainees, the physicians, about how to best perform their surgical procedures? One thing is integrated intelligence, and this is stuff that's available here at Houston Methodist, and there's some stuff that's available now, and there's a lot of stuff that's coming down the road. The biggest thing is the Intuitive Hub, and that's been available here at Houston Methodist now for a little bit over a year now. And then, and that's a system where you capture and connect, and so this allows seamless, recording of your surgical procedures just at the press of a button within the operating room. And the next step is the Intuitive Discover Insights, which allows the surgeon to access procedural data, case video, and case insights, so they can give themselves their own feedback, look at all the information that's being collected on a case-to-case basis, and learn. And then also Sim now, which is going to be available down the road, looking at activated learning, where surgeons are able to build and maintain their skills and share expertise with others. So the Intuitive Hub enables virtual collaboration, providing connection and learning between surgeons. So you're able to record your case. You can interact with remote observers through all portions of the case. If I am performing a surgery here at Houston Methodist and I need Dr. Bavare's help and he's in his office, if he has access to the Intuitive Hub on his computer, he can dial into the surgical procedure, see exactly what I'm seeing, and tell me what needs to be done, or if what input he may have, or if I'm going to be getting in any trouble. Another thing is this may impact proctoring. So if you have surgeons that need proctoring for robotic privileges, they can, the proctor can be logged in a couple of 100 miles away and are able to proctor the cases without having to be present in the OR at the same time. So what data-driven insights can make possible? It can quantify and elevate the surgical skills of the surgeon, help reduce surgical variability, and then also one of the biggest things is improve quality and safety so that we're training the best surgeons out there. So one big thing is the Intuitive Case Report. So this is an app that's on, you can get it through Intuitive on your phone. I have it on my phone. And it actually just gives you operations of your practice. So anytime you log on to the robotic console as your name, as your surgeon, as your password, it quantifies that data on what case you're doing. It can check in and monitor and manage your surgical practice and provide quick snapshots of basic procedural instrument data. Case Insights is coming down the road where you're able to explore your personal performances on each case. It allows segmented video review, historical video analysis with comparison to hospital reference, and you're able to kind of look at your metrics to understand your surgical performance. So this is looking at the Intuitive app. This is just kind of like a quick look at it. You could see that it can provide how many cases you've done, your procedural types. This is from a general surgeon, and it allows you to see your time on each case, your average time, what the US average is, and then it kind of looks at your performance trends as well as your workflow. So you can access any particular case if it's recorded, and you can access the video anytime as well. If you look at workflow trends on each case, it can look at different portions of your procedure, like the exposure, dissection, transection, reconstruction, and it gives you the amount of time or the percent spent on each portion during the procedure. That way you can look and see, well, on this gallbladder or this hysterectomy that I did, I spent this amount of time, obviously knowing that there's going to be variability between the cases. And so it can give you a lot of that feedback that way. Another good aspect is that it can record your videos and you can access your videos as well. And so looking at this upcoming video, I'm not a general surgeon, so this is looking at a cholecystectomy. It's able to look at your procedure and then analyze things in terms of all your kinematics. It can look at your force feedback, which is available on the DV5. It can look at how many times you clutched your camera, your instrument motions, your efficiency, efficiency of your movements as well. And you can kind of go and look at your clinical segments, consoles and surgeon, look at all the different instruments you used, and then with the newer robots, looking at how much force are you applying. And it'll actually calculate that and give you, this is too much force or this is less force. Obviously, that can impact safety in any surgical procedure. And so this is, if you look at, let me kind of go forward, features at first access. So you have to log into the Intuitive account at the surgeon console. It can give you all the instruments all the data that we discussed. And then, so if you look at case videos, it looks at automated and manual bookmarks, duration of your case, endoscopic clutch counts, hand controller clutch counts, instrument timelines, how many times you change the instruments. And then if you look at phase, it can look at, like, let's say you're doing a cholecystectomy or ventral hernia repair. It can give you and look at the phase specific, like how long it took you for the exposure, how long it took for the dissection, the transection, and the extraction of the specimen. And then obviously you can look at steps that are procedure specific. I work with residents, and if they want to see how long it took them to close the vaginal cuff at the end of a hysterectomy, it can provide that information so that the residents can look at their data and say, okay, well, it took me 20 minutes at the start of my second year, now it's taken me 4 minutes. And they can look at that data and see their improvements in their skills. So there's a lot of deep integration enabling unique insights with looking at system events and kinematics. So this is on the left side, it's a radical nerve sparing prostatectomy, which I do not perform. This is on the video. And then if you look at on the right side, oh, sorry, let me go back. If you look at the right side, it can show you the kinematics that are being recorded by the system itself. May not be coming up. Let me see if I can get that again. Is it coming up now? Okay, good. And so it can look at, yeah, there it is now. So you can look at, how often, how much is your camera moving, the tool that it's in your right hand, the tool that's in your left hand, and the retraction tool. So it kind of looks and sees how efficient you are with your motion. And then obviously that can impact on, how safe are you operating? Are your instruments visible? And it gives you that real-time feedback, which is all coming down the road. And so you look at objective performance indicators. This is the last slide. So if you kind of the same thing, if you look at the prostatectomy, the top one is looking at an experienced surgeon, looking at bladder mobilization, seminal vesicle dissection, some anastomosis, and lymphadenectomy. You can see that the kinematics, the motions are a lot more efficient. They're a lot more tighter in this specific range. Whereas if you have that inexperienced surgeon, you can see that the motions are a little bit more out of the range that you want. So surgeons can track their training from when they did their first case to down the road and see how well they're improving. And this obviously gives hospitals feedback, gives other surgeons feedback, gives your attendings feedback, all for educational purposes and hopefully creating more efficient, better surgeons on the robotic platform.
Well, I posted a thing which said terrifying and exciting all at the same time.
Yeah.
So it's. Yep. Do you do video review in your residence? I mean, does somebody sit down and look at the robotic cases and go, "Hey, you're not very good. You need to improve on this."
So in the up until we got the hub, I have a few videos of a hysterectomy that I've recorded, like a nice simple hysterectomy. Literally, the residents have it on a DVD. They're like, "Yeah, I'm gonna just watch that video over and over again." And they do that, and they do a great job doing it. But now with the hub, we're able to record all the cases, and I can sit down with the residents and say, it does take time. It does take time to, hey, we're going to do this. I can sit down with the residents and say, this is your side of the hysterectomy. This is what you can improve on. This is what you did great on. So providing that feedback is important. I think as an attending, you have to make time to do that. Mm-hmm. But also, this provides residents, fellows, surgeons to look at their own feedback and look at their own videos and see, okay, was this a good move or not? So it just makes things a lot more easier and efficient, and the residents have access to their videos. So literally the nurse just has to press record and it gets automatically filed under my name in the system.
One of the other things also that I think is helpful is particularly for us where the residents are sitting at the console and performing the procedure. I often will ask them to look at the video before the day of surgery, so that not just so that they will get familiar with the approach to the procedure, but also so that they will have a better understanding of the instructions that I'm giving them. When I say, move the instrument this way, use this other instrument, move the specimen to this side or that side, that they have an understanding rather than just like blindly, like, what does he mean by that instruction?
So all of this video goes to Intuitive?
No, it stays on the hub, and Methodist has an account. So it stays in the system for about 30 days. And then after that, it gets deleted. So it doesn't go under the residence names. It goes on every robotic surgeon here. All the attendings can have that, and they can access their videos. But it stays there for about 30 days. You can save your favorite videos as well. And there's a little link on the side if there's a surgery going on in Sugar Land, the doctor needs my input. If I'm at a computer, I can log on and get onto that and see what they're doing in real time and give them input.
And then the other thing is also that is very useful for us, particularly now, when collaborating with other institutions on surgical trials. As an example, we have a trial that is open now on sentinel lymph node mapping, and it requires that we send them unedited videos of our procedures before they give us approval to actually come in as a surgeon. So it's not even as an institution, as a surgeon. So I may have passed, and Anuj may not, and then he needs to keep sending videos until the committee approves.
So when you say collaborating with somebody, like for example, somebody calls for help, say in Sugar Land, what are the medical legal implications of such a call? Because I'm sure in today's day and age, everyone's looking at, okay, where is it going to go wrong and what's going to happen? Yeah. So
that's something that needs to be explored, I think. I think from that's something that if it's, I think for the intraoperative console, usually it's like an institution-wise. I think if you were to keep it at Methodist. In Sugar Land, it would be definitely a little, that's a very important question. Be like, you're not there, you're not really seeing it. But that's something that definitely we need to look at. Yeah.
Are there any devices that are robot-specific in the GYN field that have been developed because you're doing robotic surgery and said, hey, we could do this if this device was invented?
No, I think that it goes back to your question as to having a discussion with those who are designing the tools, and oftentimes when they say, well, now you use a manipulator as an example to manipulate the uterine specimen. So then, of course, obviously that's very unique to gynecology, and that comes specifically to gynecology, where you can say, well, now through the robotics technology, then I can from the console also manipulate the uterus, or a particular, I'm sure with vascular, a particular stapling device that is just unique to that procedure.
It used to just be, monopolar scissors and bipolar graspers, and I think for the last 8 to 10 years they have now vessel sealer that some of the gynecologic surgeons use. There's also something called the sinker seal, which bipolars and cuts at the same time. So they used to have a robotic, I think harmonic, but I don't think that's been used anymore because it doesn't articulate. So there have been a couple of little bit advancements, just overall, not just specific for gynecology, that have come about over the last 5 to 8 years.
Okay. All right, shall we move on? Next is actually a video, and it's going to be by Dr. Ye, who's the director of the Robotic Living Donor Liver Transplant Program here at Methodist, and she's going to show us a video on minimally invasive living donor and liver transplantation.
Okay, and we're back, and I'm delighted to introduce my next guest in the studio, Dr. Yili Chia, and she's here today to talk about robotic and minimally invasive living donor liver transplantation program, and she is director of the Robotic Living Donor Liver Transplantation Program here at the J.C. Waller Jr. Transplant Center, Houston Methodist Hospital. Yili, pleasure having you in the studio.
Thank you very much, Stuart, for the invitation.
Love to learn more about this.
Yes, I'm very excited. Thank you for inviting me to join the Bookout Center Symposium. The title of my talk today is Robotic and Minimally Invasive Living Donor Liver Transplantation. So liver transplantation, what is our need and the solution to our need? So the numbers of liver transplants in the United States. By the end of 2022, about 12,000 people were on the waiting list for liver transplantation. And throughout the year, about 12,800 was added to the waiting list. So on average, daily, 35 people were added to the liver transplant waiting list. Now, of all these people that were added, about 1,095 have died throughout 2020. That means about 9% of people on the waiting list died in 2020. And that means about 3 patients die every day while waiting for a new liver. The number of patients that are removed from the liver transplant list for being too sick for transplantation is about 10%. And a third of those people will eventually die within 60 days of removal from the list. So for patients that are living in Texas, how many of them will get a new liver within a year of listing? It depends a little bit on this thing called the MEL score, which is a way we calculate how severe their liver disease is. The worse the liver disease is, the higher the MEL score is. So a MEL score of 30 to 40 are like some of the sickest people on the waiting list. And in Texas, about 62% of them will get transplanted within a year of being on the waiting list, whereas the rest will actually pass away. Now, for people on the bottom of the waiting list with a MEL score that are lower, 15 to 24, the majority of them within 1 year are still waiting for a new liver. And even about 16% of them have died while waiting for a new liver, even though their liver disease is not that severe. So what is the solution? Well, new livers come from 2 sources. One are deceased organ donors, and the second one, living donors who can donate part of the liver to someone in need. The majority of organs in the United States come from donors who are brain dead or donors after circulatory death. And only about 5% of liver transplantations are performed from organs donated by a living donor. Most of these are from people who are related somewhat to the donor, but there are a significant number that are from patients who are not related to the recipient. So what is living donor liver transplantation? For a living donor, what's going to happen during the operation is a portion of the liver will be removed. Say in this picture, on the right side, on the left side of the picture, the liver will be split in the donor between the left lobe and the right lobe. And the right lobe will then be moved to the recipient's room and be implanted into the recipient after their bad liver comes out. This is basically what living donor liver transplantation is. Living donor liver transplantation, or LDLT, is possible because the liver regenerates. And we've known this since the story of Prometheus of Greek mythology. He was punished by Zeus for giving mankind fire, and he was kept locked to the side of the mountain, and an eagle would eat his liver every day, but the liver kept regenerating at night, and he suffered there for centuries until he was freed. Scientifically, we have proven that about 1 year after donor surgery, the liver volume has regenerated to about 90 to 100% of the original volume. So the advantages of LDLT is our recipients do not have to wait until their MEL increases before receiving a transplant. It is an elective procedure. The surgery is scheduled for a time when they are sick enough to justify transplantation, yet in the best possible clinical condition. The living donor undergoes a thorough and full evaluation, and the cold ischemia time, which is the time between when the liver comes out, is put on ice and flushed with preservation fluid, and when the liver is sewn in, is very short. Therefore, there are very, very little degradation of liver cells due to the short time on ice. Disadvantages of LDLT, well, of course, the donor has to undergo major surgery, which is of no physical benefit to themselves, and all the attendant requirements of major surgery, including a recovery period, loss of income, scar from incisions, and there are risks associated with living donor surgery, including but not limited to bleeding, bile leak from the cut surface of the liver, bile duct injury to the remnant of the liver that stays behind, infection either in the abdomen, the wound, lung, urine, etc., thromboembolic disease, which is DVTs in the feeder or PEs, and inadequate liver regeneration leading to insufficient liver function. Well, I can tell you that in the world, the powerhouses of living donor liver transplants are in Asia, particularly South Korea, India, China, Japan, and Saudi Arabia. Whereas in the West, only about 5 to 10% of liver transplantations are performed with an organ donated by a living donor. But we do know that LDLT decreases waitlist mortality both in the US and Canada. It offers transplants to patients in very low MEL states, and it improves survival compared to deceased donor liver transplant for some of our patients. So who is the living donor? Well, a living donor is a healthy individual who is willing to accept risk in order to save a life. For instance, this was one of my patients. This is a 19-year-old young man who met his high school friend during a reunion and realized he was on the waiting list for liver transplantation, and immediately filled up a questionnaire online and volunteered to be a living donor for his friend. Donor safety, therefore, is paramount, and donor well-being should be optimized. In terms of evaluating the post-donation quality of life for our living donors, 15% of donors do report donation-related issues or symptoms, including hernias, problems with scar tissue and adhesions, and 22% could not perform physical activities as well. 47% reports limitation in abdominal strength, 21% limitations in vigorous physical activity, and 19% limitations lifting significant weight. And that probably is explanatory because traditionally our incisions for living donors are as pictured above. On the right side, either a T scar or a big L scar. In terms of symptoms post-donation from incision, donors have reported keloid scars, rib pain mainly because when we have to do it via the open incision, we have to retract on the rib cage for hours to expose the liver, as all our livers are protected by the rib cage, and also incisional discomfort. So in order to try and improve these symptoms that are reported by donors post-donation, we have gone from a maximally invasive approach to donor hepatectomy to an upper midline incision, which is what we currently do for our open procedures, and then to laparoscopic or robotic surgery, which I will detail coming up. Now, in terms of evolution of minimally invasive liver surgery, and I'm talking about robotic or laparoscopic approach to liver resections, laparoscopic liver surgery started in the 1990s. That's the blue line. And numbers didn't really go up until 2006 and 2007, where there was a huge increase in the number of laparoscopic liver resections performed worldwide due to improvements in laparoscopic instruments and improved training in places that do a lot of laparoscopic liver surgery. Whereas robotic liver surgery only started in the 2000s, probably with the second generation of the Da Vinci robot. But over the last 5 to 10 years, those numbers have exploded as well. So the first laparoscopic donor was a relative that donated their left lateral segment, which is part of the left lobe, to their child, and that was reported in 2002 in France. And it was performed by Dr. Chouki, who is a very famous laparoscopic liver surgeon. He reported 2 cases. The duration of the operation was 7 to 6 hours, but there were no complications. As you can see, the incisions are very small. The graft was extracted using a Fenner steel incision just above the pelvis. The first laparoscopic hybrid donor right lobe was performed in 2007, 2008. Now, right lobe donations are more technically challenging than left lobe donations because the right lobe is bigger. And it was reported again by our colleagues in Chicago and also in South Korea. And what they did was they performed part of the procedure laparoscopically and only made a slightly bigger incision in order to help with parenchymal transection and then removal of graft. The first totally laparoscopic donor right hepatectomy was reported in 2012, by Dr. Soubrain in France. The duration of operation was 8 hours and there were no complications. Again, 4 small tiny incisions followed by an extraction wound just above the pelvis in the suprapubic area. This first series of laparoscopic donor right lobes was reported after the invention of the 3-dimensional laparoscopic camera in 2015. And the benefit of this camera is that it could also be articulated, so you could see over the dome of the liver or around the hilum to get a better view of the structures that you need to be preserved and dissected. So the largest laparoscopic donor series is a multi-center study from South Korea, where the average duration of operation was 340 minutes, and complications overall was 10%, and serious complications, which are Clavien 3 or 4 complications, of only 4.9%. These are much better than open results previously reported. And in looking at the recipient 3-year survival, it was 86.7%, which is excellent. Now, when it comes to robotic living donor liver surgery, as I said, the robotic evolution started much later than the laparoscopic evolution. But in 2012, Dr. Giulianotti in Chicago reported the first robotic right donor hepatectomy in the world. The duration of operation was 8 hours. The EBL was very low, 350 mils. There were no intraoperative complications. However, 6 months post-operatively, the donor actually had portal vein stenosis, which had to be treated with interventional radiology dilatation. And I think since this report, interest in robotic donor hepatectomy cooled down a little bit until 2016, where the first series of totally robotic donor right lobes were reported by Professor Poda Chen in Taiwan. And then since then, multiple centers have reported series of robotic donor hepatectomies worldwide. This is basically another approach to provide minimally invasive surgery to our living donors instead of laparoscopy. In the United States, there have been some growth in series of robotic living donors from centers including at Leahy in Massachusetts, Methodist here, Baylor in Dallas, VCU Virginia, Columbia and Cornell in New York. In terms of all the single centers, they have reported very good outcomes. Of course, these will be highly selected patients performed by highly skilled and trained surgeons, and the outcomes are better, if not equivalent, to previous open donor outcomes. This is the largest single center series, and this is the largest center of robotic donor hepatectomy in the world. It is in Saudi Arabia, and they reported 501 cases. They've done over 1,000 now, with very, very low morbidity rates. This is a study that compared open versus laparoscopic versus robotic donor hepatectomies by our friends in Korea. They compared 52 robotic versus 62 open versus 118 laparoscopic cases with PSM. And overall complications for robotic hepatectomy showed no difference between the 3 approaches, and serious complications also revealed no difference between the 3 approaches. Now, the learning curve for laparoscopic donor hepatectomy has been shown by our Korean colleagues as to be around 60 cases, which is meant to say that after you have done about 60 cases, then you can achieve a comfort level with the procedure where your times and complications actually go down for this specific procedure. We recently got a paper accepted to Liver Transplantation Journal. This is a multi-center trial between us and our Korean colleagues, and we studied the learning curve for robotic living donor hepatectomy using a standardized technique. So this is our operating room setup and port placement for robotic donor hepatectomy. The robot ports are arranged usually at the level of the umbilicus. There are 2 laparoscopic ports, and the extraction is again through a suprapubic fenestrial incision. And this is our standardized technique where we organize the operation into structured steps, and the steps are consistently performed in a similar manner. The first step is falciform dissection, where the liver is freed up from the diaphragm at the top. Second is the hilar dissection, where we have to isolate the right hepatic artery and the right portal vein. Step 3 is a retrohepatic dissection where the liver is then mobilized from the diaphragmatic and posterior abdominal attachments. Step 4 is demarcation between the right lobe and the left lobe using ICG enhancement. You can see the bright area is the left lobe, and the right lobe is not being enhanced because I've clamped the right hepatic artery and right portal vein. And this is where we're going to split the liver between the right and the left in the parenchymal transection. Parenchymal transection is where we split the liver, and this is done without any inflow or outflow control for donor hepatectomy because we want to preserve blood flow both to the remnant and the graft that is to be donated. Once most of the parenchymal transection is done, step 6 is bile duct division because the right hepatic duct has to be transected as it will be anastomosed to the recipient. And then once everything is done, the graft is procured. Now, we presented this technique at various societies, including ILTS, SAGES, and IHPBA. So in looking at our demographic data, what stands out, of course, is that our patients are very different compared to South Korean patients. Our patients are larger with a higher BMI and a higher weight. Most of our patients had alcohol or autoimmune disorders as etiology of the liver disease, whereas it is hepatitis B in Korea. In terms of right lobe graft, because of the difference in size of the donors, the grafts are different. Our grafts are much bigger than Korean grafts, about 857 versus 749. In terms of perioperative data, we had slightly higher EBL compared to our Korean colleagues, but our average EBL was only 286, which is very acceptable for donor hepatectomy. Warm ischemia time was short in both centers. And most of our patients would tolerate a regular diet by post-op day 2 to 3. In terms of complications, overall risk of complications was 23.3%, and there was no difference in the rate of complications between us and our Korean centers. And that is the same for Clevin 3 or more serious complications. And in looking at the learning curve for robotic donor hepatectomy, Center 1, which is our Korean colleagues, analysis showed that they took 17 cases to achieve their learning curve, and whereas for us, this was analysis of our first 15 cases, we appeared to achieve the learning curve after about 9 cases. So that was much better than the laparoscopic learning curve, which was reported to take about 60 cases. So we started the transplant HPB robotic program at Houston Methodist in 2023, and we increased the number of robotic liver and pancreas resection and transplant procedures from 8% to 61% in 1 year. From January 2023 to June 2024, our surgeons have performed 500 plus total and 300 plus HPB procedures, and the Methodist program has performed almost 150 total robotic procedures, of which 78 are major HPB procedures. From September 2023 to now, which is about a year when we started living donor liver transplantation at HMH, we have performed 13 living donor liver transplantations, of which the robotic approach was used in about 54% of donors. So in conclusion, minimally invasive living donor hepatectomy is feasible in specialized centers with a deliberate standardized approach. I believe laparoscopic and robotic approach have similar outcomes, but the robotic approach probably has a better learning curve, needing a smaller amount of cases to achieve mastery, but may have increased cost considerations. And in order to achieve mastery in the robotic platform, we need to use adjuncts such as simulation, proctoring, and very careful prospective monitoring of outcomes and operative performance. Thank you very much.
Okay, well, thank you for that very insightful overview. I got a few questions here, right? So I did notice in the graph there was a bit of a dip in 2016 when you were comparing the robotic versus laparoscopic approaches. Was there any reason for that dip? I know you said there was one earlier, right, in about 2010 or 12 or so?
So the first robotic donor hepatectomy, even though the early outcome was good, eventually the donor needed another procedure to fix a problem with the portal vein that got a little narrowed. And I think since that time, a lot of donor surgeons were a little hesitant to keep pushing the envelope that way. And also, you know, we were probably waiting for better robots to come around. So I think 2012 was probably when the second generation was being used, or the third generation, and now most people are using the fourth, if not the fifth generation.
Got it. I guess this goes into other questions. So remind me again, what's the percentage of living donor versus deceased donor liver transplantations?
Well, in North America or in the United States, it's about 6% living donor versus 94% deceased donor.
So my question is going like, how can that needle be shifted? How can we get more living donors? Is it a matter of education? Like maybe someone's out there and they actually want to donate, but they just don't even know this program exists. So what are the main bottlenecks?
I think you're right, because as you know, compared to kidney donation, which is very much well known, everyone knows you can donate one kidney because you have two kidneys, right? So that's pretty acceptable, and you know, people are relatively educated about that, but not many people know that you can actually split the liver into two and donate half of it, and both halves will actually grow back into a whole liver.
Do you think there's ever a day where the majority of liver transplants are done with living donor?
I don't think there's a need to in this country, to be honest. There's definitely a need in Asia, where 90% of their liver transplantations are done from living donation, because culturally they don't favor deceased donation. But in the United States, you know, we should push both deceased donation and living donation, because there's just too many people on the waiting list, and there's too many people who get too sick or die while waiting for a new organ.
Got it. And I know it's a small percentage, but are you saying that the living donor program, the outcomes are better? So the better if it's living donor?
It's a little bit of comparing apples and oranges, because living donors generally donate to people on the bottom half of the waiting list, so they're not like the sickest people that we have in our surgical liver ICU here. People that we have in our surgical liver ICU who's on multiple medications, intubated, has renal failure, they need a full liver, you know. But people on the waiting list who probably never reach the top but still need a liver transplant because they're not working, they're confused half the time, they have ascites that's collecting in the belly every week that needs to be drained, and the MEL score just doesn't go up. Those people can be saved by a living donor.
Got it. And I think you said it takes about 60 cases before you're very confident and comfortable where you can start decreasing the time of the surgery, etc. Do you want to give a few comments on what current methods are used to train the surgeons? Are they cadaver models? Are they simulation, like digital simulation models, or is it a synthetic kind of cadaver model or benchtop?
I think the 60 cases are for laparoscopic donor hepatectomies, and that is a very difficult procedure to be done laparoscopically. But you know, some of our Asian colleagues are very skilled in laparoscopic liver surgery, therefore they can do it. In terms of robotic donor hepatectomy, I think one has to be already have already mastered the open part of the procedure, so that you're not trying to figure out how to do the donor hepatectomy and then how to do it robotically at the same time. So I had already, you know, mastered open donor hepatectomy for years before I started going to robotic donor hepatectomy. And after that, the transition between the open technique and the robotic technique is actually quite I don't want to say it, but intuitive. So, because the movements of your hands is very similar using the robot compared to using open. And if you compare it to laparoscopy, laparoscopy is very, very different and requires very different movements.
Got it. And two more questions. So what's the main complications for intrasurgical these procedures? Like, what's the main?
The one that we all worry about is bleeding. Because there's a lot of blood vessels within the liver. The liver has two blood supplies going into the liver and then one blood drainage system. Therefore, when we split the liver, we don't want to come across, you know, a big blood vessel that you can't control. Every little blood vessel needs to be clipped or tied before we cut through them.
Final question. So it's kind of going back to the very start on how you actually, basically the MELD score, right? So. Yeah, I know there's companies out there that are using AI to better predict the uptake or utilization of a donor organ for a patient. But that would actually kind of really allow you to rewrite the MELD score, like completely flip it on its head. So to say maybe potentially this liver shouldn't go to the most sickest person, it should actually go to this person because the AI algorithm has kind of predicted that. can you maybe comment on any technologies you've seen that are addressing that, or even just any other algorithms or thoughts?
I think each program probably has their own, I wouldn't say algorithms, but protocols about the sickest people and who we would accept as a transplant candidate. Mm-hmm. And then we will also have enough experience using various different graphs to see which graph is suitable for which patient. And there are just so many parameters that you have to consider when it comes to graphs. It's not just size, it's how fatty the graph is. Mm-hmm. Was there downtime in the donor that the graph was a little ischemic, and then because you're going to give them another ischemic hit. And you know how unstable the recipient is when you put the graph in, because if they are very unstable, then the graph becomes even more ischemic, and that will affect graft function. So I think AI sounds like, you know, it's very promising mm-hmm. to try and put all this data together and come up with an actual algorithm, but I don't know how feasible that is at this point in time.
Okay, got it.
Yeah.
Well, thank you for your time today. It's wonderful.
Okay, thank you very much.
Thank you all.
Well, that was fascinating. And so at some point in time, we got to go from the removal of that liver to the implantation of the liver. And that will really impact my world, because we need technologies that let us use the robot to join blood vessels together, join bile duct together. And so that's a challenge really that's out there. So I'm joined in the studio now with two people, Dr. Laura Kim from otolaryngology, who's going to give the the first talk, and then Dr. Kaufman, who is from plastic surgery. As you can see, describe robotics as a young person's sport, not for people like me. And so we're going to kick it off and hear a little bit about single port and natural orifice robotics. And we're going to kick it over to Dr. Kim. Thank you.
Perfect. It is a true honor to join everyone at the symposium today. I'm Laura Kim, a head and neck surgeon, part of the otolaryngology department at Houston Methodist. I will be discussing how head and neck surgery has and is evolving with the advancement of technology. I have no conflicts of interest other than my interest and enthusiasm for robotic-assisted surgery and technology to better serve our head and neck cancer patients. Today, I will be discussing transoral robotic surgery and virtual surgical planning. My true goal of today is to bring awareness, share my excitement, and ultimately stimulate ideas and collaboration in further enriching the field of head and neck surgery through the advancement of technology. First, we'll delve into the role of robotics in head and neck surgery. To a greater degree than many other surgical specialties, the barrier to advancement in otolaryngology has been the inability to directly examine and access the anatomy in a living patient. It is a field in which progress has been limited not by physiologic knowledge, but more so by the pace of technological advancement. As early as the 6th century BC, there are documents recording nasal examinations via nasal tubular speculums crafted from bamboo shoots. Since then, the field has been driven forward by pioneers who skillfully adapt new technologies to intricate anatomy of the ear, nose, throat, and neck. A light conductor introduced by Dr. Philip Bozzini, the father of endoscopy, is the first internally lit device used to inspect cavities of the human body. The head mirror by Dr. Hoffman and the Hopkins endoscopes are instruments that we are more familiar with. Fast forward many years, and the modern-day otolaryngologist is equipped with a range of tools, including the microscope for the otologist, endoscope for the rhinologist, laryngoscope for the laryngologist, and for the head and neck surgeon, the Da Vinci robot. One of the most dramatic transformations in the accessibility for the head and neck surgeon is in the recent development of transoral robotic surgery, or TORS, for oropharyngeal tumor resection. Given the difficulties associated with accessibility, difficulties with airway management, and concern for hemorrhage, surgeries of the oropharynx have been slow to develop. Traditionally, tumors of the oropharynx have been resected via an open approach, which can be very invasive, as shown here with the mandibulotomy, which involves splitting the lower jaw to gain access. The first robotic system introduced was the Puma 560. In 1992, the Da Vinci surgical system was developed, and in 2000, it was approved by the FDA for performing head and neck oropharyngeal procedures. In the early 2000s, Dr. Weinstein and Dr. O'Malley successfully demonstrated how the Da Vinci surgical system can be used for oropharyngeal cancer resections. In 2009, the Da Vinci Xi surgical system was introduced, featuring improved dexterity and visualization for complex head and neck surgical procedures. In 2014, the single-port robotic system designed for transoral procedures received FDA approval. In robotic surgery, the surgeon's hands are physically separated from the patient, the robotic instruments engage with the patient's tissues, and the surgery is aided by a bedside surgical assistant. Surgery is performed in a virtual environment, allowing the surgeon to interact with the patient's anatomy with a novel perspective. Advantages of TORS compared to traditional open surgery in the head and neck include: 1. Improved visualization and access to otherwise difficult to access areas with enhanced detail. 2. Reduced surgical morbidity, such as in blood loss, and faster recovery times leading to shorter hospital stays. 3. Potential for improved functional outcomes exists, such as in speech and swallow. And 4, there's the potential for reducing treatment toxicity by avoiding or de-intensifying post-operative treatment, for example, with reduced radiation and chemotherapy. Patients with the most potential for deriving benefit from TORS is in those with oropharyngeal cancer. And within this group, the subtype that is driven by the human papillomavirus, a group of patients that is increasing in incidence. These patients have a favorable prognosis compared to the non-HPV related oropharyngeal carcinoma. As such, there has been modifications to the American Joint Committee on Cancer Staging System. Recently published and ongoing trials are helping to define the role of transoral robotic surgery in oropharyngeal cancer. Evidence to date supports the use of surgery as a valuable tool in this group of patients by allowing to 1. Reduce the extent of surgery, 2. Avoid or reduce post-operative treatment with a lower radiotherapy dose and field, and 3. To avoid or reduce chemotherapy, all of which would reduce treatment-related morbidity for the patient. Standard treatment for head and neck squamous carcinomas was defined before the HPV era. This includes radiation treatment of 60 grays in the post-operative adjuvant setting and 70 grays in the definitive curative setting. Adjuvant platinum-based chemotherapy is recommended for patients with high-risk features. And patients that present with metastatic lymph nodes without an identified primary site would receive wide-field radiation to all potential primary subsites of the pharyngeal region. Needless to say, this is associated with short and long-term toxicity, including dysphagia, xerostomia, fibrosis, with a large impact on the patient's quality of life. This is an example of a patient who was able to avoid radiation treatment altogether and in turn minimize short and long-term radiation treatment effects such as dysphagia and fibrosis. This is an otherwise healthy 57-year-old male who had presented with an enlarging neck mass. Further workup revealed the diagnosis to be HPV-related squamous cell carcinoma, however, without the primary site identified. Treatment options for this patient included radiation, targeting all potential primary sites, or to proceed with the diagnostic and potentially therapeutic TORS with neck dissection to address the metastatic lymph nodes. He ultimately underwent a diagnostic and therapeutic TORS surgery. Through improved access and visualization, we were able to identify the primary site, which was less than half a centimeter, and resect the tumor from the base of tongue with clear margins. A neck dissection to address the metastatic lymph nodes were completed at the same time. Based on final pathology, he was able to avoid any adjuvant treatment. He was able to tolerate an oral diet postoperatively and was discharged home the next day. By week 1 following surgery, he was close to his baseline function in terms of speech and swallow. This patient's case demonstrates the value of TORS in low-risk HPV-related oropharyngeal squamous cell carcinoma. Even when patients are to undergo postoperative treatment, the use of TORS may help reduce treatment toxicity. There are multiple trials examining the use of TORS in early-stage disease to reduce treatment-related toxicity through de-intensification of adjuvant treatment. Not to go into too much detail, but we'll touch upon a key trial to demonstrate this point. ECOG 3311 is the largest trial of TORS and transoral surgery. Patients, after undergoing surgical treatment with TORS, were stratified into groups based on features found on pathology: low, intermediate, and high risk. Patients in the intermediate group, for whom the standard of treatment would have been 60 grays of radiation, were randomized into two arms, a standard treatment arm and a reduced radiation dosage group with 50 gray. The results showed that 3-year progression-free and overall survival were comparable between the standard radiation dose group and the reduced dose group. As such, de-escalated adjuvant radiation of 50 grays is now included as an option in the National Comprehensive Cancer Network guidelines for early-stage oropharyngeal cancer patients. Also, in comparing this trial to the outcomes in non-surgical trials of definitive radiation or definitive chemotherapy, the 3-year outcomes are comparable or better. In the intention to treat analysis, patients who received reduced dose radiation were statistically more likely to have stable to improved quality of life than patients who received the standard dose. A secondary analysis with modified barium swallow found significantly lower aspiration rates at 6 months in patients randomized to reduced dose radiation. There are ongoing efforts to study the role for de-intensification in postoperative treatment with the use of TORS. Further questions remain to be answered in how to best individualize the use of TORS and de-intensification of postoperative treatment. Also, data comparing long-term outcomes from treatment toxicity need to be elucidated. Ultimately, the ideal treatment for each patient must be determined by evaluating the data, individual factors, and through shared decision-making in a multidisciplinary setting. However, TORS has been proven to have potential in greatly improving the quality of life of our patients as they navigate their treatment journey. There are, however, areas for improvement. Current robotic systems may have limitations in terms of fine motor control and dexterity, which can be challenging for delicate head and neck anatomy. Robotic surgery often involves the loss of direct tactile feedback, making it more difficult for the surgeon to sense the tissue properties and apply the appropriate force, which may be especially relevant in tumor resection. The size and configuration of robot arms can also limit access to certain anatomic areas in the head and neck and may obstruct the surgeon's line of sight during surgery. Although a great improvement has been made with the advent of the single-port robot, exposure and setup often remain the most difficult part of the surgery. Setup and docking process for robotic systems can be time-consuming, which may impact the overall efficiency and workflow. Lastly, robotic surgical systems require significant initial investment and ongoing maintenance costs, which may limit their widespread adaptation, especially in resource-constrained healthcare settings. Future directions for improvement in robotic-assisted surgery may include: 1. Continual development of more versatile, precise, and miniaturized head and neck surgical procedure, or miniature robotic system designed for head and neck surgical procedures. Incorporation of advanced haptic techniques to provide surgeons with enhanced sensory feedback, enabling more precise and dexterous manipulation of delicate tissues. Integration of real-time imaging modalities such as augmented reality or mixed reality could provide surgeons with enhanced visualization and guidance during complex procedures. Integration of artificial intelligence and machine learning algorithms may also assist surgeons with decision-making, task automation, and intraoperative optimization. Lastly, advancements in remote surgical capabilities may enable specialists to perform procedures from a distance, potentially improving access to specialized care. Now we will switch gears a little bit and next briefly touch upon the use of imaging and engineering platforms and virtual surgical planning for complex head and neck reconstructive surgery. Virtual surgical planning, or VSP, is a powerful tool for the head and neck reconstructive surgeon in complex reconstruction of bony anatomy. This is most widely used for patients with cancer involving the mandible and maxilla. It is a process of creating 3D digital models of the patient's anatomy and using it to plan and simulate the surgical procedure before the actual surgery. It is particularly useful for complex head and neck procedures such as reconstructive surgery, tumor resection, and craniofacial surgery. VSP can improve surgical outcomes, reduce operating time, and enhance the surgeon's ability to visualize the patient's anatomy and plan the procedure more accurately. VSP planning process starts with imaging data acquisition. We first obtain high-resolution imaging, such as CT studies, which is oftentimes obtained as part of the cancer workup. Next, a specialized software is used to identify and segment various anatomical structures, allowing us to construct a 3D digital model of the patient's anatomy. This allows for better visualization and manipulation. The 3D models are then used to plan the surgery with predetermined cuts and strategic reconstructive planning. Intraoperatively, cutting guides, customized plates, and models are used to increase precision and to reduce surgical time. That's a cutting guide and a customized plate and a model. This is a patient with osteosarcoma of the maxilla. We were able to proceed with virtual surgical planning and obtain cutting guides, customized plates for the complex reconstruction of his maxilla with a fibula-free tissue transfer surgery. This is the patient immediately postoperatively and 3 weeks postoperatively. Advantages with the use of VSP include: 1, custom surgical guides can assist the surgeon in accurately executing the planned procedure, improving precision and consistency of the operation. 2, planning the procedure a priori, surgeons can minimize the time spent in the operating room, leading to faster recovery times and reduced risk of complications. 3, virtual 3D models can provide surgeons with a detailed, high-resolution view of the patient's anatomy, enabling them to better understand the surgical site and plan the procedure accordingly. Ultimately, the combination of meticulous planning and reduced operative time can lead to improved postoperative outcomes, such as faster recovery and better functional and aesthetic results. Other areas in which VSP may add value would be in soft tissue reconstructive surgeries. For example, in patients with tongue cancer, when a large volume of the tongue is resected, this is reconstructed with the soft tissue-free flaps, such as from the forearm or the thigh, as shown in the pictures. Currently, the volume assessment and shaping of the transferred tissues is completed by the surgeon at the time of surgery. Although in most cases, and certainly with an experienced surgeon, the volume match is fair. However, in some situations, the patient requires second and sometimes third revisional surgical procedures. Virtual surgical planning may add value in these situations by improving accuracy of volume assessment to avoid additional surgeries for the patient. AI-assisted assessment could also be a potential area of development to further help with improving accuracy of soft tissue volume match. Another potential area of limitation in VSP for the head and neck cancer patient lies in tumor progression between planning and surgery. Rare, but in some instances, there may be tumor progression necessitating adjustments to the surgical plan. Again, in most situations, and especially in the hands of an experienced surgeon, this may not be a significantly limiting circumstance. However, it is certainly with increased complexity, longer operative times, and increased risk for complications. Intraoperative image integration with augmented reality platforms may allow for real-time adjustments in the surgical plan, which would greatly benefit the select number of patients with aggressive tumor progression. This concludes my discussion on transoral robotic surgery and virtual surgical planning. I hope that I was able to bring awareness, share my excitement, and ultimately stimulated some ideas and future collaboration in further enriching the field of head and neck surgery through technology. These are some of the references I used. And lastly, I would like to thank you for listening, the Bookout Center for inviting me today, and to my colleagues and friends at the otolaryngology department at Houston Methodist.
Well, thank you. Some pretty good-looking pictures right before lunchtime there, just to finish it off. But so, Matt, if you've got questions, jump in. I'm going to kick it off. So, you have your hand on two platforms: single port and the intuitive, and the XI. Do you use the XI?
So I had actually trained with the XI during residency, so I'm familiar with the setup and the use of it. Starting in fellowship, I became more acquainted and familiar with the single port robot. And I can tell everyone that the single port robot is by far the more advantageous in terms of the setup, the ease of the procedure as well. So I don't think I would ever be going back.
So in the previous session, we talked about surgical resident training. In ENT, otolaryngology, does everybody have to train a single port robot?
So the residents certainly do get experience with the single port robot during the OR cases. They're often the bedside surgical assistants during these cases. And actually not too long ago, we had a single port training session with the help of Intuitive, also with the Mighty Lab, where the residents came and we were able to go through models, learn how to set up the robot and apply it.
So when somebody finishes otolaryngology training, can they go out and do single port, or do they need to do an incremental fellowship?
Most of the time the robot is used by a fellowship trained head and neck surgeon, and I don't think that would change in the near future, but perhaps with a more widespread use of the robot, maybe improved access to the robot, that is something that we may be seeing in the future.
You have a question?
I mean, I have a question, but I don't want to step on my own talk, but just to mention some of the advantages that you mentioned as far as the ablative procedure, do you find that you couple either insetting flaps with the robot, so you do your ablative procedure, and if you're doing your own reconstruction, you showed an ALT sort of insetting that with your single port robot. Have you done that? Do you find that that provides any other advantages, or is that just kind of for bells and whistles?
I have mixed feelings about it, but I do certainly think that it can be used. I have certainly used the single port robot for insetting of the flaps, especially in the oropharynx where it's difficult to access. I don't think it is an absolute necessity, but I think it does help with the accuracy and maybe save some time with the inset of the robot, if we take away the time of bringing the robot in and out.
Fair enough.
Now, I've heard about crazy things like going transaxillary to take the thyroid out.
Yes.
Is that real?
It is practiced by some surgeons in the United States. It is very popular in Asia, where there is a lot of stigma for scars across the neck, and where the patient population, of course, is a lot thinner, so it makes it easier. But it is used for thyroid surgery, even parotid surgery, where people will enter retroauricular behind the ear.
And is that the single port robot, or just the
with the single port robot?
Okay. Very interesting. So, is a single port more expensive than the XI? Do you know?
I think it is. I would have to look that up.
So we went out to Intuitive, actually, really exploring the vascular applications. And to be honest with you, prior to going there, I was thinking about intracavity procedures. And they suggested we try this cadaver using the single port robot. Transformational, because this really opens up extremities. And so we could dissect from the above the knee all the way up to the groin. We could turn it around and get the popliteal fossa. We could put it in the arm, dissect the axillary vein up. And the nice thing from our standpoint is the robot, unlike the XI, where these arms are in the way of bringing in a C arm if we wanted to combine endovascular and robotics, the single port moves the robot completely out of the target field, and so we could integrate imaging into it too. So it was very interesting, and opened up something I'd never really even thought about.
That is amazing. I've never thought about it for use in the extremities, but fascinating.
We're going to make you famous. All right, so let's kind of move on to our last topic, I should say. And so, although vascular surgery is early, I would say this is probably even earlier in terms of the evolution in plastic surgery.
I would definitely say that.
So go ahead, Matt.
Well, hello, I'm Matthew Kaufman. I'm one of the plastic surgeons here at Houston Methodist. And today we'll be discussing robotics and plastic surgery, and I have no financial disclosures. So why is a plastic surgeon here? That's a great question. I think it's better to understand what do plastic surgeons do, because I think a lot of people don't understand that. I think from a PR standpoint, a lot of people think plastic surgeons are simply cosmetic surgeons, and I think the reality is a lot of plastic surgery involves reconstruction, and that is a majority, if not the entirety of my practice. Reconstructive surgery is the management of complex wounds and defects following cancer extirpation and traumatic injuries. This involves breast reconstruction, pelvic and abdominal reconstruction, upper and lower extremity reconstruction, head and neck reconstruction, lymphatic surgery, peripheral nerve surgery. So wide breadth of surgery in patients of all ages, anatomy throughout the body, and we work with nearly every surgical specialty in the hospital. And the way we accomplish these goals are through performing flaps, which is repurposing tissue. They're kind of in broad terms, pedicled flaps, which is tissue still connected to its blood vessel leash that is rotated about a pivot point, versus a free tissue transplantation or a free flap, which involves microsurgery where the tissue has its intrinsic blood supply, it's mobilized, divided from its source vessel, and then moved remotely to a different recipient site where the vessels are reconnected with hand-sewn anastomoses under the microscope, and these vessels usually range about 1 to 3 millimeters in diameter. So again, the goals of reconstructive surgery are to restore the form and function and provide well-vascularized tissue to facilitate healing while minimizing donor site morbidity, which again is what we strive to do. Often our surgeries are not minimally invasive, but we try to have less donor site morbidity to accomplish our goals. So again, what do we have to do with robotic surgery? These are the FDA indications in the specialties that involve robotic surgery, with an asterisk with breast surgery oncology, currently ongoing trials to have this FDA approved. But it's a wide scope of surgeons, and again, we work regularly with all of these surgical disciplines. So when we see the robot in the room and they are doing a complex, minimally invasive robotic surgery, and then they hand the patient off because they need a reconstruction, we then do things very open. So we see this very advanced technology and then our conventional ways, and work is being done to sort of marry these ideas together to see how can we play into this technology. The advantages of robotic surgery, I'm sure it's been discussed multiple times, but again, for the patients, decreased donor site morbidity, less pain, faster recovery, shorter length of stay in the hospital, and overall better outcomes. For the surgeon, improved precision, tremor control, and motion scaling, improved visualization, so high resolution 3D imaging modalities, even computer augmented reality can be safer because of this. Helps us get access to confined spaces, not unlike what Dr. Kim was talking about earlier, getting into the pelvis and the head and neck, and overall improved ergonomics. And this picture is obviously not of me, but most days I'm in the operating room, you will find me looking exactly like this. Turned up sideways I have loops on, a headlight, and this can seriously impact the longevity of a surgeon. I'm still, like to think I'm still pretty young, but recent from our literature shows up to 70% of plastic surgeons have musculoskeletal complaints, and again, using the robot can hopefully add time to the to the surgeon's career. So what's been described as far as robotics and plastic surgery, which again is an emerging field. I think overall, the applications that have been described do not completely remove the open surgical aspect of plastic surgery, but rather augment our skill set already. So working to develop and harvest flaps in a less invasive manner, as well as augment our technical skills to improve outcomes. So abdominal wall, pelvic reconstruction, breast reconstruction, lymphatic surgery, and again, head and neck reconstruction, which again, we won't discuss since it's already been covered so well. So beginning with abdominal and pelvic wall reconstruction, again, the pelvis and the abdomen are the site of many robotic procedures by our gynecologic, urologic, and colorectal surgery colleagues. Often when a large tumor is resected, the patient is left with a large dead space, as we call it, or a potential space. And this is often the setting of previous neoadjuvant radiation therapy. The plastic surgeons are called on to recruit tissue in the form of flaps to bring in non-radiated, well-vascularized tissue to obliterate these potential spaces. And this has been shown to improve healing outcomes, decrease infection rate, and wound healing complications. It's important to note the anatomy of the abdominal wall. So you can see on the right, the strength layer of the abdominal wall, as I'm sure has been covered, above the arcuate line, which exists sort of transversely just below the umbilicus. You have your anterior and posterior rectus sheaths, which house your rectus abdominis muscle. But as you go below the arcuate line, it's the strength layer is predominantly the anterior rectus sheath. So we take this into account when we plan our surgery. So on the left is a schematic of a abdominal perineal resection for a low rectal tumor, and the surgeons today will perform partly external surgery to remove the perineum, as well as robotic surgery. And again, this surgery involves resecting the sigmoid colon, part of the rectum, the anus, the pelvic floor, so it creates a large potential space. And the sort of gold standard workhorse procedure to obliterate this space from a reconstructive standpoint is to use the abdominal tissue, and this is a VRAM flap, a vertical rectus abdominis myocutaneous flap, which is to say that it's tissue that skin and fat that overlies the rectus abdominis muscle, and this is dissected. The muscle is removed from its superior connections, removed by making an incision through the anterior rectus sheath into the abdomen and rotating this tissue into the pelvis, where the skin can sometimes serve for posterior wall vaginal reconstruction, as well as well-vascularized tissue to obliterate this space. In this procedure, though, if the patient has already benefited from the previously explained benefits of a robotic procedure for shorter hospitals, say less invasive, less painful, now we've converted into this large open procedure which they have to heal from, and we've effectively weakened their abdominal wall further. So work has been done to try to perform robotic rectus abdominis flaps. So again, the advantage of this, and this is where instead of making an external incision, performing a laparotomy, dissecting through the anterior rectus sheath, all of the flap harvest is done intra-abdominally. The ports are placed, the flap is mobilized while being preserved off its inferior blood supply, and the muscle itself is used to fill that dead space as it's rotated, and it can also serve to cover either colonic anastomoses or urologic anastomoses as well that have been subjected to radiation. So it avoids disruption of the anterior rectus sheath. You don't need a large laparotomy incision. It's possibly better for males as they have a narrower pelvis, and again, bringing in this thick subcutaneous tissue, which you can see in the bottom right picture, delivering that through the pelvis, that can cause it to be delaminated and create problems. And again, that's hair-bearing skin that you may not want to have there. And overall, preserves the benefit of why they had a robotic procedure to begin with. So you're not really increasing the OR time, the length of stay, and the complication rates. Plus you have a facile, well-experienced robotic surgeon there who can proctor you as you begin this process, as well as advocate for you to improve patient outcomes through this mechanism. So moving on to breast reconstruction. So breast reconstruction is the restoration of form following a mastectomy. Overall, large classifications are autologous and implant-based reconstruction with the goal of replacing the volume and in some cases the skin. So autologous reconstruction, it's the use of the patient's own redundant tissue, and again, often this is used from their lower abdomen. If the patient wants to avoid having implants placed, it allows for more modification and shaping for the patient, so it can be a little more unique as opposed to the kind of cookie cutter breast implants that we have available to us from a sizing standpoint. And often autologous tissue is needed following radiation, as there are much higher rates of implant exposures, infections with just implant-based reconstruction in an irradiated mastectomy pocket. So along the course of development of breast reconstruction using the abdomen, this is sort of the time frame, and a lot of this is before my time, but we began with pedicled trams, which again, not dissimilar from bringing that tissue into the pelvis that we mentioned earlier. This tissue is kept on its blood vessel leash from the rectus abdominis muscle, and it is all brought in concert up to the chest where it is inset. From that was developed the free tram, where again, the muscle and the vessels that nourish that muscle and the overlying skin and fat are dissected, clipped, transferred up to the chest where blood flow is reestablished under the microscope using microsurgery. From there, work is continually being done to minimize abdominal donor site morbidity. So taking less muscle in the form of a muscle-sparing tram, or the gold standard currently is the deep inferior epigastric perforator flap, where the flap, the skin and fat are isolated on just the piercing blood vessels through the rectus sheath. They are traced through the rectus sheath into the rectus abdominis muscle, where the larger perfusing deep inferior epigastric pedicle is dissected back to its source vessel. And this is closed, and the patient, as we transfer the tissue up to the chest and we close the abdomen. The reason why we err towards doing surgeries with less abdominal donor site morbidity is because of the complications. These are often underreported, but when you disrupt more of the abdominal wall, the strength layer, the muscle itself, and the nerves involved, it stands to reason you have a higher chance of developing weakness, bulges, or even true hernias. So these are things that we try to avoid. Specific to the anatomy, as we mentioned, the perforator, you can see on the left the CTA demonstrating the perforator piercing the anterior rectus sheath and nourishing the overlying skin and fat. And the other view demonstrating the course of this vessel as it perforates through the rectus abdominis muscle through its intramuscular course, and then caudal to that as it travels deep to the rectus abdominis muscle back to its source. The more we have to gain length on our pedicle is to allow for more ability to have larger vessels to perform microvascular anastomoses, and accordingly we have to provide larger exposure, which can contribute to larger abdominal morbidity. Similarly, when you perform this dissection from superficial to deep, you have to negotiate motor nerves that encase the pedicle as well as the perforating vessels, and often these are sacrificed. So even if you are able to spare the muscle itself, you are inherently denervating it, which makes it less functional. Thus became the idea to harvest these flaps robotically, where the initial portion of the procedure is the same. The skin incisions are the same, the dissection to the perforating vessels is the same. The dissection is done exteriorly from top down, so to speak, through the rectus abdominis fascia into the rectus for the course of the muscle, and then once the perforator meets the rest of the pedicle, the robot is brought in and docked. And here are a couple of videos that hopefully work, but it kind of shows the robotic dissection of the pedicle vessel intra-abdominally, which involves less abdominal morbidity as the muscle is not being disrupted, which again avoids the crossing nerves and again allows for us to get increased pedicle length. So here you see the pedicle has been dissected from the underside of the rectus abdominis muscle. It's been clipped and divided intra-abdominally. Then the arms are removed, and the flap with its long pedicle are delivered through a much, much smaller fascial incision. And again, this provides additional length as well as vessel caliber to help facilitate microvascular anastomoses when this is transferred to the chest and connected. Let's see why the next slide is not going. Okay. And again, this just shows what the advantage is. On the left shows a traditional deep flap. That's the donor site. Even if the muscle is not taken per se, it's by definition spread apart. We've got a large fascial defect. And on the right, you see that caption A demonstrates a very small fascial defect, but a very long pedicle. And this illustration demonstrates what's the benefit of doing that. You essentially allow yourself to only have a fascial disruption that measures the length of the intramuscular course of your pedicle. You do not need to extend that and have a larger fascial defect that extends inferiorly to achieve the same pedicle length. And this is important, especially when we talked previously about the arcuate line, where we divide that anterior rectus sheath, it becomes much weaker and you have a higher chance of abdominal wall morbidity. Going on, again, augmenting our armamentarium, the latissimus dorsi is a flap that can be harvested. It's an expendable muscle, and we use that for a variety of different reasons, whether it's breast reconstruction in a pedicled fashion, upper extremity reconstruction, as well as distant free flap reconstruction for scalp, lower extremity. And again, traditionally, we have to make a large incision to allow us to harvest this very large muscle, which is seen on the left. With the robot, this does not change as far as what we're doing and what we can purpose this muscle for, but it allows us to accomplish this feat through a much smaller incision, which again can benefit the patient greatly. Going on, lymphedema. This is a condition that involves dysfunction of your lymphatic channels that is often seen in breast cancer following lymph node dissections and radiation, but it can be seen in a variety of situations. But it involves the dysfunction of the lymphatic draining vessels, which contribute to increased arm circumference or leg circumference, whatever it be, as well as eventually fibrosis and complications involving infection. So physiological surgical options that are being employed are vascularized lymph node transfers, so harvesting the omentum, an organ inside the abdomen that is very rich with lymphatic tissue that is lymphangiogenic, can be harvested robotically and transferred to the site where it's needed, as well as immediate lymphatic repair or lymphovenous bypass, where the lymphatic channels, the flow is directed towards a nearby vein. The challenge with this is a technical challenge. Again, this involves super microsurgery, which is an anastomosis of vessels even smaller than previously described, again on the order of 0.3 to 0.8 millimeters, so considerably smaller and more technically demanding. And with that in mind, work has been done for dedicated surgical robots for microsurgery. So the Samani surgical system, here demonstrated with the operator manipulating the hand pieces and it translating to the arm, is a dedicated microsurgical robot, and again benefiting from the tremor reduction, motion scaling, and allows for completion of a more technically demanding, much smaller vessel, whether it be a lymphatic or even a perforator to perforator, which again can contribute to less morbidity. You can see in the bottom drawing, and again, this is probably exaggerated since it is from their website, but there is inherent tremor when you're operating on this scale, and if this adjunct can help minimize the tremor and improve the technical ability of surgeons to perform this, this may become more ubiquitous in practice. Now, with this microscope, you often have to employ a visual mechanism, so again, an exoscope, a 3D exoscope that's demonstrated here, and the benefit of that, you can, from an ergonomic standpoint, visualize this better, but also incorporate ICG for augmented visualization, whether it be lymphatics or vessels, so that can improve our outcomes. And again, this is a video that may be in the near future. So here's the surgery taking place on the monitor. You see the folks by the patient and the robot in place, and they're acting as assistant when the surgeon is over here sitting down, performing the operation, looking at the screen with his 3D glasses on. So this may be where things are headed. The challenges with robotics and plastic surgery is how do we adopt this technology as a field? I think it's a different infrastructure with respect to other systems and other services that have incorporated robots. Right now, we don't have any FDA approval to do any of these things per se. So how do we establish that? How do we establish a training program? The learning curve with respect to visual feedback that we need, as opposed to our standard haptic feedback with experienced surgeons have gained over time, as well as patient selection. There's fixed resources, and are these robots even available? As they may be in a different case, they may be being used. So how do we use our resources appropriately? There's also associated costs with adoption of this technology, the 3D exoscopes, the robot systems, and understanding that as this technology evolves, when do we want to jump in and become part of it? Do we wait for the advancements to be exactly what we want, or do we start using it and see what the benefits are, understanding that things are constantly changing and we need to change with it? So where do I see things going in the future? I hope to establish a training program Here at Houston Methodist, I think phasing implementation and collaboration with our other surgeons is the ideal starting point. And I think with more experience with this, it will drive more innovation. I think one potential option is the continuum of breast cancer surgery, where their mastectomy is performed robotically, their reconstruction is performed robotically, and lymphatic channels that may be disrupted as part of an axillary dissection are also repaired robotically. We can couple imaging modalities and hopefully get improved outcomes as well, working with technology to try to work on a smaller scale to get less morbidity. And again, working on microsurgery friendly instrumentation. I think machine learning, again, capturing this data through video, which we, generally speaking, in plastic surgery do not do a great job of capturing video, open things up for using this data to create technology that can perform autonomous anastomoses, such as the smart tissue anastomosis robot that's been described for bowel repair. So I do think there's a lot of future direction. We just need to get going. So thank you very much for your time, and I appreciate it. And this is my email if you have any questions, and look forward to hearing from you.
Well, thank you, Matt. Very stimulating, but you got some challenges. And one of the comments said, odd that the plastic surgeons are the guys making the biggest incisions now. And I think that's going to be a challenge for you. I actually think the analogy between vascular and you are very similar. And I'm going to tell another story we told this morning. I got called up to an operating room one day because they had bleeding from the pelvis in the blood vessel. And I went in there to help them. That's my job. But the robot was docked in the pelvis. I said, you want me to take the robot out and sew this? No, I think you can do it with the robot. I said, I can't. And I got dismissed. And the surgeon took care of the bleeding. I think the challenge for plastic surgeons, you're going to be in the same boat. If you get called in by the GI surgeon who's done the abdominal perineal resection through a couple of little incisions in the perineal incision, and you want to make an incision this long to reconstruct, you're going to get replaced. And so the challenge is, how do you stay engaged? And I know you've been thinking about this. And Dr. Kim, do you have any questions that you want to ask or comments?
How widely spread is the use of robotics in the harvesting of the deep flap and the lat flap currently?
So I would say it's overall definitely not a large portion of people's practices. I think there are some centers, MD Anderson, for example, Cleveland Clinic, where their path to becoming part of this has been a little bit different. They've been either grandfathered in or have a general surgery background and have adopted this early, and they're sort of the promoters of this initially. Again, and there are other programs, but is this widely adopted? No, but I think as we still strive to minimize our donor site morbidity, if this is something that can augment our existing practices, I think it's something very important to engage in and become part of before, like you mentioned, we're on the other side of it.
Yeah, I mean, so again, the other analogy is that I trained in general surgery, okay? But there's also a different training pathway now in vascular surgery, same as you've got. You go straight into vascular surgery, you don't do any laparoscopic surgery. The exposure to general surgery is minimal. Well, now it's going to be a challenge to take that cohort and retrofit them to be able to do this. And so I presume the same paradigm is taking place in plastic surgery.
And again, that is the challenge, and I think the widely available surgical robot, the Da Vinci, it's an interesting position where they control kind of the credentialing, the pathway through their training courses, which I find to be interesting from a technology application, because again, we would use it, we're not going to be performing prostatectomies with this robot, we're going to be using it to augment what we do. And I think trying to incorporate that safely, no one wants to do the surgery safer than we do, and I think that's the point. So how do we really incorporate that and integrate that into our training program?
So as you were talking, I was thinking, I mean, there's not a whole lot of difference between the deep flap and taking down the internal mammary artery. One's in the chest and one's in the abdomen, but there are very established pathways in cardiac surgery for dissecting out the left internal mammary artery and using it, not necessarily sewing the anastomosis, but the takedown. And so I think one of the challenges you're going to have to figure out, kind of like we did, is that we were fortunate that we kept peritoneal dialysis catheters in our armamentarium. There was an easy, low risk, where you can get your teams up to speed and you can get experience with it. I think you're going to have to try and figure out the same thing, because the challenge is you're usually the second wave surgeon that comes in, and they're not particularly going to want your residents to be trained on the abdominal perineal resection or the or whatever the reconstruction needs to be.
Yeah, I mean, you bring up an excellent point. I think what one avenue would be, we do abdominal wall reconstruction, so ventral hernias, that is an indication. We do have overlap with that. We do that, and can we incorporate that as part of essentially a stepping stone before we get to tedious dissection? I think the instrumentation needs to follow, as well as from a precision standpoint, microvascular clips. The handling of the instrumentation is on a macro scale as opposed to a micro scale. But I do think there are challenges, and where do we see ourselves? Because again, you don't want to start with the hardest case that you can imagine. You want to do something safe and reproducible before you, and then once you have that under your belt, you can expand your indications, what you do, and offer that technology to your patients.
Are you going to get your reconstruction done by the plastic surgeons if they have to come in and make a big incision?
That is a great point. I mean, for the lay population as well, and patients coming in to see us, if they see different advertisements, one as minimally invasive versus not, then that will certainly play a role in their decision making and expectations as well. So,
do most plastic surgeons have laparoscopic credentials? Could you, in other words, can you put a port in somebody's abdomen in an institution like this based upon your credentialing pathway?
That's a great question. I would say probably not. I would have to look, but again, that is not something that we do regularly, because again, short of this, and there have been some description of harvesting these flaps using endoscopes or even laparoscopically, but again, the advantages conferred by the robot sort of outweigh those. Is that something that we come in to from training and get credentials in the hospital? I would say no.
Yeah, so again, this is what I think the single port robot, as I say, we started intracavity. Now we're thinking about how we can do extremity stuff. You're more in kind of the extremity stuff. I mean, latissimus dorsi, I've actually shared the patents with endoscopic vein harvest by working with a plastic surgeon at Emory. Okay. And because we watched minimally invasive latissimus dorsi harvest. And Monty Eves was his name, worked with John Bostwick, and we developed this thing together. And so it seems to me like latissimus dorsi harvest would be a pretty good place to start.
Absolutely. I think there are, again, what is the sort of low-hanging fruit? What's the easiest place to enter with, again, understanding that you're going to have collaboration from other surgeons, proctoring, going about things safely, but what is something that can offer an advantage to the patient? I think that's a great example. And again, muscle harvest, it doesn't relegate the entire operation to a robotic procedure, but it does augment those areas and, again, making it less invasive.
So two different parts. The big dissection. That's in the intuitive realm.
Correct.
And then there's the reconstructive part, joining small blood vessels together. What's the scoop in the plastic surgery world about MMI? I mean, it doesn't do dissection. It's purely designed to join blood vessels together.
So I would say, and again, this is my opinion, a lot of these, especially when you're talking about scale on the lymphatic level, which is super microsurgery, which is a lot more technically demanding, I think the concept would be to more or less democratize and allow a good microsurgeon to become a great super microsurgeon. That would be their argument, but you could also argue the investment related with that, and what are the applications as they develop. Now, I would say this is a very new technology. Do they have the, whether it's the IP or the ability to create instruments that allow for dissection? I think a lot of that remains to be seen. But I think it's a very interesting technology that can augment and allow us to implement a robust lymphatic program. I think having access to that could be a complete game changer. And again, not only with lymphatic vessels, but as we mentioned with a deep flap, we still have to dissect out our pedicle length to get sufficient length as well as caliber. If we had something that was more allowed for a little bit more latitude with respect to your technique and facilitated performing small vessel anastomosis, perforated or perforator flap is the probably even less morbid approach to this. And again, can this technology help with this? I mean, it seems like it has the potential, but remains to be seen.
Let's democratize it even further. One of the arguments I brought up at our national meeting was, look, if you can adjust my tremor and scales a millimeter vessel up to make it look like the aorta, can the aortic surgeon saw it?
Well, that's what they always, I mean, that's what they always told us is that when you're doing microsurgery, you want to make microsurgery macrosurgery. Yeah. So how can you make something that is more complex? How do you simplify things? And it's taking it back to the source vessel, something of appropriate scale. And I think if this can augment that, but just like all these technologies, I'm sure when the initial the Da Vinci was brought out, where it was and where it is has changed along the way. And I think being someone who is leading medicine, I think it's important to be in the driver's seat and kind of controlling where things go.
All right. Well, thank you. We're going to hand this program back to Dr. Kaur. We're about 7 minutes ahead of schedule, which is amazing. But lots of exciting things to see this afternoon. Thank you very much indeed for being here.
Thank you all. Okay, so we're about to go into our third session now of the afternoon. It's more of our industry. And we're going to look at technological developments about to hit the market from the likes of Setante. And we're going to hear from Brelion and ViewFlow Medical. However, before we start, I'd just like to bring your attention to things which are happening this week and on to December the 9th. So if I could just share a couple of slides with you all. The first one is at the end of this week, we're going to kind of celebrate with an informal session at Valhalla. We're not talking about where the Vikings go, we're talking about where the Rice students, graduates and the faculty go, usually after about 4 p.m. Valhalla is the student bar at Rice. It's non-profit. It was set up in an old chemistry storeroom, and in conjunction and collaboration with Rice and Rich, we are hosting a happy hour, 5 p.m. until 7 p.m. on Friday. So if you like to go along, you just you can register by getting your phone out, etc., and scanning that QR code. That would take you there. And keep in mind, we're going to have free barbecue. We're going to have obviously there's going to be beer there. It is a non-profit bar, so even with inflation, the beer is about $1.07 or $1.10. But all the beer is on us, so please get yourselves down there. It's going to be a good couple of hours. And the second thing is we are back again. It's that time of year. It's time for Pumps and Pipes. So we're going to come at you live from the TMC3 Helix Park this year. For those of you that don't know the Helix Park, it's a phenomenal brand new structure shaped like a double helix that Dr. Jeff Severson was actually talking about earlier, because that's where he is based. It's one of the translational research institutes there. So that's going to be on December 9th, 8 till 3 at Helix Park. And the concept is Blueprint Houston. So converge and innovate, why that is an exceptional high bar blueprint for Houston, because we are the leaders in the convergence of aerospace, energy and medicine. So again, if you want to get your phones out, click on the QR code. You can register. Tickets were on sale today. And I'm going to show you a little bit of a recap from last year's event, just to get you the flavor of what we're doing at Pumps and Pipes.
The fact that you've got people from energy, oil and gas, aviation and healthcare all converging together to discuss, I've got a problem here, let's solve it, that's innovation. Ultimately, inside our team, we are not doctors, we are not clinicians. So coming to an event like Pumps and Pipes, where you get access to people with real world clinical problems that we can solve, that's the whole reason that we're here.
Peripheral vascular disease, blockages in the blood vessels of the leg, it is a growing epidemic. So my hope is to really engage with the other industries to use some of their toolkit to see how we might be able to open up these vessels in a safer way.
Even just within the room, you could see chemical engineers next to biomedical engineers, next to mechanical engineers, sharing those ideas and maybe overhearing each other. I think that's just representative of what happens at Pumps and Pipes more broadly.
I think the one that really made my mind start to think and my brain start to tick was some of the conversation around composting and hydrogen, and some of the potential that exists on the hydrogen side, but also some of the massive improvements you can make as it relates to food waste that we don't even consider right now.
Our particular interest is the combination of robotics and imaging. Imaging is transformed medicine. Imaging has transformed cardiovascular disease. And this is a group of people here who can really help us with this.
We're kind of a mecca for ideas to come and germinate and cross-collaborate. And whether it's space, medicine, oil and gas, and some of the new, clean tech innovations that are coming through, it's amazing to see everyone borrowing ideas from each other. And I think that's one of the reasons that Houston is going to lead the energy transition.
When I explain the Houston attitude to people who are not from Houston, if something needs done, Houston is the person that steps forward and says, hold my beer, I got this. That's Houston.
It's thinking outside of the box and thinking about other industries and how that we can learn from them. And this is the true pinnacle of that process. And I use this example all the time when I'm out trying to talk with other organizations and other industries about how you can think differently and make an impact on another industry outside of the one that you work in.
There you go, Pumps and Pipes Innovation on Demand. Get your tickets now, December the 9th. So we are officially in session 3 of the afternoon, and it's next generation robotics and imaging. And this is where we're getting a glimpse into what new tech is coming to market, what we'll be able to get our hands on and actually help with the patient experience and enhance patient outcomes. So I'm delighted to have in the studio next to me, Edvardas Satkauskas, okay. And he is the CEO of Setonti. And we've got a real treat for you today because we actually have the system on site here over at the Bookout Centre, over at Mighty, and we're going to patch into his companion, Thomas Baltrunas. So, Edvardas, over to you, sir.
Thanks a lot, Stuart. Thanks a lot, really great to be here. I'm CEO and one of co-founders of the company. My name is Edvardas, and we are building developed actually a teleoperated endovascular robot system, Setonti. The history of endovascular interventions started a long time ago. It was 40 years ago. We used mechanical typewriters back then as a standard technology. And a lot of things have changed since then. So we developed thousands of new endovascular devices. We got computers instead of mechanical typewriters. We went digital since then. But one thing did not change: the way we deliver endovascular treatment to patients. It is the same as it was 40 years ago. So doctor is still standing next to a running X-ray source and manually manipulates guide wires and catheters inserted into the patient. So even though 40 years have passed, we have the same process as we used to have. And endovascular interventions actually expanded, and it's a gold standard treatment for most critical conditions, be it heart attack, stroke, peripheral artery disease, and even some types of cancer. So do doctors do a good job in treating those patients? Absolutely, if they are skilled. But one, we don't have enough skilled doctors, we don't have enough skilled nurses, and the conditions that we provide for doctors and nurses to work are really hazardous. So now we know that X-ray causes radiation, it causes DNA damage to physicians and nurses who are exposed to it every day. It causes cancer and cataracts. They wear lead aprons to protect themselves every day from radiation exposure, and especially for nurses, they have back pains, and you wouldn't meet a nurse who is above age of 50 and would not experience a back pain. The same with physicians, and we still expect them to do a perfect case each time. And it's really hard to show the smell, but I guess this picture illustrates the conditions that physicians are working in. And technology could definitely help here. We have robots out there for precision. We have robots out there for automatization and making processes automatic. We have robots for hazardous work environments and when you cannot physically be there. And we even have robots when you have to do remote work. And even for medical field, just one of those justifications is enough for robot to exist. So they are built for accuracy, precision, to hold the devices, to position the devices, or to enable remote work. But when we talk about endovascular, we have to check all the boxes. And we have developed a system, Sentante, which checks all the boxes. It is accurate, precise, and for the first time ever allows entire procedure to be performed robotically from a different room. So a physician working from a remote workstation can perform entire procedure using robot, which is inside the cath lab. So Sentante is compatible with standard off-the-shelf endovascular devices and can manipulate 3 devices simultaneously, be it guide wire, catheter, and guide catheter, for example. And this setup allows entire procedure to be performed using robot. We are compatible with guide wires from 014 to 0035 and the catheters 2 to 8 French, so really wide range. And we can use any off-the-shelf devices. So we are device agnostic, but also procedure agnostic. We can do any procedure, be it diagnostic, treatment, you need to place stent, balloon PTA, coiling, anything that is needed can be done using robot. But those are the must-haves. The most important thing is how we do this. So we have developed a revolutionary user interface because the interface is the same guide wire, the same catheter, and the same guide catheter, set of 3 devices that physicians would physically use during the procedure. They have physically them in their hands and manipulate them the way they train to. So you push a guide wire, robot does the same thing inside the patient. You rotate the catheter, exactly the same movement is happening there. But if there's resistance inside the vessel, physician can feel it here real time in his cockpit. So real-time haptic force feedback provides the same sensation to physician just as if he would work manually next to a patient. And this is robotic digital technology, so we have robotic accuracy, we have extreme precision, we have increased stability, we have possibility to freeze the position of any of the devices. And that's a digital system which enables physician to work better, faster, safer, perform entire procedure using robotic system. So earlier this year, we did quite a lot of preclinical testing of the system. We did very different procedures. We did cadaver procedures, animal study, animal GLP study, 76 procedures in total, very different procedures, be it below the knee PTA, renal artery stenting, visceral artery PTA. And we have great success. We have 100% technical success rate, 0% safety issues, and no X-ray radiation to any medical personnel. So no one was wearing lead aprons. And what's most important for us is excellent feedback from investigators. Just a couple months ago, we completed our first clinical study. That was a huge achievement for our team. We did 10 patients and 21 procedures, again, very different procedures. Different devices were used, and again, 100% technical success rate, 0% safety issues, no X-ray radiation to any medical personnel. And again, really great feedback from physicians that used the system. And doctors love technology, love this technology. It's super easy to use. It's very easy to learn. We're happy to demonstrate this in Houston. And as a next step, we are bringing this technology to market, but also looking forward to expand indication, not to do only peripheral vascular, but also address neurovascular indication, because the stroke is a #1 cause of disability, severe disability, and the time which we have to treat the stroke or to help that patient is really limited. We have 2-3 golden hours, and if we do procedure in time, the patient is perfectly intact. If we miss this window, the patient stays disabled for the rest of the life. And only less than 30% of eligible patients get treated. The rest of them just don't make to hospital in time. And tele-intervention and robotic system like Sentante with tele-intervention capabilities could dramatically help here and help to solve this issue. So we are basically developing a platform for digital cath lab. At stage 1, we are empowering physicians with teleoperated robot system, providing robotic accuracy, precision, stability, and safety. We provide non-sterile X-ray free workplace for physicians who can work in very different way now. They are all of a sudden are not sterile but have desktop interface. And all this will create conditions to provide the procedure better, faster, and safer. But as a next step, we really are looking forward for inter-hospital tele-interventions to increase access to care to those stroke patients, emergent stroke patients, thereby reducing costs of care and with the satellite hospital setup. But this haptic force feedback, which we have in our system, is not just a nice feature for a physician. It is data. It is data of actual forces used with actual devices during the procedure. And when we pair it with X-ray imaging data, we have a full data, basically a blueprint, digital blueprint of entire procedure. And we can slice this data in very different directions. We can use this data for procedure optimization. We can create simulated vascular models for really realistic training platform with the system. But also we can use this data to train AI and increase autonomy of the robot. So in the future, the robot would be able to do procedures better, faster, and safer on its own and to help physicians even more. So this is all what we do and why. And we have the robot here in Houston Methodist. Happy to show the video footage of it installed and over to Thomas in the cath lab.
Okay, Thomas, how you doing? Can you hear us okay?
Yeah, I can hear you perfectly. So, good afternoon to everyone, and thanks, Alan, for your kind invitation. It is our huge privilege and pleasure to come to this super high-tech facility, and we would like to demonstrate this robot. So we have this morning just installed it in one of your cath labs, and this is Santante actually. So it is a remote cockpit. So one part of the robot was just filmed, and probably you can see from the cath lab as a separate thing. And there you can see the user interface. So the user interface is 3 devices. So it is a typical guide wire. It is 2 catheters, and it is super intuitive to use them. Again, you have some information about the devices on both of these screens, and the manipulation is straightforward. Typically, it takes less than 5 minutes for the doctor to start using. There is a security pedal. I press it, and once it is pressed, I can actually move back and forth any of the devices. And if you can see in the screen, so these devices, I can rotate, I can push, I can pull, I can do all the things. But it's not only about the movement of one or other devices. It's actually about the interface. It's not joystick. It's not a gamepad. It's actually the devices. And there is a haptic feedback. So if I push the guide wire up to the wall, I can feel the resistance. And this is extremely nice feature. So nowadays, only 2 robots in the market, so Da Vinci 5 and Santante, has haptic force feedback. So if you push the wire, and the wire has a resistance in the patient, you can feel it in the cockpit. And if you take a Lunderquist wire, so you feel resistance, but it's pretty safe. If you take a CTO wire, so you have to be extremely careful, but you feel that haptics in your fingers. And you can do actually all the tricks you know, and you have learned through your career, so you can use whatever, you can rotate, you can twist, you can tackle the plaque. So everything is allowed there. The other feature is once I release these devices, so they will recenter in this cockpit, but they would not move on the patient side. So now I'm releasing, and you see they actually moving here, but they are not moving on the patient side. So all in all, this nice cockpit actually is acting as a joysticks, and they should not be changed very often. We recommend to do it once per week, and despite thin or thick wire, whatever platform, balloon stents, microcatheters, coils could be used in the patient side. These remain the same. It is just a little bit calibrated to have a different tactile feedback in the cockpit, but otherwise it is acting like a joystick. So it is not time consuming to be changed every time. So the next thing is actually I can do the procedure without my gloves. So I can add an additional device. It's digital interpolator. I can add another device, and I heard some talks about 3D fusion images fusion. So actually the doctor can work in the nice workstation and work with another third-party software, and it's enabling technology. So you are not dependent on nurse just to make fusion. You can do a lot of things yourself. So, and what Edward has mentioned just now, it is digitalization. So it's not about only, okay, I can move a catheter, I can move a wire or whatever. It is actually about converting this procedure from analog to digital. So for instance, I am happy with the position of the wire. I am happy with the position of the guiding catheter. So I can lock guiding catheter, I can lock a guide wire, and without any possibility to lose the position of guide wire, I'm just removing with one hand. I am not securing neither guide wire nor guiding catheter, and actually it is removed. What it means? It means you don't need to ask a nurse, could you hold my guiding catheter while I'm removing the balloon? So it is a very nice feature of time saving and workforce saving. The other feature of digitalization is actually ability to use a precision mode. So once you press a precision mode, you have to move, let's say, 1 millimeter on the patient side. So you will have to move on the cockpit 5 millimeters. So now when precision mode is on, I'm actually moving a guide wire quite a lot in this side, but on the patient side, it moves just extremely slowly, just a little bit. So if you need an extreme precision, it is a nice feature and you can have it. Another feature for digitalization is measuring the length. So for instance, I would like to measure the length from this to this point. So I do have the numbers of each catheter. So I don't need any measuring device anymore. I can say it's okay, 44 centimeters. I subtract it up to this position and it's 45.8. It means the lesion is 1.8 centimeters. So these features actually is converting the procedure from manual analog to digital. But in addition to that, as Edward was mentioned, we are creating a platform. So a platform of converting the whole cath lab to digital one. So first of all, it's eliminating a black box. So it's integrating of various devices. And there's one feature I could show you, balloon inflator. So let's say I am creating some atmospheres up to 6. And we see here a nice graph of atmospheres over time. And it is a digital record, actually. And if you need to inflate a balloon for your clinical trial, or for your patient up to 6 atmospheres for 3 minutes. Not always it is so. Sometimes the atmospheres drops, and actually you have to have it adjusted. So in addition to that, we do have this feature as a possibility to move it to your digital electronic patient health records. So these are the previous inflations, and they could be just scanned with your mobile phone or with the iPad, and they could be moved. This graph could be moved to the electronic health record system. So this is about converting the cath lab to a digital one, and we do believe it is the future. So I don't know, do we have any other questions from the audience?
Yeah, thank you for that, Thomas. And I know you guys had a video. Do you want to show that as well before we go to questions?
Let's.
Yeah, so this video was taken just half an hour ago.
And again, special thanks to the video production team for doing this last minute request. Great job, guys.
Thank you so much. So actually, here you can see how the device moves in a vascular model. The same it actually acts whether it is a preclinical trial, so animal, or in clinical trials with a human. So actually, you can see moving hands. They are sterile, single-use hands, and they are changed for each patient, for each procedure. And you can mount any device out of the shell over the wire catheters. So be it a balloon stand, microcatheter, any type of guiding catheters up to 8 French, any platform for the guide wires, so 014, 018, 035, anything could be used in this robotic system. And actually, I think this is pretty much the movie, just to show the concept, just what is behind me in the next room. So I'm sitting in a very safe environment, no lead aprons, and I can actually manipulate these devices remotely. It's kind of an extension of my hands, but it's not only about the doctor, it's also about the nurse. So actually, no nurse has to step in while X-rays are on, and it's a dramatic change. So no one has to wear lead aprons. And for the future, it is a stepping back stones for us to do remote procedures, as it is for the first time ever, the first robot which can perform the whole procedure robotically. Up till now, no other endovascular robot could perform the whole procedure with 0 X-ray exposure to all medical personnel.
Wonderful. Listen, thanks, Thomas. I think we're just going to cut that live feed to you to go on to the next thing. Thank you very much for patching in there. We've got quite a few questions coming in for our audience. I believe the first one was, how does Setante compare to Corinda's CorPath? Yeah, that's a good one, I guess.
That's an excellent question. And as Thomas mentioned, we designed Setante to be able to do entire procedure robotically. So meaning we cannot do the arterial access, but from the moment when introducer sheath is placed inside the patient, you connect a robot to it and you can do entire procedure robotically. While you obviously know you had a Corinda system installed in here, with Corindas you have to start the procedure manually using the over-the-wire devices, advance guide catheter to the position you want to, then only then you connect the robot to a patient, go to shielded cockpit, use joysticks to advance those those devices to needed position, but then you come back again, disconnect the robot, and complete procedure manually. So yes, it saves some X-ray exposure to physicians, but the workflow is so much more complicated. Corindas was designed for coronary interventions, so they are compatible with rapid exchange devices and specific devices, 014 guide wire and rapid exchange stand, so catheter-based devices. While we have developed a system which is device agnostic, you can use a wide range of devices, you can use different devices, do different procedures, and use very intuitive and natural way to advance to manipulate the endovascular devices. And this is also additional a big difference. We are, Syntante is working with over-the-wire devices. So this is now developed for peripheral vascular intervention, but very soon we'll expand indication, move to neurovascular as well to help those stroke patients. And also the haptic feedback. It is a feature which is very much appreciated by physicians, and it's a digital data that our system generates. So basically we had to build a big hardware to become a software company. But on the other hand, this leaves the decision to physicians. So if physician feeling what's happening needs to push hard, it can, or he or she can push hard that guide wire. If you have a floppy 014 guide wire, you need to be very gentle. You can be very gentle. So robot does not take away those decisions. While in Corinda's case, the robot doesn't have haptic force feedback. You do not measure the forces. So the robot has to have some force set to advance those catheters. Like any force, like your X newtons, for example, you set for advancement of that catheter. And in one situation, that might be a perfect setup. But what if the situation changes? What if you use different device? So you have basically to validate your system to many different situations and many different devices, while Syntante is developed as a platform technology to be device agnostic, to be procedure agnostic, and we can easily adopt the technology to use different devices and perform different procedures. So that is probably the biggest differences from Corinda's system.
Thanks for that. And I guess we can probably combine two questions here. So, has this been used in the clinic yet, or is it preclinical? And can you maybe comment on the EU robotic device approval process? How is all that linking together?
So we are not FDA approved device. We are not CE marked device in Europe yet. We're going there. So just a couple of months ago, we completed our clinical trial, collected first clinical data with the system, and we are moving towards submission for regulatory approval in Europe. But we also are planning our clinical trial here in the US to collect clinical data and submit for FDA approval next year.
And how does that kind of work then? So, with the FDA approval, is it possible to do like some stuff simultaneously, so you can take some data sets from the EU, apply them to the FDA strategy, or is it really like you're starting fresh?
We have had a couple pre-submission meetings with FDA, discussed our preclinical and clinical validation strategy. And the EU data will be submitted together with the US data, but obviously FDA wants to see the US-based data in the US facility, so they can be sure that this device is safe to use and can work well in the US cath lab.
Wonderful. And I think we have another final question there. So is it possible now or one day to program an A and B and have the wires automatically go to pre-selected points? Very specific. Yeah.
That is an excellent question, and it is not possible today. But as I mentioned, we collect the data of the procedure. That's a digital record of entire procedure, so we can definitely train the system using this data later on to do certain things automatically. For example, one simple example is retraction of devices after the procedure. So the robot knows what forces were used to go inside. So it is easy to develop a solution that robot would automatically retract the devices after the procedure in a safe manner, because it has data, it knows how to function. So this is a very simple example, but going next step forward, yes, we can use this data to also to manipulate the devices in different ways. And when we collect a sufficient data set of real clinical data, of real clinical use cases of the system, we'll use this to develop next steps. And one of those absolutely can be increased autonomy of the system and ability to advance, not only retract devices to a needed position.
Okay, so I don't know if our viewers can see this, but we actually have Dr. Lumsden now over in Mighty. Can we patch this? This is kind of, maybe not pull the audio in because I'm not sure what they're saying. But yeah, we go. So we actually have Dr. Lumsden right now over in Mighty at the Bookout Centre, and he is getting some hands-on experience with this system. So again, just to keep in mind to our viewers, like Tonti have come all the way over from Lithuania. Okay, so I do really appreciate the effort that you put in here. And they've been here since Saturday, and I know they managed to go down to Johnson Space Center, so another unique kind of selling point for Houston, right at the doorsteps for NASA. And it's really experiences like this where, by coming on site, getting to know people face to face, and actually having hands-on experience, you just can't replicate that virtually. So again, kudos for you to coming all the way, and we really do appreciate it.
Thanks a lot, Stuart, for inviting us, for having us here. It's really a big privilege for us to be here and to demo the system to you.
No problem. And hopefully you're still here on Friday. We can get some barbecue at Valhalla at Rice. So moving on to my next guest, we have Dr. Jim Sun, who is the Chief Executive Officer for ViewFlow Medical. And he's here to talk to us about a system which is enabling real-time insights into hemodynamic blood flow. Jim, it's a pleasure to have you in the studio, sir.
Yeah. Thank you, Stuart. Our product is ViewFlow. Its goal is to help assess blood flow during open surgery. On the screen is to the right is the form factor. It's a cart with an arm, and the head unit is brought down to about 9 inches above an exposed organ surface. The picture on the left are two surgeons using ViewFlow in a pig lab where we help develop the product itself. The picture on the right shows what ViewFlow actually reveals. This is a pig heart explant, so it's benchtop. We're pumping blood from the top through the coronary. In this case, we wanted to get to much higher speeds, like 31 centimeters per second, and to get to that on a pig heart that's been harvested, we had to cut the lower part of the coronary. So basically it's just coming right through, and it's not going through the other vessels to the left and the right. The picture on the left, of course, is what a surgeon sees without the aid of some type of system. Another view is this is blood being pumped through a tube at 20 centimeters per second, and then pliers from behind cutting off the flow, and to give you a sense of the dynamics that are visible at these speeds. And there's probably many clinical applications that can come out of this, and we're looking for that kind of guidance and kind of co-development partnership on the clinical side. Some of the common tools out there today to assess blood flow during surgery or during open surgery are flow probe off to the right, and from there you can assess the speeds. The challenges are you have to manipulate the vessel, and the information is limited to the place you're actually measuring. So if you're trying to assess downstream in a coronary, for example, you have to have some type of flow probe imager to go to that spot as well. The other one is ICG glow dye for short, to assess circulation. You won't see a pulse in that scenario unless you inject it right right proximal to where you're working, and only then you'll get pulse for a moment. That's because the concentration is constant throughout the whole system. The workflow is disrupted if anybody's used the ICG before. You have to mix the ICG, inject it, oftentimes turn off the lights in the OR. And ViewFlow does provide this ICG glow dye in case that's part of somebody's common workflow. In that case, it would show it side by side to our technology. How it works: surgeon brings the imaging head unit above the organ, brings it down. There's two lights that come together, targeting lights. When the red beam is in the middle of the green light, that's 9 inches away. It's in focus. Turning on the system, near infrared laser lights, pretty deep infrared, unusually deep compared to most things that are out there. It penetrates about 5 millimeters deep into exposed organs. The light goes into the tissue, comes back, and to the extent that the blood flow is flowing, the red blood cells are tumbling, and that tumbling is throwing light. And we're basically measuring just how much it throws the light. And that's directly correlated with the mass transport flow going through the vessels. If we capture the images down below, left number 4, and we apply a multi-dimensional algorithm to basically separate out vessels from tissue and then identify the blood flow speeds within the vessels. And this is all in real time. And then the bottom right is a picture of the output. Clinical value. Now, the clinical value we have right now is based on what surgeons have told us that they think the clinical value may be. We're looking for co-development partners to verify these things and validate them and make claims to the FDA. Currently, it's class 1, no claims. So we're looking to make claims to add to the value, and we need clinical guidance and co-development to do that. One is it's easier than dye. Basically, you point and shoot. So you skip quite a few steps there. If you make an intervention or you make a correction on a vessel or whatnot, revascularization, you don't have to keep injecting dye to get an assessment of how does it look now. You can just re-image in real time. There's no physical contact as there is with probes. It lets clinical practices or practitioners standardize on one instrument that basically this one does several different things. And leveraging data. Like before and after fluid dynamics. Economic workflow benefits, no autoclaving, no probe calibrations, no ICG mixing, said that. We think it's about 75% less time to actually assess blood flow during surgery with our device, probably half the cost. And having evidence to show a patient after the fact, like before and after procedure, if it's a, for example, heart bypass. In a CABG or heart bypass example, we've had our medical advisories suggested that maybe these are the typical examples of benefits, is assessing or start off finding the obscured surface vessels below some tissue. With our device, would show you that. Pulsing artery versus a vein to distinguish the artery from the vein immediately. Scan the coronary looking for a blockage in addition to the angiogram. Checking the patency of the lumens in the candidate grafts. Assessing the quality of the flow through the graft as well as the anastomosis and into the coronary itself, all at the same time. And then, as I mentioned before and after evidence that could be shared with the patient and help with real-time decisions. Several therapeutic areas could be relevant. We've had surgeons from different areas, such as dealing with newborn infants, general plastic and transplants, GI, cancer, heart and vascular. And I won't go into detail here, but these are some use cases where it could be relevant. I could go back to that too, Stuart. Okay. Future form factors could be a scope. What we do could work with today's camera and our laser delivered by fiber optic, so it could be seated inside a scope, as well as a handheld or ceiling mount. And we have a demo the next 2 days on the 5th floor at Mighty Labs, and we're in room PSL 6 and setting up today.
Okay. I think we had a few questions that were coming in from our audience here. One of them was like, can you actually use this to measure pressure? Very interesting concept.
Yes, that's good. Yes, that's a good question. We get that a lot. I don't know that. We probably need to talk to a fluid dynamics person to help us figure out how we translate. We can see the transit time speed. We can estimate the volume speed. We probably need guidance on how to convert that to assessing pressure.
Okay. So is that something you think you could do internally, or?
We need guidance on that. I think from the variables that we probably can, but we need to make an assumption about viscosity and the degree of, how much variability there is in viscosity and how much that impacts the pressure calculation.
Got it. And how did this technology actually originate? Like, where did it come from? Want to tell us the story about that?
Yes. So I was assessing inventions for NASA and universities, and as well as consulting with Fortune 1000 companies. And I was basically looking for an invention that would help in healthcare that would be disruptive. And so I came across the idea that flow probes and glow dye were being used to assess blood flow. And there are solutions out there for assessing blood flow with a laser and a camera and algorithms, but they're limited to perfusion. And so I was asking the question, I actually reached out to those companies and asked them, can you assess blood flow in vessels? And they said, no, it's not possible. And so that kind of set me off to figuring that out. And in my own PhD at Duke, I had worked on a multidimensional model, and I started applying that kind of thinking to how to solve this thing, and started getting closer to how we may make that work, crack the code on that. And so it's pretty much, so I was looking for something to that would be disruptive for an existing market that would be really helpful. We ended up having to invent it. It took several years to do that.
And when you say we, who's your partners in this? Is it just yourself, or is
it myself,
yeah.
Kind of engineering teams and lots of interns and.
Okay, so where are you based? I mean, like, you got a company, but what did you do before that, kind of thing? Who's Jim Sund?
Before that, well, to that, so I was working for Duke University as an adjunct faculty for their graduate program, and helping them with helping Fortune 1000 companies who came to Duke and wanted help with new market entries, Cisco, Lenovo, Deutsche Bank. I was also assessing inventions for NASA and for DoD and for universities, invention disclosures from inventors, professors typically, and is there commercial value in this? So that was my main task of doing that. So I'd been doing that for about 10 years. And really in that time I was actually looking for something that I could turn into a company. And we would license the product. So in this case, I actually had to invent it. That wasn't I wasn't trying to do that. I was just trying to find something that we could close the gap a little bit and take it to the market.
So how did you stumble across that kind of need, that unmet need, which led you to invent this tech?
Yep. So we came across some inventions that might do something like this, but they only did perfusion. Okay. And so I just asked a question that went beyond that, like, what about vessel flow? Because when you talk to surgeons, it's like, well, yeah, I want to know about perfusion, but I really want to know about flow. Since I'm revascularizing, I'm attaching a vessel, or I'm cutting a vessel and reattaching it. Do I end up with the flow that I started with? Or if it's a cabbage, did I improve flow downstream in the coronary? So it came down to like trying to assess vessel blood flow itself.
Okay. So you talked about other technologies that are on the market. Can you maybe talk a little bit more of the actual technology behind them and how yours is a differentiator?
Yep. So what is out there is cameras, lasers, algorithms. But when I look at these images, I can tell that there's a few dimensions that you have to conquer first before you can actually start unpacking vessel blood flow speeds. And I can tell that they're not actually correcting for things like, I'll try to keep it less technical, but when a light comes out, there's a Gaussian distribution where it's brighter in the middle and less bright. You have to correct for that. And I can tell they're not correcting for that. I don't want to help them out too much here. But so it's sort of knowing like how to correct for light going in. Glare coming back can influence a lot of things. Hearts are not homogeneous. When we get them in, there's fatty here and muscle there and kind of commingled tissue somewhere else. So there's quite a few different phenomenon that you have to actually solve to get to kind of unpack like, okay, what's really actually going on? So to do that, I would say it really came down to mathematically describing what is happening, removing something, and then seeing what's behind the curtain, and then now dealing with that. So it's basically a series of unpacking or removing layers of information that was noise relative to what we're trying to get to.
Okay, and I guess probably the last question here is, it came up there, so can this tech see through grafts, or is it just biological tissue? We have not looked at a graft yet. I mean, if it's a biological graft, yes, but if it's a kind of a, what's the So I guess it will
Gore-Tex
depend on
product,
the,
I think.
depend on the material optical properties, right?
Yes.
So,
Yeah, it depends on their optical properties. Is a kind of a long infrared wavelength, can it penetrate it?
Right. Okay.
Yeah.
Because I know you were saying earlier that there was potentially a need for using this to look through blood flow through grafts. So is that in your experimental pipeline?
Oh yeah. So that kind of graft I'm referring to is a mammary artery, thoracic artery, a saphenous vein, those types of grafts.
Okay, got it. Okay, so we're going to jump in and go to our next guest, but I'd just like to take the opportunity to thank Jim for coming in the studio today. Thank you very much, Jim.
Yep.
And as Jim mentioned, he will be on site today, tomorrow, Wednesday, doing some live demos, so you can register for that. Before we move on to our next guest, I'm just going to promote again a couple of events that we have come on this week. So if you can see my slides here, we have an event this Friday, which is over at Rice University. It's a kind of nice informal way to wind down the week to engage in more discussions with our staff. So if you could pull up my slides there, please, guys. Show the promo. Okay, so I don't know if that's working. I'm going to try another one. All right, another HDMI. See if that does it. Doesn't matter, it's not working. So Bookout Center at Valhalla this Friday. It's 5 to 7 p.m. So even if you're not registered, just please go along. You'll figure out you can register there and then. It's going to be barbecue and beer, great chance to network, etc. And also Pumps and Pipes is back this year. We are going to be at TMC3, Helix Park, December the 9th, 8 till 3 p.m. Tickets have gone on sale this morning. So we have an early bird discount rate of 20% off. So for $40 you can grab your ticket. You've got breakfast, you've got lunch. It's going to be great catering, great day. So please go there. And I'm going to show you a recap of last year's event. So hopefully see you there.
The fact that you've got people from energy, oil and gas, aviation and healthcare all converging together to discuss, I've got a problem here, let's solve it, that's innovation. Ultimately, inside our team, we are not doctors, we are not clinicians. So coming to an event like Pumps and Pipes, where you get access to people with real world clinical problems that we can solve, that's the whole reason that we're here.
Peripheral vascular disease, blockages in the blood vessels of the leg, it is a growing epidemic. So my hope is to really engage with the other industries to use some of their toolkit to see how we might be able to open up these vessels in a safer way.
Even just within the room, you could see chemical engineers next to biomedical engineers, next to mechanical engineers, sharing those ideas and maybe overhearing each other. I think that's just representative of what happens at Pumps and Pipes more broadly.
I think the one that really made my mind start to think and my brain start to tick was some of the conversation around composting and hydrogen, and some of the potential that exists on the hydrogen side, but also some of the massive improvements you can make as it relates to food waste that we don't even consider right now.
Our particular interest is the combination of robotics and imaging. Imaging is transformed medicine. Imaging has transformed cardiovascular disease. And this is a group of people here who can really help us with this.
We're kind of a mecca for ideas to come and germinate and cross-collaborate. And whether it's space, medicine, oil and gas, and some of the new, clean tech innovations that are coming through, it's amazing to see everyone borrowing ideas from each other. And I think that's one of the reasons that Houston is going to lead the energy transition.
When I explain the Houston attitude to people who are not from Houston, if something needs done, Houston is the person that steps forward and says, hold my beer, I got this. That's Houston.
It's thinking outside of the box and thinking about other industries and how that we can learn from them. And this is the true pinnacle of that process. And I use this example all the time when I'm out trying to talk with other organizations and other industries about how you can think differently and make an impact on another industry outside of the one that you work in.
All right, and we're back for the last presentation of the day, saving the best till last. In the studio, I'm actually delighted to have with me today Michael Tolkien, and he is Vice President of Business Development and Marketing for Brelion. And I'm very, very excited to have you here, and even more excited to going to be getting some hands-on experience with the system, because you're also here at Mighty, right? You got a demo for the next couple of days.
We do.
So Michael, what is Brelion? What are you guys bringing to market?
So Brelion is a Silicon Valley-based startup that is pioneering an entirely new category of immersive display technology. We are rolling out a number of new products, which are large format displays in a very compact form factor, which allow a lot of different medical applications. Do you want me to kick off?
All right, yes, sorry. So I'm just already engrossed looking at that graphic that's coming up on your presentation. Yeah, I believe you. Yep, let's go. Awesome looking.
So our two main products, Ultra Reality on the left and Ultra Reality Mini on the right, are what we're featuring today. Ultra Reality is a 122-inch virtual image viewable through a 30-inch viewing window. And then our smaller version, Ultra Reality Mini, or UR Mini for short, features a 40-inch virtual image through a 14-inch aperture for especially space-constrained environments. And today we'll talk about a number of different medical applications ranging from virtual ICU to medical imaging and review, endoscopy, in-room cinema or in-hospital room cinema, MRI in-bore cinema, and robotic-assisted surgery. I'll get into a little bit of detail on each of those. But to answer your question, a little bit more about Brelion and our background, we're an MIT spinoff backed by Lockheed Martin and LG, as well as a number of other strategic and financial investors. And we're based in San Mateo, just outside of San Francisco. We have a secondary office in Taiwan where we do our manufacturing and assembly. And then we have customers, distributors, and showcase sites around the globe. So a worldwide presence at this point. We've won a number of awards for our technology from the optics and photonics community, the Optica Award, SPIE, and Society of Information Display Technology Award. The origin story of our technology, our CEO and founder was studying at MIT, studying imaging, and had a similar idea based on those principles to apply to display technology. And so we unveiled our technology on the TEDx stage a few years ago, where we visualized a proof of concept of 6 discrete layers of depth in a single interface. As you can see here, the camera's refocusing between the front layer and the back layer as each of those images are on different depth planes, all within a single display. And the way we view the future of immersive visualization is you really need to hit 3 key attributes: comfort, performance, and immersion itself. VR headsets give you immersion, but not really comfort and performance. Conventional monitors can give you comfort and performance, but are lacking in terms of immersion. And so at the end of the day, we think most use cases will continue to be accessed through non-headset based platforms. And so we're positioned somewhere between conventional monitors and VR headsets, again offering comfort, performance, and immersion in a single device. So first we'll talk a little bit in detail about Ultra Reality. Again, this is that large format display that features a 10-foot screen through a 30-inch viewing window, kind of like IMAX on your desk. And the smaller version is a 40-inch virtual image through a 14-inch aperture. And as you can see here, it gives you sort of a panoramic effect that wraps around you and immerses you, but doesn't isolate you the way a VR headset might. And the experience is like looking through a window. So instead of looking at your display as you would a conventional display, you look through the display. And when you look through it, you see a much larger screen on the other side that again wraps around you and gives you that large format experience. So in terms of the key attributes of our technology, it's a 110-degree field of view in a compact form factor about the size of a 30-inch monitor. It's plug and play with HDMI or DisplayPort, so there's no software or content bottleneck. It'll work seamlessly with your existing systems, content, and software. And the image depth and curvature, the image depth being 1.4 to 2.5 meters away, and the curvature matching the horopter, or the curvature of the human eye, is much more comfortable on the eye, leads to less eye fatigue and eye strain over prolonged use. In terms of spec, we can outperform standard 32-inch 4K monitors. With respect to brightness, we enhance the brightness. By directing the photons towards the user, we control the directionality of the light. Resolution, our current units are 4K. We have architectures that go to 5K, 8K, all the way up to 12K. Field of view, again, is 110 degrees. We can go up to 155 degrees. The image size is 122 inches. We can go up to 300 inches. And there's also a pretty significant power savings relative to comparably sized multi-monitor setups, about a 7x decrease in power consumption. So there's a sustainability aspect to our displays as well. So in terms of how it works, there are a couple of principles that are worth mentioning. The first is depth modulation, where we push the image far away from the viewer into virtual space without any image degradation. And the second is what we call light field expansion, which is distributing pixels in virtual space to give you that panoramic kind of experience. To dig a little bit deeper, with depth modulation, we're able to give you an image across the field of view that's pristine and without any optical aberration. And with respect to light field expansion, again, we're positioning those pixels in virtual space curved to match the horopter of the human eye, so much more comfortable viewing experience over extended use. You might be thinking, how does this differ from standard 3D stereoscopic displays? So some of the disadvantages of 3D displays is you have accommodation divergence mismatch, which means your eyes are focused on a plane that is not corresponding with the image you're seeing. So you go to a movie theater, your eyes are physically focused on the screen, but the images may be coming out from you, and that disconnect is what leads to nausea and discomfort. It also has significant artifacts in a very narrow viewing zone, and of course it requires glasses. Brillion offers true optical depth. It's monocular depth, so your eye is actually focused on the depth plane you're viewing. Zero artifacts and a very wide viewing zone, and again, doesn't require any glasses. It's a glasses-free technology. There are other methods to achieve autostereoscopic 3D or 3D without glasses using lenticular screens and such, but they have limitations, limited viewing zone and doubling artifacts, shallow depth relative to what we're able to do with deep depth, and haze artifacts. Brillion technology again offers true monocular depth, an infinite viewable distance, no doubling artifacts or discomfort, and no head tracking or eye tracking required. Minimal computation. So this is just to summarize the competitive landscape. As you can see, Brillion outperforms our competitors in almost every metric. And with respect to cost, we're continuing to drive our costs down as we continue to scale. And one sort of point of reference, in the automotive industry, our technology is estimated to be about a 20% increase compared to comparably sized flat panel monitors. So you can use that as an estimate of the increase in cost relative to alternative flat panel solutions. So in terms of the applications, we're a dual-use technology, meaning we have applications in both the defense and commercial sectors. So in defense, flight simulation and training, we partnered with Lockheed Martin to develop an all-in-one simulator using their prepared software and our display and some peripherals for a bundled solution. It's also used for command and control and ISR, where you need to find very fine details in a very vast landscape of data. And that tracks to some of the use cases we'll talk about here. But first, I wanted to talk about patient care and our displays being ideal for nursing administration. So this idea of a virtual ICU, similar to control rooms in the defense space, we can offer a 20x reduction in size, weight, and power compared to multi-monitor setups, and enhance comfort over prolonged use. With image review, our displays are ideal for physician comfort, efficiency, and effectiveness. So diagnostic imaging and radiology, Our displays allow for extended review sessions because of that eye comfort. Because we enhance the brightness of the image, we're able to get doctors out of the dark room and view images in standard lighting conditions. With our image magnification and our image brightness enhancement, we can increase the probability of detection in the diagnosis. And we also offer volumetric privacy, so this notion that it's really meant for one person to view in isolation and not have multiple people seeing the image at the same time. So it gives you some privacy that way. Brilliant displays are also ideal for enhancing physician comfort, efficiency, and effectiveness with respect to procedures. So in endoscopic and laparoscopic procedures, we're panel agnostic, meaning we can source any monitor panel for our system. The compact size allows us to integrate this monitor into the surgical suite with space optimization. And the virtual screen is, again, sculpted in 3D space. So what appears or what should appear closer to you does appear closer to you, and what should appear farther away from you does appear farther away from you. So when you're looking at these images, it gives you a feeling of 3D, even though it is a monocular depth profile sculpted in 3D space. Next, we'll talk a little bit about Ultra Reality Mini. So Ultra Reality Mini gives you a 40-inch virtual image through a 14-inch aperture and has a number of different applications for space-constrained environments. So one is with respect to the patient experience and recovery, creating a cinematic kind of hospital room experience that's immersive and transportive and potentially helpful with pain management, as we've seen with VR headsets, except you don't have to wear anything on your head. And now I want to talk about some of the future-facing technologies we're working on, some more advanced capabilities that I think is very exciting for this audience. So the first is Ultra Reality MRI, and this is a concept to enhance the patient experience when going into the MRI bore, alleviating claustrophobia with a virtual bore that's 5x larger than a 70-centimeter bore. So our optical system allows us to create the illusion of having much more space in the bore and therefore reduce claustrophobia. We also are working on a concept called UR3D, or Ultra Reality 3D. And this is for robotic-assisted surgery and procedures. So it's glasses-free access to both shallow and deep depth, or true depth, the monocular depth and the stereoscopic depth. And enables enhanced efficacy and accuracy in the surgery. So we're pretty excited about the potential for this technology in the emerging robotic-assisted surgery realm. And last, one of the most recent technologies we rolled out is called UR Extend. Instead of having one monocular depth layer that's far away from you, we have a secondary monocular depth layer that's a little bit closer to you. And those discrete depth layers allow you to augment the back layer with secondary information. So by way of example, you could have patient images in the background and patient data on the foreground, or just multiplex data in a new dimension. So very exciting technology that we'll be rolling out next week. So again, a number of different use cases that leverage our immersive and virtual display technology. Really is a new age where you don't have to wear headsets or glasses in order to get immersion and to take some of these medical applications to the next level. So thank you very much.
Thanks for that, Michael. That was a really insightful and exciting talk. You know, we had a couple of questions come in from the audience there, but I just want to get on to the whole thing about virtual reality, augmented reality, so extended reality, right? You know, they're trying to find what applications are suitable for virtual reality or augmented reality, and in some cases, you're not going to have people in a VR headset for extended periods of time, so it's a bottleneck. But it sounds like what you guys are offering is the complete opposite of that, but allows for the same immersive experience. Is that right?
Exactly. So you can use it 8+ hours every day without experiencing fatigue or exhaustion.
Okay. That's really interesting, actually. So I know someone's asked, can you use this for robotic surgery, i.e. Da Vinci? And I think you mentioned that in your slides. You know, are you doing any developing in that space? I mean, if you want to do it for the Da Vinci, I mean, you would essentially just replace that stereoscopic imaging.
So our approach is to actually have a much larger aperture, so you don't need to be in that sort of head mounted or head sort of space. But yes, that is one of the applications that we're very excited about. Requires 3D, and right now we offer monocular depth or 2D depth. But the combination of our monocular depth with the stereoscopic depth creates a really compelling new type of solution for robotic-assisted procedures.
And somebody's wrote up here, so your device doesn't cause nausea. I don't know if that's a dig at being in VR and getting nauseous in VR. Do you want to maybe comment on that?
Yeah, absolutely. So one of the reasons why people get dizzy or nauseated in VR is because of this accommodation vergence mismatch, where they're viewing an image that appears to be divorced from the physical plane that their eye is focused on. We don't have that issue because the image you're looking at, your eye is actually focused that far away. It appears to be that far away, and so it is a much more comfortable experience. Also, relaxing the ciliary muscles in your eyes by looking farther into the distance is a more comfortable experience and less fatiguing. And the last thing I'll mention is for people with presbyopia, they don't even have to wear their glasses because we're naturally pushing the image farther away from them outside of the physical embodiment of the device.
I think that's another very good point. You know, for users that are wearing glasses, it can be kind of tricky, put it on a VR headset, etc. Right? It's just like, you know. So again, it's another great opportunity for you guys to enter that market with something that's fully immersive. I guess my final question is, you know, can you comment on your history? You said it was a spin out of MIT. Mm-hmm. How did that come about?
So our founder was a research scientist at MIT studying imaging, Barmak Heshmet.
Okay.
And he then partnered with Alok, who was at DARPA under the DoD umbrella.
Okay.
And they came together both with an optics and photonics background to create this solution on the display side. So no IP transfer, complete separation of IP.
Wow.
But that's how the company came to be, and then I joined shortly thereafter.
So what the lesson is, get MIT and DARPA in the same room together, see what they come up with. Okay, well maybe we'll do that next year. So again, you know, to the users that are local, or even if you want to travel in, Brillion will be on site today, Tuesday and Wednesday for hands-on demos. So if you feel like attending, please register for that. You could get details, I think, in the description. And on that note, I'd like to thank Michael for coming in. I'm looking forward to experiencing this myself.
Absolutely.
And to our audience, I'd just like to thank you for your time and your patience, etc. Waiting for this event. You know, I know people have been wanting this to happen, so here it is. We want to keep the momentum going strong. I think we'll be here next year. So if anybody has any questions or information, if they go to bookoutcenter@houstonmethodist.org, they can send in their emails, etc. And thank you all. And that is it. A little bit earlier, we'll give you 25 minutes of your time back. Thank you.